broadly can be made in 4 stages. Hyperacute, wherein there is stabilization within first 24 hours. Acute, that's where there's opening up of the neuroprotective window period or the neuroplasticity. And the most important has been a subacute between 3 days to 3 months, where the most of the neurological function occurs. Chronic, wherein there's a slow gain and happens more with more kind of a repetitive and high intensity rehabilitations. What is recommended at this point of time in a hyperacute and acute phase within the first 72 hours is a positioning protocol. You change the position every 2 hours, supine positioning, side lying, prone positioning, long sitting, standing with or without support, and modify postural drainage to aid the secretion removal. In a subacute of in 3 days to 3 weeks, task-specific training using walking for walking or hand use, constraint-induced therapy, speech and cognitive rehab, balance and coordination works. They work the best to have the best of the outcomes. Between 3 days to 3 months, gait training, maybe with advanced robotics or VR guided things, so fine motor recovery and different mechanisms for radial independence will be useful. With this, the lot of studies have shown that in early kind of a rehab has found to be very activation has been found to be very beneficial. In EVER trial has been seen. In EVER trial, they tried to rehabilitate the patient within 24 hours, which is a multicentric randomized control study from in international stroke centers. Therein they compared within high intensity rehab starting within the 24 hours compared with the usual care, the low intensity and delayed mobilization. They did not found any kind of a great benefit with the procedure. In fact, the outcomes are a little bit unfavorable in acute thing, and the possible explanation could be in this is been a little understanding of other factors associated with stabilization of the hemodynamic stability, ICP stability, or excessive mobility can reduce, in fact, interfere with cerebral perfusion, and metabolic demands which have been increased can exceed the recovery capacity. So what is now recommended is been like a controlled mobilization after stabilization is beneficial. So this is what the EVERT's trial study, they showed a slightly lower kind of outcomes in very early mobilization. However, this is a very, very heterogeneous group combining both ischemic stroke and as well as hemorrhagic stroke, and proper randomization of the protocols has been not been done. So with this interest, there are several studies which have been started. So this is a one large meta-analysis of over 1900 patients with 16 studies comparing a rehab within 2 weeks and active rehab after 2 weeks. They found that people who had a rehab within 2 weeks have an excellent improvement in the self-care ability, daily activities, neurological function, and a statistically significant improvement of NIHS scores and modified Bethel index have been noted. So with this, there have been few studies which have started again with within 24 hours or delayed between 4 days. In one study, there are 4 groups of RCT of a 340 MCA therapeutic infarct patients, wherein early or a delayed, that means delayed is more than 4 days, with the proprioception, neuromuscular facilitation, and the cognitive therapy exercise has been tried. Of these, people who had an early rehab, they found to have a better outcomes in the Bartlett index and 6 minutes walking distance. Similarly, high intensity compared to normal physical therapy, in a large RCT of more than 1700 patients, they found that high intensity group have found a higher favorable outcome with a modified Rankin score of less than 2, which is statistically significant. So another large study with systemic review of comparing between rehab after 24 hours, after 5 years, 7 studies. After the 7 studies, 2 studies have shown that early mobilization greatly improves the functional capacity in these patients. However, early rehab for kind of a speech therapy has not found to be very beneficial in a large study called a WERT study, and wherein outcomes are measured at 12 weeks. Similarly, high frequency and low frequency repetitive transcranial magnetic stimulation has been done, which has been where the outcomes have been studied with fMRI at 3 months. They have found that high frequency or low frequency transcranial magnetic stimulation greatly improves the motor outcomes. But few caveats you have to think about. Sleep, pure sleep can reduce your neuronal plasticity, so is the pain and seizures. So you have to optimize this condition. So I end up that individualized task-specific high-intensity training rehab protocols drives the best outcome. Start rehab at the earliest if patient is stable. Brain is most plastic within the first 72 hours. You have the best biological recovery window. Early rehab is not just optimal, it is not optional. It changes the long-term outcomes. So use it early or lose it permanently. So early rehab is a game changer. Time is brain, time is function. We as surgeons save the neurons, and early rehab restores the networks. Thank you.
Thank you, Dr. Raju. Are there any questions? I think we can take one or two questions if there are any. If there are none, then we will go to the next talk by Dr. Naveen Mehrotra on when to initiate rehab interventions.
Respected Chairperson Dr. Sandeep, distinguished neurosurgeons like Dr. Manas, Dr. Raju, and Dr. Kiran, and good morning to everyone. I think we all have, by the two talks, it is clear that neuro rehab is an integral part of the treatment. And one thing we also accept that it is the equally neglected part of the treatment also. So I think I congratulate the Suprata's team, Dr. Vijay and everybody, for coming up with a topic which is as important as treatment. So I think we'll start with the presentation. So I think Dr. Raju has talked about the neuroplasticity. So my talk will be when to start the rehabilitation, what are the parameters by which or when they are there, we should start the rehab. Folder में नहीं है, इसमें direct. We'll wait. Let the other person. Let other person start and then we can go ahead. Yeah, I think, sir, I think somebody else. कनेक्टर मेरे पास है ये वाला आ जाता.
Ladies and gentlemen, as we know that we are living in the world of technology, and there can be glitches anytime. So this is just one of those instances. I request you all to please maintain the decorum of the room while you are talking. Yes, you can also talk about the topics that are coming forward. Any questions, please write down. Maybe towards the end, we can take 1 or 2 questions as well.
Yeah.
As our moderator right there is also taking the care of the same.
I think it's all settled now.
Fantastic. Over to you, sir.
Thank you. I think the presentation will be based on this is the right layout. That what are the concepts of neurological triggers, which means that what the signals that makes the patient is ready for rehab. The neuroplasticity window, I think Dr. Raju has talked very well about that. And what are the general criteria for initiation, and especially for stroke, traumatic brain injury, and spinal cord injury, and when we should not do rehab. I think in this era of shortened focused attention, this presentation will have 3 things. The important points will be either underlined, the very important points will be red in color, and the take-home messages will be in blue color. So if anybody in between misses this, I think there are a few slides you can take along. So all I think we have agreed that neurological rehabilitation is a crucial component in the management of patients. What has, I think it has again gone. The color changes there. What to do now? Copy color pen drive now. In the meantime, somebody else can speak now. Yeah, leave her hand up. Yeah.
So while we are loading up his talk, we can go to the next talk by Dr. Manas.
Shall I remove? Yeah, remove that.
It's working. Yeah. Good morning, and I'd like to thank Dr. Vijay for insisting on that come and present. When he was calling to present, I was very hesitant. I said, means am I the only neurosurgeon feeding physiotherapy centers? And so because he did not give me the program till 2 days ago, then I was very happy that I have friends Sandeep, Kiran, and Raju, and Naveen. And but then his aim is to impress on us that acute rehab plays a role. But we have realized that more than I think you people have done, that acute rehab has made a significant change in the patient outcome. It's not only, as Dr. Kiran was explaining, that it makes emotionally they feel confident. There is a hope that they should go for surgery, and that hope also keeps driving them to go for surgery, go through treatment, and then have a good outcome. And even changing the emotion of the patient changes the biological activity, as Dr. Raju explained, the pathogenesis. It changes in the neurons. There's a genetic change. There is a neurodopamine also. The receptors production changes. The apoptosis comes down, and that is what. Emotional support changes biologically, helps. It's like an innate immunity. It helps in the recovery, and what we use in physiotherapy is just enhance that. And there are many modalities of doing that in addition to doing rehab. and use different instruments. I'll be discussing not on again the theory of rehab, but I'll tell the experience of acute rehab in our hospital in the past 1 year. I'll be presenting the work done by Dr. Ajay, our physiotherapy head, who does magnetic stimulation for the spinal cord injury patient, and Dr. Siddharth, who does magnetic stimulation for the brain tumor patient. And this is the work for the past 1 year they have been doing. I'll be presenting few of the examples of the cases which I have done. And the theory behind this stimulation already Dr. Raju has already explained. And this is the whole physiotherapy team who are very active. Without that, we would not have achieved what we have achieved with our patients, the results what we have achieved. Now this is the example of the acute rehab. We start in the ICU itself, and we have rehab specialists who are posted 24 hours in round the clock, 12 hour or 8 hourly, so that patients get a rehab, not that in the working hour between 10 to 4, but it's like 24 hours, because that is what we realize can reduce the complications of DVT or bed sore, chest infection. It's not just 8 to 4 activity, it's a 24 hours work. And this is a case of a frontal lobe lesion. Patient had hemiplegia. And this is the patient at follow-up. Immediate post-op he had weakness, and this is one at follow-up at home. So this is what is the result if we work all together. And this was done with the magnetic stimulation. We start magnetic stimulation immediately 24 hours later after the surgery, and what we have seen is the results what I'll tell in the later slides. And this is one of the result. Now this is another case, again 30-year-old, because many elopement area lesions come to us, and this patient had immediately had hemiplegia, and then she recovered. Now all of us know that the anatomy. Normally, all these days we used to only stimulate peripheral nerves or the axons in weakness, but then stimulating the neurons and the axons makes a lot of difference. So here in magnetic stimulation, you work on the neurons, and in peripheral stimulation, we work on the axons, and the pathophysiology is totally different when we do an axon only and neuron only. Normally, the activity, the response is better if you do targeted stimulation. Like if you stimulate the motor cortex, the response is better than just stimulating any area of the brain. Now, to identify the motor cortex, the central area, we use navigation in the theater. But then in the OP setup, in the rehab setup, it's not easy to use a navigation, fix the patient on a frame and all those. So how do you do with a pinless navigation? That is what we are working with a company from Korea and from HCAH, where you can localize the motor cortex, localize the tumor with just an iPad. So this is how it is done. This is a pre-op patient, where with the iPad you do a scanning of the patient, 360-degree scanning of the patient. And all this, the anatomy of the face, nose, eyes is integrated with the patient scan. And once that is done, you can mark the blood vessels, you can mark the tumor on the patient. This is I'm just showing in the pre-op phase so that it is easier for you to understand. The blue area is the tumor, and these are the the veins, transverse sinus, superficial sinus. So you can mark on the patient where is the tumor, and you can mark the motor cortex, and then plan your stimulation, cortical stimulation, so that the effectiveness is better. And this also helps us to plan surgery, to make a flap. Like this is pre-operatively patient on bedside, we make a flap, and then patient goes to theater. So we don't have to use navigation, so it reduces the time taken during surgery. And the same thing can be used in a rehab. This is a post-op case. So this patient in the rehab, it helps the physiotherapist to identify the location where he has to stimulate, because you can see here the MRI and the CT scan can be integrated on that, and you can mark the tumor, mark the motor cortex. So here the motor cortex is marked, and then magnetic stimulation can be done. specifically targeting the motor cortex only. So here the motor cortex is identified by the specific anatomy like the hand knob sign, and then you can place the stimulator in the targeted area. And this is what can see that when you stimulate, and this is on the second post-op day, one can see the stimulation. Patient who are voluntary was not able to do, but stimulation he can move the fingers. And if finger moves, the skill movement improves, they are the best patients. You can assure them that they will recover. This is how, this is Dr. Siddharth working with the patients of planning the stimulation of how to do accurate targeted stimulation. Now they have, we have done 50 patients and we have got quite good results. I don't want to go to all the theory of that. And now this is the pre-stimulation rehab, and this is at the post. This patient had again right side weakness post-op, and this is the result at the end of 1 month. So immediate post-op was having this movement, but this is what we could achieve at the end of 1 month. Now it not only works in only the limbs, but it also works in cranial nerves. We have done for facial nerve, we have done for ocular nerve. Oculomotor nerve, you can see the third nerve palsy, how it recovers with stimulation of the motor cortex. And so this we use for gliomas, we use for skull-based tumors, we use for patients who post-traumatic who have cranial nerve palsies also. This is again another case of example pre and post. This is immediate, the first is the immediate post, and then at recovery in the hospital and at the suture removal time. So this is a facial nerve palsy, again with transcortical stimulation, you can see here the recovery. So of the 50 cases we have done intracranial tumor, we had the results, that they had a significant recovery earlier than just the standard physiotherapy. And this is the work of spinal cord injury done by Ajay. In spinal cord injury, especially whiplash injuries, where we have to just send for acute rehab, we have started doing magnetic stimulation for whiplash injuries, which have people and who had instability, we have sent them out of fixation. Whiplash we have started immediately, and which were managed conservatively without surgery, and with this case after surgery, and this is what the recovery we get. And we have, if you see here, the control which earlier we were not doing, and now with magnetic stimulation, there's a significant change in the recovery and faster recovery. So the advantage of doing neuronal stimulation versus axonal stimulation is significantly different. And this is the possible mechanisms of stimulation, which Dr. Raju has already explained, that it's proved in rats, they have shown that when you stimulate, they have change in the neurotransmitters, they have change in the genetic apparatus of the neurons, there's a change in the cell death and neuritic regeneration. And all this is proved in dendritic growth spotting and neurotropic factors, they are proved in animals and in volunteers in clinically. Now, these are the few papers where early stimulation with magnetic stimulation, they also have shown that this came in 2025, that they have found, like us, that they have found better results with acute stimulation with either low frequency magnetic stimulation. In conclusion, the future lies at the intersection of surgical precision, rehabilitation science, and using AI and virtual AI and different technologies for the benefit of patient. Thank you for your attention.
Yeah, so thank you, Manas, for a very nice talk. Do you have any questions? So are you doing magnetic stimulation in all the patients or only those patients who have post-op deficits?
Only they have a deficit, not all.
Okay.
Yeah.
But then if any patient has deficit, then you do it on all the patients?
Yes, if they have seizures, we don't do it. And if they have cardiac problems, we don't do it. Yeah.
Okay.
Yes.
Yeah,
Mo-
sure.
Good morning, sir. I'm Dr. Chandrakant. It's a privilege to share this stage with you. So my question is, sir, there is a gray zone, patient safety and early rehabilitation. So is there any criteria that we meet, sir, for patient shifting to rehab or in a rehab facility from an ICU to hospital? Is there any discharge criteria or admission criteria that we need to look at?
That depends on it's a spine injury or a cranial surgery. So in a spine injury, they can be shifted in 2 days, but then the rehab setup should have the magnetic stimulation, and they should believe also that it works. So that is why we keep the patient at least for 7 days, so that it is done along with us. Because when we started, I think Dr. Kaul, who is in stroke, he didn't believe that acute works. So he was very critical of this thing, starting this protocol. But then now he's convinced, and he has started for his stroke patients. So it's not easy when you start a concept that it will be followed in a new setup. So once it's established, you can always, even if you transfer to a new setup, it will be done. Yeah. At our own hospital, they didn't believe us. So.
Thank you, sir.
Yeah, chronic, the literature says even after 3 months, it works, and means it is proved that it has helped in Alzheimer's and after many years. So it in chronic cases, with Dr. Kaul will speak that because it started with chronic cases, that is why they had an objection for the acute setup. But if you look at the pathophysiology, what Dr. Raju explained about the golden time, that one should use that pathophysiology for our benefit. So it will work for both acute and chronic, but it will work better in acute, as Raju showed the graph, is better in acute than the chronic. But then it is like in stroke, people do vagal nerve stimulation also, and they have proved that it works. So if you believe vagal nerve stimulation, you should believe magnetic stimulation also. Yeah, as I told, stimulation can precipitate seizures. So if the patient has has a propensity for seizures, we do not do, and cardiac diseases also we do not do. Yeah.
I think the current level of evidence for RTMS and stroke is only for subacute stage and for hand function, level 1. Rest all is not level 1. Level 1 is only for MCA stroke, upper limb, subacute, up to 3 months. Rest all is level 3 or level 4 evidence.
True, that is. But what is the difference is, what they have seen is at the long-term outcome is the similar. But when you do an acute, you can just prepone the recovery by 1-2 months. And that is a significant lifestyle change for the patient. A patient recovering at 3 or 4 months and recovering at 1 month makes a difference for the patient and family. At the end of 3 months or 4 months, both have equal with or without.
Okay. So are we ready with the next talk by Dr. Mehrotra?
I'm sorry for the glitch. I think it's just the reverse order. So now we have the physiotherapy. I will tell you what are the indications when we should start the physiotherapy for that. Next slide. Can you start the presentation? So I have told about the next, please. So this is what will be the layout about the triggers, the neuroplasticity which has been discussed, and then the criteria for starting the. Okay, I think we'll go back. So the trigger points, the ICU based, and then the when we should not be doing it. So as we all agree that neurological rehabilitation is a crucial part of the treatment of patients with stroke, traumatic brain injury, and spinal cord injury, and it should be started as early as possible, as has been told with the previous speakers. So I think in one single line we can say that in neuro rehabilitation, The timing is therapy, and various trials and studies have proved that the earlier we start, the better outcomes we get. So how do we identify the correct moment to restart the rehabilitation? So that is what is the neurological triggers. So that is, the triggers means the clinical milestones which signal the readiness of the patient for rehab. So they are all neurological. So if there is no worsening of the deficits, there is improving general GCS, and there is emergence of the meaningful responses. That's a good indicator that we can go ahead with rehab. The physiological stability, meaning hemodynamic stability, SpO2, the ICP is under control. And another important is the functional readiness. That is, the patient is able to tolerate the positioning and simple movements even on bed. So that normally what has been the traditional thing, we will wait for another 1 week or 10 days to start the rehab. It's not that. So it's not time based. So the patient's condition, not the calendar, decides when the rehab begins. So if the patient is stable and can tolerate, we can start as early as possible. The next, I think neuroplasticity has been beautifully discussed by Dr. Raju, but a few words about that. So after any neurological injury, the brain doesn't remain static. It enters a phase of active reorganization, and this reorganization is called as neuroplasticity. And this ability, I think, has been shown that it is not constant over a period of time. So it is in the early few periods, few days, and that is called the critical window, where the brain is more responsive to external stimuli and training. That means the physiotherapy, and the better we utilize it, the better we get the outcome. So I think the pathophysiology is very simple. It has been discussed. I'll just give a passing by. The surviving neurons start forming the new synaptic connections, and there's axonal sprouting with cortical mapping. And undamaged areas of the brain, they take over the functions which are lost. So rehabilitation becomes crucial. So it's the right stimulation which is done at the right time leads to strengthening the useful neural pathways. It promotes the functional recovery and improves the long-term outcomes. And if we do not do it, then brain may develop inefficient maladaptive pathways, which leads to poor motor patterns or incomplete recovery. So rehabilitation is how we guide the neuroplasticity towards recovery rather than a disability. So what are the criteria for initiation? As I told, hemodynamic stability, the vital stable being BP and HR, the heart rate. The neurological stability, where there is no active deterioration and there is ICP is under control. The adequate respiration is there, and the level of consciousness, at least some level of arousability should be there, and the patient should be able to tolerate activity. So it should be started safely, but not prematurely. So right timing in rehabilitation is called as safety plus opportunity to use it. So now my topic will be on typically on the neuro rehab. I think stroke is what has been the most studied area. So it should be started early, but only when specific clinical trigger points are met, which should initiate within 24 to 48 hours, and it should be graded. It start with positioning and passive movements, and then progress to sitting, standing, and eventually walking. So evidence suggests, I think the AWARD trial what Dr. Raju was telling suggested that short, frequent, low-intensity sessions early after stroke are more beneficial than prolonged and early aggressive therapy. So in stroke, the goal is early mobilization, which is not guided, but guided by stability, not just an urgency alone to start it at the earliest. And traumatic brain injury, the early rehab with ongoing cerebral protection is the key message, and it should be careful, parameter-based approach. Even in deeply unconscious traumatic brain patients will benefit from early passive and sensory stimulation, which may aid recovery of arousal pathways. So the three triggers are, and then the ICP should be under control and should be less than 20 millimeters of mercury and requiring no aggressive interventions for control of it, because movements can further raise ICP. There should be adequate blood flow to the brain, that is the cerebral perfusion pressure should be maintained, it should be between 60 to 70. Hemodynamic stability and neurological recovery, I've already spoken about. So stepwise, if the patient is in coma stage, we can do passive range of motions. If there is low responsiveness, sensory stimulation, which can be auditory, tactile or visual. Emerging consciousness, it can be active based movements. And I think there is again some problem with that. So in traumatic brain injury, the rehabilitation should follow the brain's recovery, not precede it. And the third component is spinal cord injury. It should begin very early. It should start even in the ICU itself. The concern should be the mechanical instability of the spine and the prevention of secondary complications. Even within the first 24 hours, simple measures like positioning and passive movements can significantly reduce long-term disability. So the key triggers are the patient's spinal stabilized, or we have got adequately immobilized either by a brace or a traction. The rehab should not worsen the injury. The patient should be hemodynamically stable and should not be neurogenic shock, which we can see in patients with cervical and high thoracic injuries. And the respiratory stability should be there, which is usually compromised in patients with high cervical injuries. So the why the early rehab is crucial, because the positioning prevents the bed sores, the frequent timing presents the pressure relief, and the passive range of movements prevents joint stiffness, and respiratory therapy prevents pneumonia. So in spinal cord injury, the rehabilitation starts early, not to restore function, but to preserve the body for future recovery. So this is a chart which compares the stroke, traumatic brain injury, and the spinal cord injury, in which the timing is like early for stroke and very early in spinal cord injury. The triggers are ICP should be controlled, including the cerebral perfusion pressure and traumatic brain injury, with the ICP less than 20, and it should always be stepwise. And then the core principle is, in stroke, it should be early but cautious mobilization. In traumatic brain injury, it should be the brain should directly recover, stability before stimulation. And the core principle for spinal cord injury is protection before prevention, protection plus prevention from day one. So in simple words, in stroke, focus on early mobilization. In traumatic brain injury, brain stability before stimulation. And in spinal cord injury, early prevention while protecting the spine. So while the principles of early rehabilitation involve or is universal, but trigger for initiation usually disease specific. It's not one principle that fits all, like stroke, TBI, and spinal cord injury. So ICU based rehabilitation is very important, because traditionally we say that rehabilitation should start after ICU. No, it should start within the ICU itself. So ICU is not a place to wait, it's a place to begin recovery. So again, the key respiratory factors are FiO2 typically should be less than or equal to 60, hemodynamic instability with neurological recovery. And why it is important? Because it prevents ICU acquired weakness, it reduces the ventilator dependence, and the decreased length of stay in the ICU is there, with improving long-term functional outcomes. So early mobilization in ICU transforms passive care into active recovery. So when we should not do physiotherapy, if there is a raised ICP and requires infusion, then we should avoid it. If there is hemodynamic instability with requirement for inotropes, if there is a persistent or active neurological deterioration, if there is an uncontrolled epilepsy or seizures, if there is severe hypoxia or unstable and unsecured spine or a deep sedation with non-responsiveness, these are the red flags, and we should try to avoid physiotherapy in such conditions. So in neuro rehabilitation, knowing when to wait is as important as knowing when to start. So it's a multidisciplinary approach, as has been spoken by all my previous speakers. So it is not the responsibility of a single specialty, it is the coordinated effort of a multidisciplinary team where each member contributes at different stages of recovery. So the success is not what we do, but how well we do it together. I think the team, the neurosurgeon, neurologist, all, they are responsible for the initial part of the treatment. The physiotherapist is required for the muscle, for the joints, occupational therapist for the activities of daily living, speech and language therapist for speech and swallowing. The nursing team is the backbone for any rehab hospital, and the most neglected is a rehabilitative physician. I think their role is very important and is more underrated. So rehabilitation is a team effort. Recovery happens when expertise works together. So to conclude, it's just neuro rehabilitation is not just an adjunct to treatment, it's an integral part of recovery. It should be early but guided. It is individualized, trigger-based initiation rather than a fixed timeline that will start after 1 week or 10 days. And goal is to survive, not to survive the neurological recovery, but to recover function and independence. So I will close my talk with one sentence. The right intervention at the right time in the right patient is the essence of effective rehabilitation. Thank you. Thank you for a patient hearing.
Thank you, Dr. Naveen, for an exciting talk. Any questions? I would like to make a comment that for us, rehab is very important. And as a routine, we don't even send a referral to a physiotherapist. They have a mandate to start physiotherapy in all the patients within few hours of surgery. So like the OT list is sent to all the departments. Similarly, it goes to PMR department also. So they know what patients are going to be operated. And as soon as the surgery is done, they come and automatically take care of the patients. So it is very important. And even when I take my morning rounds, the physiotherapist who is assigned to our department is on the rounds with me, so that there is no communication gap, and then they know the requirement of the patient there and then. So rehab is a very, very important part for the patient's recovery. Thank you.
Thank you very much to the prominent speakers. You've all added your bit of it, and thank you very much, sir, for also adding your valuable points and summing it up. And now we would like to call on stage Dr. Gaurav to please join me, as we would like to make sure that we thank them. I would like definitely your presence. Yes, I would like to also invite firstly Dr. Sandeep Vaishya and Mr. Ankit Goel to join me on stage. We will take this moment of pride to thank all our speakers who are here. So can I please call Dr. Kiran M to step forward? This is just a good gesture from our side to thank you for your valuable time and insights. So we would like to take a moment to present the memento. Can we have the memento on stage, please? Ladies and gentlemen, the silence is absolutely dangerous. So we would like you to please stand at the center of the stage so that we can frame this beautiful moment together in a picture, please. Yes, we can put our hands together now. And now can I please request Dr. BSV Raju to please come forward. While Dr. Kiran talked about the transformation videos and approach, Dr. BSV Raju stressed on the importance of rehabilitation and the phases of recovery therapy, as surgery saves neurons, early rehab restores the network. Thank you, Dr. Raju. And now I request Dr. Naveen Mehrotra to please join us. Dr. Naveen mentioned very well about the importance of physiotherapy, and he stressed upon a point that success is how we as a team do things together. And can I now please invite Dr. Manas to join us, please. Very interesting pictorial presentations on screen. Dr. Manas shared with us the brain tumor recovery cases. Thank you, sir. And now to our fantastic chairperson and moderator, Dr. Sandeep Vaishya. We would like to thank you for joining us. I request Mr. Ankit Goel as well as Dr. Gaurav to please present the memento and do the honors. Let's hear it loud and clear, ladies and gentlemen. And can we have one group picture of all the panelists as well as the moderator and our delegates on stage, please? The discussion reminded us that the rehabilitation is not just an afterthought to treatment. It is an essential continuation of care that restores life beyond survival. Thank you, dear gentlemen, for joining us today. And now with this, we will be taking you to the session 2. And now as we move to the session 2, managing neurological outcomes expectations from prognosis to prevention and care continuum. I would like to invite on stage our keynote speakers, please. Can I please invite on stage? All right, while we're setting this stage up, we all know that we are into neurocare, and we all know that we talk about a lot of coordination that should happen. So everyone who can see me, can you raise your right hand, please? See, who are not raising your right hand, I imagine body is present, mind is somewhere else, or you're looking in your mobile phones. So raise your hand if you can see me, right hand. Thank you for that. Raise your left hand if you can hear me. So I didn't say to put your right hand down, right? So raise both your hands and say hi. Fantastic. Now let me see your good coordination. You raise your right hand, you raise your left hand, and without looking at me very seriously, don't scare me. I want you to draw a circle with your right hand. Everyone, can you draw a circle with the right hand? Someone's circle is here, like a 0. Someone's circle is very big, like an O. Can you draw a big O? Fantastic. Now with your left hand, can you draw a square? Don't make it an O. It's a 4-corner square. It can start from left or you can start from right. Yes. Why did you stop? Come on, go for it. Let the hand practice it for you. Very good. And now stop. Circle. Very good. Square. And now, can we do both? Try. Who is able to do it? I can see that wonderful smile on everybody's faces, but then I'm not able to see you trying it. Can we try table 1, sitting over here? Yes? Circle with your right hand, sir, and the square with your left. एक के बाद एक नहीं करना है, not one after the other. It has to be together. Can we do that? Ma'am, yourself, yes. Can we try? Both are circles. Very good. So when we talk about coordination, neurology, and every aspect that we are here for today, this is just one small workout as well as a filler that I thought of doing it with all of you. I hope you liked it. Put your hands together for yourselves for trying it out like good students in a class. And now I take you to the next session and I invite on stage our speakers. Firstly, can I please invite Dr. Praveen Gupta to join us, Chairman, Marengo Asia International Institute of Neuro and Spine and Marengo Asia Hospitals, Gurugram, please. Warm welcome to you, gentlemen. And I would like to invite our speakers as well. Dr. Subhash Kaul, please join us on stage. Senior Consultant, Neurology, KIMS, Hyderabad. Followed by Dr. Varun Rehani, Senior Consultant, Neurologist, BLK Max Hospitals, Delhi. And can I call Dr. Amit Haldar, Director of Neurology, Fortis Anantapur, Kolkata. Am I marking the presence of Dr. Varun as well? Fantastic. And now I would like to invite Dr. Gaurav to please join us on stage to introduce our keynote speaker, Dr. Praveen Gupta. Let's hear it for all the speakers, ladies and gentlemen.
But it's so heartening to hear from such renowned, eminent speakers what you actually want all your people to know. Every day, in and out, Dr. Abhishek will vouch with me, this is what we go and tell, early rehabilitation is definitely going to improve outcomes. So the next session of the day, I have with me a very, very eminent senior, Dr. Praveen Gupta. He's the chairman of Marengo Asia International Institute of Neurosciences, again an AIMS alumni. He's the founder of the first stroke center in Gurugram, performed the first solo mechanical thrombolysis in the region, led the first deep brain stimulation procedures in Gurgaon, and conducted the first epileptic DBS surgery in Asia. His areas of interest are stroke and vascular neurology, epilepsy and seizure management, movement disorders and Parkinson's, headache and migraine management, and multiple sclerosis, peripheral neuropathy, neurodegenerative disease. I welcome Dr. Praveen Gupta, the keynote speaker for this session.
Thank you, Dr. Gaurav, for such a generous introduction and having us, all of us here. Thank you, everyone, for. My presentation is about rewiring recovery, advanced neuroscience restoration. So we move away from the concept of physiotherapy to the concept of neuro rehab. Simple physiotherapy is like painting. Neuro rehab is like an art. Let's move one step further to neuro restoration, and that is what we will speak about in the next 15 minutes. So this is a post from coma to consciousness. So from politics, film stars to sports, even good recovery, good healthcare is also newsworthy. So presenting, so you see this MRI where you see significant damages all over the brainstem, the posterior cortex, and when you see the history of this patient, you realize this is a 45-year-old male, young patient with posterior circulation stroke, deeply comatose, GCS of 3, pupils fixed and dilated, transferred to us in deep comatose stage, life hanging by preserved respiration, hyperthermic, fluctuating BP. End of life? Not really. Why? Because neurons initiate signals. If you can enhance the neural activity, increase synaptic transmission, and enhance the connectome and make these neurons talk to each other, maybe you can create recovery, because for that, because stroke and traumatic brain injury are one-time events. Post that, there is increase in edema, inflammation, worsening of symptoms and signs for first 7 days. Tissue starts to heal after 7 days, and it takes about 3 weeks for cells to recover. From 3 weeks to 3 months, beyond neurons, the rewiring and reconnection takes place, and for a neural restoration expert, this is the window of opportunity. And this is not what we just say. This is borne out in research studies by heat map studies, where initially after a stroke, everything is blue, dumb and dull. But as time passes, as the heat map shows, the warm colors initiate, the brain has extraordinary recovery to rehabilitate itself and recover with the neuroplasticity, which is just not a theory, but it is the key biological reality. And as time passes over 12 months, everything becomes bright and beautiful, with rewiring of neurons talking to each other, initiating new routes for recovery. And that is what we believe in, and that is what rehab has to center itself on, the philosophy of neuroplasticity. And why everything is not lost? Same patient, same MRI, you see here, this is the damaged area, the brainstem, but on the top, the whole brain is preserved. We should not be held back by what is lost, but we should be focused on what is saved, because that is the beacon of hope that will drive recovery in these patients. We should sincerely move away from just treating the disease. We should strive to restore the human function, because survival alone is no longer a success. Neuroscience and neurorehabilitation must move beyond stabilization. The next frontier is to rewire, to restore for human bodies to rework and rehabilitate into normal life. So it starts with neurocritical care, acute care, signs of stroke where time is brain, advanced imaging, robotics, and we look at neuromodulation, AI-based recovery predictions. We are now looking at future for brain-computer interface, regenerative neuroscience, and then finally, precision neurorehab. And it makes a huge difference. The data tells us that this golden window, early versus delayed neurointervention, actually enhances recovery by a whopping 40%. If you start the right treatments in the right time, 40% more people will be functionally able and be recovered into normal professional work. See this gentleman, 55-year-old, active male, history of recurrent strokes, came to our ER with aphasia and weakness for 30 minutes. On acetrom, cannot be thrombolized. Right hemiplegia with global aphasia. Cannot move the left side, cannot speak. You see this MRI, his main artery, the MCA is blocked. He's having a very early stroke. You see the blocked artery. You put in an aspiration catheter, take out the clot, the artery is flowing within next 1 hour, and that is the magic of early intervention. And this is just next day. Just 1 day, right intervention, right time. So we saw the key benefits of timely mechanical thrombectomy in acute stroke. We go to the next concept, the penumbra salvage. When there is a stroke, there is a core of tissue which is dead or dying, but there is a tissue around it which is called penumbra, which can be really salvaged. Let's see now. Yeah, it's moved. So here you see so this patient's MRI, the main artery there is blocked, the blood is not flowing. This is the small stroke, but this is the large penumbra here. And this is the difference, small stroke, large penumbra. Intervening time, the stroke remains small, the artery starts flowing, the penumbra is salvaged. You see, this penumbra is salvaged. The blood flow is there, the brain is green with the flow again. Another pointer. So this patient is recovered and is walking. So we move forward from acute interventions to advanced rehab, which includes robotics, virtual reality, VR therapies, transcranial magnetic stimulation. We have seen few cases before, and eventually neuromodulation, which will actually derive precise neurorehab techniques. So repetition creates rewiring, and that is the principle of rehab. Another pointer. And this concept is not just a concept. We can actually visualize it. With advanced MRI techniques, we could image the tracts or the highways of the brain by DTI, tractography. We could illuminate the brain connectomes by these connections which lead to functional recovery, where neurons are able to communicate with each other, establish connections, and derive function. And it actually needs to reroute the pathways. When something is blocked, you create a new highway, you create a new pathway. So rehab is designed to reroute and rewire the pathways so that we create new pathways inside the brain to drive functional recovery. Yeah. So, and between the neurons there are these transmitters which are acetylcholine for cognition, serotonin for mood, dopamine for movement, endorphins for pain relief, and growth factors for neuron repair and support. So these connections, these neurochemicals can help you derive the recovery. Okay, fine. So another day, another story. Another 50-year-old female comes with right frontal intracerebral hemorrhage, secondary to venous sinus thrombosis, comatose for 2 weeks, and in status epilepticus for next 1 week. Brain damaged by stroke, body ravaged by seizures, deeply comatose. All seems lost, or really. So this lady now, after a week, is gradually recovered. She's giving a speech from that aphasia in a conference. And that is why we launched the stroke helpline, so that stroke patients can actually become aware and take timely treatment. But this cannot be done alone. We need a whole integrated team, which is the Marengo Asia International Institute model. One patient, one team, which integrates neurosurgeons, neurophysicians, neuropsychologists, therapists, occupational therapists, nurses, language therapists, nutritionists, pain management specialists, to create a care continuum of flow, which includes assessment, planning, intervention, monitoring, and most importantly, support. This team is a team of people who come together like a football team to create beautiful outcomes, or more like a racing car team where man and machine become one to facilitate a brilliant outcome. And just to end it, from no hope to ISB Hyderabad, we are in Hyderabad today. The story of this girl brought to us in this comatose stage, moved, become well enough to study at ISB Hyderabad. Thank you very much. And all these stories remind us of only one thing. When you restore one human being from no hope to full recovery, you restore a family. You restore a person's belief in medical science. And for naysayers and people who have skeptics about the value of modern healthcare, you validate and vindicate modern healthcare. And more than above, you actually value the existence of your own education in your own self. Thank you very much for a patient listening.
Are there any questions for the doctor? If not, we will take it towards the end of the session, please. You can please note down the questions. And now I would like to call our next speaker. Dr. Subhash Khalsa, please join us. Senior Consultant Neurology, KIMS, Hyderabad. Let's put our hands together for the gentleman. You have to click it facing that side.
Good morning. Thanks, Suvitas, for giving me this opportunity. And it's nice to see on this Sunday morning the hall is full, many familiar faces. You see, stroke is a shattering experience for the patient, for the family, for the doctor. And after the intensive care and after that heat settles down, the patient or his family notices that he has a deficit. His foot is not moving. He cannot see, and he asks his neurologist. And it's at this time that we tell him, don't worry, with rehab everything will be all right. And his family finds out there are robotics and there is new techniques and all. But he again looks at his neurologist only, for his primary neurologist, for the advice that where should he go. Even after a patient goes for rehabilitation procedure, repeatedly his attendants come to the neurological OPD and tell him, you tell us the exercises. We'll show it to our physiotherapist. That is because of the trust. That is because at the time of the initial impact, they were with the primary neurologist. They look to the neurologist for understanding, hope, reassurance, and support. Now, it's very important that family counseling should be done in appropriate time, because after all, the patients and the attendants are not trained in neurology or rehab as we are. So we have to counsel them that there's something called severe disability, which we know MRS 4 to 5, which means these are the patients who are completely dependent. They cannot move. There's no flicker in them. And there are patients with milder disability, that is MRS 1 to 3. And the family and the attendants have to know it, that what is the baseline from where they are starting. And they can understand. We have to spend some time with them. Now, this is the example of a MRS 5. And we see these patients every day. This is on day 2 or day 3. These patients have severe cognitive and motor deficit. Many of them are ventilator, but eventually they are off the ventilator. And the family wants to know from the neurologist what is the progress. And these are the kinds of the patients where we can upfront tell the patient that he is very seriously ill, he is actually fighting for his life, but there is a good hope. And at this time, the main issue is not whether the patient will walk or not. This we have to tell the family, otherwise they will not understand. They will immediately think that patient walked, that stroke patient in a different patient hospital walked, why my patient is not walking? We have to tell him that your patient is different. For him, at this stage in time, the question is, will he live or not? He's off the ventilator, that is the success. The issues at this time is tracheostomy, PEG management, change in position, timely feeding, care of urine catheter. And this has to be made to be understood by the family. Now, little better than this situation is a patient who is conscious. He may be having a minimal cognitive or motor disability. Now, these patients have a relatively better outcome because they can even become independent also. And contrary to the intuition, these patients have a desire to live and the desire to love. So we should tell the family to use simple language, use gestures, avoid frequent correction of them, timely grooming and attention to cleanliness, swallowing, bowel and bladder care. And you know, these patients I have seen, they enjoy visit of the doctors. They enjoy the medical checkups. They look forward to the exercise time every day in the hospital or even in the rehab center. The wheelchair tours which you take him throughout the hospital or the rehab facility, you know, they look forward to that. And time spent by friends, relatives, phone calls are extremely welcome by them. And we have to understand this as doctors and counsel the family accordingly. Now, this is a low-hanging fruit, MRS 3 to 1. They will almost always become near normal, if not completely normal, because they need minimum support or no support. And they have got a mobility ladder, which you have been discussing. It's a step-by-step. First, encourage them to sit in the bed, then supported standing, then unsupported standing, then walking with aids, and then walking without aids. And this trajectory may take 1 week to 1 month or 3 months also. But these are the good patients. And the family has to know that. Now, home is always a good place for rehabilitation, not immediately, but maybe after 1 month or 2 months, because home is a place where the rehabilitation will continue throughout the life of the patient. Rehabilitation is not only for 1 day or 1 week, it's a lifetime event. And home is the best place, but it needs preparation by the family, by the caregiver, and there has to be a proper rehab person who will help them to set up the home in such a situation that is friendly to the stroke patient, you know, like the handlebars, like adequate lighting and all. And this was one of the trials which was done with the help of the University of Sydney many years ago, in which we participated, called ATTEND trial, in which the physiotherapy is given by the family members with the help of the rehab team. And now this is about 7 or 8 years down the line, and it has been found that almost 70% of these patients have as good outcome as the formal rehabilitation in the institutional setting. So family is a very important resource in our country which should be utilized in the chronic rehabilitation. And there are books, manuals for stroke care at home. You know, for patients, it's very important. They are worried by the edema feet on the involved side. They are worried about the hemisensory pain. They are worried about the frozen shoulder. Most of these things can be prevented. And when they occur, they can be taken care of by teaching the person how to sleep, what postures to adopt while sleeping, how to lie on the back, how to sit up in the back. A lot of manuals for that. And we have to tell the patient and the attendants avoid the non-use of the weak limb. Even if it's weak, he has to be encouraged to use that by lifting a mobile. Even if it is awkward, even if it's clumsy, it doesn't matter. Since morning we have been saying repetition, repetition. That's true. Whole practice is about the concept of repetition. Let him do it 100 times, 1,000 times. It will get better. And then there are anti-spasticity, anti-contractors, measures, stretching exercises. Backward walking has come in a big way. Encourage the patient to walk backward. Conscious and mindful gait training, where the patient is taught how he has to walk. You know, like they do cat walk. These patients also have to be taught mindfully how to walk, and it really works. As far as drugs, Botox and surgery, they should not be done immediately at the drop of the hat. Many times these surgeries and Botox may worsen the patient by taking away the tone, which may be necessary in a particular person. So they should be done only sparingly when required, and which can be decided by the rehab person or the neurologist. There are many mobility aids
aids now which are available easily on the Amazon. There are canes, walkers, wheelchairs. You all know in conferences we talk about them now. They are commercially available equipment, for your hand. Gloves are there now, and for lower limbs also. And the other thing is that sometimes, in our practice we see there are patients who have got a severely spastic limb. Even if you remove the tone, still it will not work. It doesn't matter. Patient still has the other limb. And we have to counsel him that you don't worry about the paralyzed limb. I often tell this. I have one of my cousins who lives in London. Her hand is totally spastic. She can't use it, but she doesn't hide it from anybody. In fact, she wears all her jewelry on the paralyzed side, and she does work with the other side. But for this, the patient has to be cognitively supported, and his enthusiasm has to be maintained. There are sexual issues, driving issues. These things are important. They give confidence to the patient. After all, life is not only about physiotherapy. It's about living the life. But for this, we have to give appropriate guidance to the patient. We have to outsource help. We have to take help from various specialists. And then there are pharmacotherapy. There's a huge pharmacotherapy which can be given. Modafinil has been shown to help in reducing fatigability, which is very common in these patients. All stroke patients take it from me are depressed. We don't have to do any test for depression. They all should be on mild antidepressants. Dextromethorphan should be given for mild pseudobulbar palsy. Donepezil helps in the memory issues. Tadalafil is for sexual issues. Erkelion is for the fatigability. And Optineuron is a general vitamin supplement with thiamine and riboflavin, which overall helps. So pharmacotherapy has a role in stroke rehabilitation. And most important thing is that a patient who once gets a stroke is 20 times higher risk than control to get another stroke. And second and third strokes are completely devastating. So therefore, we have to make sure that the patient is taking medicines for secondary stroke prevention. Is he taking the correct drugs? Are his sugars, BP, everything controlled or not? Many times they forget. Has his sleep apnea been treated? Half of them have sleep apnea, so they need the CPAP machines. And is he standing or walking enough, even if it is within a room? We have to check all this. The common pitfalls which happens in chronic stroke rehab is they do irregular exercise, they get lazy, and then they stop doing it. And sometimes overprotection by the mother, by the father, by children, they don't allow them to move much. That is another pitfall. And mental health is very important. Like psychosis, neurosis, depression, that also has to be treated. And then stopping after a plateau. So physiotherapy, like normal exercise, is not for 1 week, 1 month, or 1 year. It's a lifelong commitment. So in summary, neurologists, since they treat the strokes, they are central to the rehabilitation process, even though they are not rehabilitation people themselves. But they cannot get away from it. They have to be part of the team. The neurologist helps the patient to improve outcome by encouraging him to do exercise, giving him drugs and devices. He makes sure that the patient takes medicines to prevent recurrence. That is the whole aim of follow-up. You have to be like a teacher. When the patient comes, just check from him. Is he taking proper drug? Is he taking adequate drug? Is he not missing? And most important is that the neurologist, as a primary doctor, has to help the family to compare patient's condition with his baseline condition. If there's a patient with, limp and he has got a grade 3 power, he should not compare him with any other person. He should compare him how he was on the day of the stroke. And patient should serve his own control. That gives them a perspective, and they feel satisfied that they have made good progress. And by listening to the patient, the neurologist has to counsel the patient to get best out of the new normal. During the COVID time, we learned this new term called new normal. So in the rehabilitation patient also, we have to teach him, this is your new normal. This is not abnormal. Even if your right hand is weak, it is your new normal. And you have to make best out of it. And invariably they will. Thank you very much.
Thank you very much, Dr. Subhash. Indeed, a very passionate person on the subject too. So your vibes and your words were actually felt by all of us. Thank you so much. Let's have a round of applause once again for him. And now let me invite our next speaker. We have Dr. Varun Rihani, Senior Consultant Neurologist, BLK Hospitals, Max Hospitals, Delhi. Let's put our hands together for him.
Good afternoon, everyone. I would like to thank Dr. Gaurav for giving me this opportunity to speak at this platform. And by the time I got to know that I've got a topic on managing the emotional and informational gaps, a topic which I thought was very mature, a topic that was to be probably spoken by a mature neurologist, but I think it's a good challenge to speak about this topic. And the topic that being given to a man who are probably poor communicators, who mostly speak like, okay, chalta hai. So we're going to speak about this. So why communication matters? Communication is important in each and every aspect of life, not only while you are being a doctor, but obviously in life as well. So in special cases for us, when the patients are admitted with us, they are admitted and they are under fear, they are under anxiety of what is going to happen, what is the diagnosis, are we going to make it through, are we going to be disabled? So these are all the fears that the patients are under. And on the top of that, if there is communication failure or lag on it, it is going to worsen that distress and is going to amount for mistrust. So a structured communication, it helps to improve the satisfaction and it helps to provide us with the appropriate decision making so that the patient chooses the right decision. So not only we need to treat with patients with care, clinically, through medical care, surgical, rehab, the emotional care is also important regarding managing patients. Regarding for us as neurologists, what we mostly encounter in the ICU is the patients who are either paralyzed, they are comatose, they are unresponsive, and these have definitely happened over a few days, and it's a sudden emotional shock for the patient and for the attendants and the caregivers. This, on top of that, in the first few days, there is a prognostic uncertainty. We do not know how the patient is going to land up. Is he going to make it? Is he going to recover? Is he going to be out of the ventilator? And if the patient has got multidisciplinary requirement, be the other kidneys, liver involvement, you may see the other doctors seeing the patient and giving their own fragmentary messages. No, the liver is okay, the kidneys is okay. And this gives a wrong information or misinterpretation for the family or the caregivers. And many a times, some enthusiastic doctors are going to come and they're going to tell us, your patient has got NOS, a new onset refractory status epilepticus. Does it matter for the caregivers? Does it matter to the attendants? No, you need to put in forward simple medical terms so that they realize what it is. They should meet those expectations of how to get the idea of the prognosis of the patient. So what are the common emotional gaps which are happening when we are managing the patients? So if the patient or the caregivers, there's definitely this fear, anxiety of disability, of death, of what is going to happen. And if the patient has made through and tided over the crisis, is off the ventilator, but is now bedbound, the caregiver, they are under stress, they are helpless. How are they going to manage? And many a times with joint families, you will see multiple family members who are going to be there and they are going to be their own opinions. No, we should do this, we should do that. They're going to be obviously interfamilial conflicts. And in the end, it all amounts to anger, denial, frustration, mistrust, and guilt. So what are the common communication gaps that we are seeing when we are managing our patients? From our ends, probably it is the inconsistent or the lag in providing updates to the patient, to the family or the caregivers. We are not probably clarifying about the prognosis, or we are sometimes there is a false over-representation, or we are saying that no, the patient may be okay. The other thing that we see is commonly is the overuse of complex medical terms, which is not useful. And many a times, the family members, they are unsure whom to approach because we are always in a hurry. We are managing our OPDs, we are managing our IPDs, we are managing our families, we are managing the interdepartmental conflicts, the interdepartmental coordinator issues. All these things are being managed, and the families, they don't have anyone to speak to. And obviously, they should understand what is the goal of care. Are we going to make the patient back same as it is? Are we going to help him become better? or what are the expected outcomes, like Dr. Subhash Kaul said, about the disability, about the MRS. The other aspect of communication gap is the listening neglect. This is a neglect that we face. Families often feel that they are unheard. We are in a rush. We are just speaking to them on the corridors, informally, just telling them, this is the issue. Yeah, this is some kidneys issues are coming up. We're going to let you know further. The kidney doctors are going to see. So this is not the right way. If they're going to ask us further questions, then like if we are going to pester our father, they're going to dismiss us. We may also become and like that and show a dismissive attitude and throw away the attendance, which is again going to be not supporting the caregivers. They are not going to feel that trust. That's going to damage their trust. Yes, they are going to repeat many a times, Papa, theek ho jayenge. Is it going to be okay? And we have to calm them down. We have to make them realize we are doing our best. And this active listening, this is something that you have to learn. You just can't say that you're just listening and not responding to their questions, not responding to their emotions. This is you have to do and learn. So if you are not communicating properly, you're going to face the consequences. And what are the consequences? Obviously, there's going to be the conflict, not only between the family members, there's going to be the conflict between you and the family members, interfamilial as well as with you. And the family members are definitely going to end up with increased anxiety and depression. And obviously, they're going to give a piece of that to you. So you need to be communicating well with your patients. And if you have not communicated well, there may be poor treatment adherence. They may miss out. If it is acute kidney injury, they are feeling that your patient is going down, they may not choose to do dialysis, which may help him. Or if the patient is already bedbound and you should have counseled that you should not get your patient intubated, it is going to further add misery, and they have somehow, because of their emotional love, gone ahead with the intubation, it's probably going to just prolong the agony. The other issues, obviously, would be the burnout among the healthcare staff. You're going to see many a times your nurses, everybody is burnt out. So you need to mention to them, this is a patient of GBS. You need to monitor the single breath count at least for me. Monitor these basic things for me. If this is a patient with a SOL, monitor the pupils. This is very essential. Keep us posted. So these things have to be mentioned to the nursing staff so that the dip in the sensorium is picked early. So now coming to the how to manage all this. So to manage all this, we should have a structured family communication. And the principles of this is honesty. You put up with the right terms, tell them that whether you know whether the patient is going to improve or not, don't make any false promises. You should be consistent with your terms. You should be transparent, and you have to be empathetic. You cannot be just dismissive. Tell them, no, we don't know he's going to be good or not. You have to have a shared decision making. Don't put your own decisions on the family members. Tell them these are the options, these are the drugs, these are the things that we can do, rather than just put on them. Repetition and reinforcement, and obviously documenting what all you have communicated to them so that you can obviously save yourself for medical legal documents. So this structured communication model, I'm going to start with the first step. In this is the preparation. So you have to identify who are the key members, the key decision makers who are going to be taking part in this decision process of managing the patient's further care. You cannot do this on the corridors, so you have to find a dedicated time. You have to ensure a quiet and a private environment. You should be knowing the patient's updates, the vitals, the SpO2s, the mode of ventilation. You should be knowing all this. And you have, if it is a multidisciplinary team action, you should be involving the other doctors as well, be it the kidney specialist, critical care specialist, all of these should be involved. And I think one important aspect is also, please keep your phone switched off at that time. It doesn't look nice when you're talking to them, you're giving them the time and your phone is ringing again and you're just talking on the phone as well. So these things should be definitely avoided. The second step, once you have set up that meeting, is to assess the understanding. You should always ask them first, what have you understood about the patient's condition so far? After you have listened to that aspect, you try to correct the misconceptions that they have regarding he's going to be okay or whatever the misconceptions they have. After you have corrected, you should again ask, do you want to ask any further questions? You should identify They have some cultural aspects, some ethnic values that they want to do with the patients. And third aspect, which is very important, is to deliver your information clearly. You should be speaking with simple sentences, not just medical terms. It should be, if they're not able to understand through your language, you can probably use some diagrams, show them the MRI, or just make some diagrams so that it becomes easier for them. Don't give them piles of information. You can ask them, what information do you want to ask? Are you ready for the bad information if you want to hear? You can put up those questions in advance. You should elicit the goals and the family values. You should ask open-ended questions. Like if the patient is probably very terminal, you would ask to ask, was there any wish, any member that they wanted to meet, anything that you want to do, probably any tilak, any thread that you want to put. You have to understand these ethnic and cultural influences. They may have their demands, but you should always focus on the patient's perspective, make combined decisions, and check for the understanding and the decisions that they have made, and document. Summarize all these things, and ask if they have got any final questions. And in the end, it is always good to appreciate and respect the family, because it is a very difficult decision. It's a difficult topic to discuss and to talk on, and appreciate the family members that they are going through a tough time and you are respecting that decision. So we have had these various frameworks, like the nurse framework regarding talking about these end-of-life cares, in which you start with the name, the emotion, understanding the feeling, respecting the experiences, supporting the family, and exploring the concerns further. And the other is the spikes framework, which is the one which basically I have discussed, which is setting up the meeting, perceiving what they know, inviting them for how much information they would want to know, and then share your information, empathize with them, and finally summarize and document and get it signed. So there are certain times there are conflicts within the family members. There are different family members which process the information differently. You can conduct separate conversations. You can respect the hierarchy. You can realign goals repeatedly. And as a tiebreaker, as if it may happen, I always say, what would the patient would have liked at that moment? Communication during prognostic uncertainty is another issue, because we have to acknowledge this uncertainty very honestly. As I said, avoid false reassurance. And in the end, obviously, there's the role of multidisciplinary team, which everybody has mentioned. This emotional aspect is also a part of this multidisciplinary part. And in the end, I would also like to say that we should also address the caregiver issues, because these caregivers, especially of the females who are more commonly the caregivers, these are at significant risk of physical injury. They might be moving and turning their patients, they might be injuring themselves. It's a financial toll on them. They have lost the income, there's an added expenses, and because of these financial expenditures, the care may change from life-extending care to just comforting the patient. We need to address the caregivers' emotional and mental health issues. There's well-documented data. There's more anxiety, more depression, more risk of cancer, more early mortality in these patients who are more caregivers, who are spending at least 21 hours a week. So my take-home message is that this communication is a therapeutic intervention. Don't consider it loosely. Families, in the end, they remember how we spoke to them more than what we said to them. A structured communication, it reduces the emotional and informational gaps, and empathy and clarity improves the outcomes for patients, families, and clinicians. Thank you.
Thank you, Dr. Varun. And now to present the next topic of ensuring care continuum post-discharge, I invite Dr. Amit Haldar, Director of Neurology, Fortis Anandapur, Kolkata. Warm welcome, sir.
Good afternoon. At the outset, I would like to thank the organizers for inviting me to this recovery conference. And so far what I have heard is I've learned a lot, because these has stressed on topics which we rarely discuss. In neurology conferences, it's more about treatment, diagnostic tools, but ensuring recovery is a very important thing. And my previous speakers have already made my work easy. They have stressed on rehabilitation, the new tools, and the communication. So I will stress on another aspect of the treatment part, that is ensuring care continuum post-discharge in neurology. So what happens in our country is the patient is admitted in the hospital, you stabilize the patient, and then you discharge the patient. Half of them are lost to follow-up. You don't know what is happening with them. Or sometimes they come after months, and then you already see the patient has passed that golden period of 3 months and has developed deformity, where you don't know what to do next. And then they will come and say that, please fix up this patient. So in complex neurological patients, so weaning from mechanical ventilation during inpatient early neuro rehab is unsuccessful in almost 1/3 of the patients. This is important. So weaning may not be successful. In 46% of the patients who needed a tracheal cannula during the acute stage, the need persists post-discharge. So these are the problems, burning problems you have to handle. So 1/3 of the major neurological patients you may not be successful in weaning. And almost half of them whom you did endotracheal intubation or tracheostomy, then even at the time of discharge, you can't remove the tube. So these patients, once you discharge, but these patients cannot stay on in the hospital. So they either need a home-based care with specialized nursing, or they need a specialized residential group, where I think the transitional care facilities come into play. So who are these high-risk neurology patients? Large vessel stroke or large cerebral hemorrhages, you have already discussed, traumatic brain injury, spinal cord injury. I think that our neurosurgery colleagues face it daily. Neurodegenerative illness, someone with an Alzheimer's disease or advanced Parkinson's disease, they come in the hospital, you discharge them, but they are still dependent. They are not fully recovered because it's a degenerative disease. It will go downhill. You might have managed the acute complication. Second is status epilepticus patients. You may have controlled the seizures, but they still need care. And obviously, all medical patients who ultimately, during prolonged stay, with intubation, ventilation, antibiotics, steroids and others, they develop critical illness neuropathy. So the illness has decreased in extent and severity, but the patient is confined to bed. They are hardly able to swallow. So all these patients, when they come, you need to plan out how to continue the care beyond the hospital. You must remember that the neurology recovery continues for months and even up to years. And early rehabilitation actually predicts better functional recovery. So it's the first 3 months which is very important. And after 6 months, actually, the rate of recovery slows down. And continuity, so if you know exactly what is happening, even post-discharge, that improves adherence, safety, and also prevents secondary complications. Structured follow-up. I think our previous speaker also talked about structured communication. But follow-up also needs to be structured. It's not just the patient goes home and then comes back according to their will. That can prevent a lot of recurrences, complications, and also readmissions. So why do we need this care continuum? Because then we'll understand the importance of longitudinal neurological care. And in this talk, we'll review the evidence supporting integrated rehabilitation. And obviously, neurologists, physiatrists collaboration models are very important. For example, when I send a patient to healthcare at home, which is 2 kilometers from our hospital, I make it a point to communicate with Dr. Shashwato, and he also gives me a feedback. This communication is very important. They explore workflow strategies to reduce disability and readmissions. So what are the core principles of neuro rehab? First, as we have already discussed, it should be begun early. A multidisciplinary goal-directed care. It's not the neurologist and the neurosurgeon who is the boss. He may guide, But there is a team where we need the intensivist, the physiatrist from the beginning itself. Focus on functional outcomes. Functional outcome is very important. It's not that this blood parameter has improved or this thing has improved, whether the person is improving functionally. And obviously the follow-up needs to be coordinated. So if we need to coordinate, for example, if I'm putting the neurologist and neurosurgeon because the patient initially gets admitted under him. So the role of the neurologist is to define the diagnosis, lay down a treatment plan and prognosticate and treat according to the disease and try to prevent secondary complications. Now, here and obviously if the patient is critical, will be in the intensive care. The intensivist's role is to prevent ICU-acquired weakness, early mobilization. This is very important. And another important factor in the ICU, especially in neurology patients, is a patient with dementia suddenly goes into delirium. A post-op patient goes into delirium. So reducing delirium and sedation burden. So when the patient is excessively sedated because of restlessness, you don't know whether it is the disease which is causing the drowsiness or whether it is the medicines which are causing the drowsiness. And obviously when the patient is being transferred out of the ICU, you need a transitional planning. And also the intensivist needs to coordinate when the patient is being discharged. Physiatrists, again, the role of the physiatrist is important from the outset itself, because better planning will lead to better coordination. The physiotherapist, the occupational therapist, the speech and language therapist all have a role, and they can manage spasticity, mobility limitations. A person with a stroke, of post-discharge developing a foot drop, that's where you have to take care from the beginning itself. And you reintegrate this care into the community life. This is important. So the role of this care continuum is not just in the hospital, it's beyond the hospital where the patient gets integrated into the community. And what are the major barriers? Poor communication, as already has been stressed, and delayed referrals. So initial part you are worried about the critical care parameters and other things. After 1 week you involve the physiatrist. By that time the patient has developed a pressure sore. So lack of shared outcome metrics. So this is one thing which we can all try, that we can share the metrics. So the whole team knows what are the metrics we need to follow up. And another limitation is post-discharge tracking. I think it's maybe due to the lack of manpower, or it can be some other facilities. Because here, from the hospital when you go, you don't know what is happening to the patient. You need to know what is happening. At least first few months you need to know. And if the patient is going to the transitional care people also needs to communicate with the primary team. And from the transitional care, when the patient is going to the community, both the primary team and the transitional care team needs to inform what are the things they need to do. So evidence supporting the transitional care is continuity programs, reduce readmission. So from the hospital, the patient goes to the home, there the nurse doesn't turn up and the patient aspirates, comes back the next day into the hospital. This is where we need the continuity programs. And integrate rehabilitation, improves functional independence and Barthel scores. So these are two scores which are easy to do. Barthel score, actually, we have already heard about MRS, Modified Rankin Scale, but Barthel scores actually looks at the activities of daily living. So you look at the activities of daily living and early outpatient follow-up. Multidisciplinary models improves quality of life. And there should be an integration of ICU to community workflow. There are a lot of points here. What I want to stress upon is the structural rehabilitation demonstrates sustained long-term recovery. And discharge, coordination, and early review are the key drivers for this workflow. And the benefits will persist beyond the inpatient phase. What are the new things which have come up? So tele-rehabilitation and digital monitoring. Patient need not come immediately. So with the help of tele-rehab, you can try it in resource-limited settings or where the patient stays far off. Wearable devices can also help. And virtual multidisciplinary team meeting reviews maintains continuity. So all the team members need not be present at the same time at the same place. Teleneurology is very important in role to play in medication optimization also. the hospital team and the rehab team can interact and modify the course over tele-rehab. This was a trial done in Germany. So what they do, this is called OptiNev trial, optimization of post-hospital intensive care for neurology patients. So they formed regional follow-up teams consisting of doctors, nurses, therapists from three participating neuro rehab centers. And they accompanied the patients and provide the community service providers. So in the home, there's a local physician, there's nurse, there's therapist. So these specialized teams went to the community, and then they, with individualized, this is very important, in each case, individualized treatment plan is necessary. Recommendations over the course of 1 year post-discharge. And the ROFs provided individualized comprehensive neuro-rehab approach based on their experience, and evidence-based clinical pathway that has been developed for the same. So caregiver engagement is very important from the beginning, because unless the patient's relatives know what you are doing, it won't help. Caregiver education is important, family participation improves adherence, and psychological support reduces burnout. Outcome metrics, I think I have already discussed upon it. So you need these outcome metrics, then you can objectively measure where the patient is going. This I think we have already discussed. So practical hospital implementation model, create the neuro rehab pathways, mandate physiatry review before discharge. Before discharge, all patients need to have a physiatry review, and schedule follow-up before discharge, and develop shared electronic documentation. If the patient is going home, you share the electronic records to the general physician who will be treating at home. If the patient is going to a rehab facility, you need to share beforehand, because then the team handling the rehab knows where you are going, which patient is coming. And this structured care continuum, you can already see there is a difference. If it's integrated rehab, even at 1 month there is a difference, and this benefit is sustained for 12 months compared to standard follow-up. And again, readmission rates also reduce significantly. And what are the things that you should have on your checklist, each team? Neurology review, physiatry assessment, therapeutic goals documented, caregiver training to be done, and follow-up appointments booked. So these 5 points before discharge should be there. Then you know exactly that the care is being continued, and the quality indicators. You can yourself assess. This actually helps the treating physician to assess how good is this team was working. Future direction, obviously AI is coming up in big way, and rehabilitation will change. Wearable devices, predictive recovery modeling using algorithms, and home-based digital neuro rehab. These are the references which I have used. If someone is interested, can go through them. So thank you.
Thank you very much, sir. And with this, we complete this session 2. Can I request Dr. Gaurav to please join me on stage? And I would also request Dr. Praveen to please rise, as we would take this moment to thank all the speakers who have joined us today. And we've been talking a lot about communication and aftercare in this session, which has been really interesting, along with your passionate presentation. Can I please request a moment to be brought forward for Dr. Subhash Kaul, please? Ladies and gentlemen, let's put our hand together for the gentleman who spoke a lot about family counseling, because if that information is right, the care becomes even more comfortable at home as well. And now I request Dr. Varun Rehani to please step forward. Dr. Varun really specified that emotional care is equally important, and he shared several examples of how to deal with the communication gaps. Now we thank and invite Dr. Amit Haldar to please step forward, sir. Dr. Amit mentioned the role of taking care is more important after going back home, and challenges are delayed rehab, poor communication, lack of shared metrics, and limited post-discharge tracking. And now I request Dr. Gaurav to please present this memento to Dr. Praveen. He said that right treatment at the right time can impact 40% of the people to resume back to normal at their professional time and workplace. A huge round of applause to all the speakers on stage. Can I request everyone to join for a group picture, please? From prognosis to prevention, today's conversation highlighted how communication, continuity of care, and timely intervention can significantly influence neurological recovery outcomes. Thank you very much to all the speakers for joining us on stage. Ladies and gentlemen, we all know that today gathered here are not just the people from Hyderabad, but pan-India experts. But can anyone raise your hand and tell me if you know everyone in the room? Is there anybody who knows each and everyone present in the room? Okay, can I ask you to raise your hand if you don't know everyone in the room? This looks amazing. So, how many of you seen the movie Chak De India by Shah Rukh Khan? Very good. Uska dialogue, if you remember, ye 70 minute tumse koi nahi chhin sakta when they go to play the match, right? So, 70 minute I cannot give you, but I will give 60 seconds and I want everyone to stand up right now in 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2. Everyone means everybody. Thank you, gentlemen. Very kind of you. And now I'm going to give you 60 seconds. Yes, 60 seconds. In this 60 seconds, you have to go and interact or say a hello or just a smile with the person you haven't met earlier. And your time starts now. Go for it, everybody. This is the ice-breaking session you need because I don't want the drowsy faces. I know it is getting a little late, but we can accommodate these 60 seconds as a fantastic networking break while we also took some time out to arrange the stage for the next session. I want everyone at the back also to talk. There should be noise in the room. You should meet at least 3 to 4 people. Remember their name. Yes. This is just the warm-up. In lunch, you're going to have a lot of conversations going on as well. So you have 30 seconds left. Let's see how many of you can meet maximum people. Looks like some are just stuck with one-person conversation. Some are waiting for you to approach. My dear friends, nobody will come to you until you make the first attempt. So look at somebody, smile and talk and introduce yourself. If you don't find anybody, I am here. I am Jyoti Sukumar and a warm welcome once again to all of you. And remember my name. So we end with 10. Hello, sir. Thank you. No, I'm a professional anchor. Thank you. That's a compliment. Thank you, sir. So while everyone is discussing something, here is where I got a compliment and I got introduced to a gentleman. So let me do the countdown of 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. See, this is the problem. When I say you talk, you don't talk. And when I say now you stop talking, you don't stop talking. Fantastic. Give a round of applause to yourselves. Still talking. Okay. Okay, so now tell me how many of you loved interacting with new friends, new people? Raise your hands up. Great. Now with this raised hand up, you're not going anywhere out of the hall. Please settle down because we are now resuming to the session number 3. As many of you have already walked out for tea, coffee and bio breaks and hence we are avoiding this 15 minutes also as a break. So everyone, I request you. All right. So these two gentlemen over here are having a very candid conversation and they really don't want to hear me out. Fantastic. But anyways, we will now move on, my dear friends, because time is pressing and we need to continue the Recovery 1 2026. Session 3 here. All right. I request every gentleman and lady to please settle down because every speaker here has come forward to talk about valuable inputs and I want everyone to be heard. So either you settle down or you settle down. Thank you. Session 3 talks about advanced therapy and robotics, bridging research to real-world evidence, linking faster recovery and affordability. I invite on stage our keynote speaker, Dr. Abhishek Srivastava to please join us, MD, PhD, Neuro Rehab Specialist Director, Center for Physical Medicine and Rehabilitation, Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai. He's going to grace the stage along with our expert speakers. Dr. Mannemela Supraja to please join us, Consultant PMR KIMS Hyderabad. I request Dr. Supraja to please grace the stage, and I also invite Mr. Stafford Michael to please join us on stage, CTO, PRS Neuroscience Bangalore, Dr. Vijay Bhatina, Clinical Director, Atharv Hyderabad, and Dr. Vijay Janagama, Organizing Secretary, Recovery 1 2026, Director, Medical Operations and Quality, HCAH. And Dr. Gaurav, I request you to please join us on stage to introduce our keynote speaker, please.
Dr. Vijay, Dr. Supraja has also joined us, yeah. So this is one of the most awaited sessions where latest technologies, robotics is going to be discussed. Is robotic complementary to therapy? Is it expensive? Is it cost effective? I recently had the opportunity to attend IFNR and WFNR conference at Mumbai, hosted by Dr. Srivastav, and there was this wonderful debate, and I'm actually looking forward to hear from Dr. Abhishek Srivastav handling all these issues. He's the keynote speaker today. And he's a revered teacher also for me because I have attended his courses a number of times. Dr. Srivastav is the member of World Federation of Neurorehabilitation, WHO Fellow for Traumatic Brain Injury Rehab, Chair Education Committee, Asia Oceania Society of Neurorehab, Member Lancet Commission for Neurorehabilitation, Chair Special Interest Group Multiple Sclerosis, World Federation of Neurorehabilitation, ex-chair Neurorehab subsection of Indian Academy of Neurology, Secretary Indian Federation of Neurorehab, which he pioneered almost a decade and a half back. His laurels are IPMR Gold Medal, Dr. Anisya Vasant Award, Hospital Medica Dadichi Award, Professor Navendra Mathur Award, Professor M.V. Sant Memorial Oration. His area of interest are management of disorder of consciousness, stroke and brain injury rehab, rehab robotics, botulinum toxin for spastic men. I welcome you, sir.
Thank you, Gaurav, for a very elaborative introduction, and I'm not going to waste any time. I have an opening statement. These are the common myths in neuro rehab. It's not playing here. Yeah. These are common myths all of us face every day. I will enumerate them one by one. Patients with severe brain injury and stroke should be discharged when they are off ventilator. Person with brain injury and stroke don't recover after 3 months. Inpatient rehab has not much advantage over home rehab. Rehab robotics doesn't offer any advantages. Neuroplasticity plateaus very early after stroke and brain injury, and patient need rest after stroke and brain injury. These are common myths we were born and brought up with in our medical school days also. And to take it forward, I take these 4 case examples. A guy with a massive brain injury with a decompressive cranectomy, a diffuse axial injury with intercerebral hematoma, a massive AC-MC infarction with ICH stenosis, or a bad APLA syndrome with a ICH. Do you think these guys will ever walk again in the community? We all think they're lying in bed somewhere in a corner. I'll show you in the end how they are if they get good, timely, multidisciplinary, physician supervised rehab. We spoke about these concepts, but remember, brain can change, but we have to make that change. We say plasticity, plasticity, plasticity. Yes, plasticity is the key, but plasticity can happen spontaneously in first few days and finishes down. You have to trigger plasticity. And that trigger can happen by 2 ways: intensive training, which causes task-specific training, or experience-dependent plasticity. Or second is the role of newer treatments, neuromodulation, hyperbaric oxygen therapy, and pharmacotherapy. All have good role to play now. Today's talk is only on how can we trigger plasticity by experience dependence, which means how can we augment the repetition to give more task-specific training, and robots are actually one agent for that change. Also, how to improve outcome for patients with medical problems. We say go for therapy. That's all we know. And see an example, what happens in real life. This is from Europe. One of the best hospitals, another local hospital. Patients still spend 70% of time in bed, even in a top-tier hospital in Europe after a stroke. And a local hospital, 80%. Not much difference. So what we are saying at inpatient rehab also has to be much more intensive because we know time limits for plasticity. What are current limitations for treatment? Severity prevents practicing. You can't use upper limb if there is no power in the upper limb. Poor motivation, less number of repetitions, less availability of time of therapist, unclear feedback, changing needs of the patient, goes to ICU, comes back, hyponatremia, tomorrow UTI, lack of manpower and cost. And there's a study in Australia, they have shown that just making it therapy 6 times per day versus 5 times per day improves both the outcome, reduces the cost of treatment. So increasing dose of therapy is the key. How can we integrate that concept in our everyday hospital settings is the solution you have to find out. And what is the key element? We call it a 6-6-6 concept. Our patients minimum get 6 therapy sessions in a day, be it a daycare patient or inpatient. Minimum 6 sessions they have to do because we work 8 to 8. We have 2 therapy shifts, 8 to 4 and 12 to 8. So patient get 12 hours in a day for therapy and patient actually do 9 session therapy also in a day in those 6 weeks. And that's why you need functional training, active participation, self-initiated movements. If you can't walk and use your hand, if you can't talk with your aphasia and hemiparesis, you need some more technology to help you. You can track that technology that gives motivation and afferent feedback. So we say this 6-6-6 concept, at least 6 therapy sessions, 6 days a week for 6 weeks in a subacute stroke and brain injury to harness or trigger plasticity to best we can do. Many technologies have come in the last 20 years. Many have come. Body terminal training. This is only for motor we are talking about today. We have same for cognition, behavior, speech, language, swallow, bladder, and bowel. This is only primarily for motor. Dynamic posturography, FES, neurofeedback, mental practice, mirror therapy, virtual reality, CIMT, biomanual training, and robotics. What comes last actually? Where's the most expensive one? If you have 6-6-6, if you have basic stuff, then think about robotics. Don't buy it in the beginning. They are cost prohibitive to start with. What are these robots? These are the machines which can semi or fully autonomously help the people to perform the function which they cannot do. So God has made hand to eat, drink, drive, not to exercise. So if we can someone use the hand and trigger the engrams in the brain, you can get new motor recovery, which you never thought of was possible. And these robotics will replace therapists, that they will never happen. Remember, that they will never happen. Conventional therapy and technology works synergistically with each other, and they always work complementary to each other. The robotics can be devised as compared to therapeutic versus assistive, upper limb or lower limb, exoskeleton variable or any better system, variable or fixed. One of our chapters in recent advances of stroke rehab from IAN, we have given the whole review of robotics. So in the upper extremity, the first came was MIT Manus from Herb Krebs in mid-90s, which was an end effector device. But now the concept of care is to start using exoskeleton first when there is no power in the upper limb. Once you have some more power, you work with the end effector device. And now we have wearable exoskeleton started coming up, the hand glove. The technology is changing with the advancement. And if you see pictorially, multiple types of machines are available. Exoskeletons, end effector, only for wrist hand, only for shoulder, sensor based. A lot of things have come up now. We call it as a hand studio, where we have an army of power. MCS 7 out of ICU sitting independently can go for an army of power. He can trigger the shoulder, and then robot will give the movement, the sensors will pick up what he can't, what he cannot do, and in one half an hour, 45-minute session, he can do 1,000 repetitions of eating or driving, which he can't do for next 6 weeks in therapy. We have to understand this concept. One is impairment, one is function. You have to improve the impairment in the first few months so functions can improve. If hand remains like this, because you can't give him mass practice, robots can give that mass practice in the beginning when there is no power. And when there's a power in the shoulder, you work on the elbow and the forearm, you work with the Armio spring type of system, and then third, when you only work for the hand, need embryo system. There are multiple brand things available, and providing any brand is what we have in our hospital. So concept is work sequential. Whatever machine you have, work sequentially. First work on shoulder, recovery comes proximal distal, follow the pattern of recovery. Same way in lower limbs, we have exoskeletons, which first machine which came was from Okoma. Then we have end effector systems, and now we have overground walking trainers being available. Many of them, if you see it in real life, first came ankle-based system, then came stationary FES, then came exoskeleton system, then end effector, now overground variable systems. This was the most popular first machine which came by Gary Colombo in early 2000. It's a Locomat, it's a body weight support system. So the concept is, it's not passive training. There's a body weight support system to offload the body weight. There's a robot which gives you assistance, 100% to 0%. There's a treadmill speed you can change. There's a cognitive VR application along with that. So you are stimulating walking as well as cognitive function when a person is walking. It's very, very task in the beginning. Our patients with even TBI and stroke who are day 10, 14 out of the ICU, even with tracheostomy, GCS 12, also start walking very, very early. So the time is limited, and we can actually decannulate most of the patients very, very early because humans have to walk and use their hand primarily. That's what we are meant for. If you can do these two tasks very early, all functions overall improve. And we call it as a gate studio with two systems to help our patient. The concept is you start with full body weight support, full robotic assistance, very less speed. Gradually you reduce the body weight support, reduce the robotic assistance, increase the speed, and transition to more toward a body weight support system or overground walking. We have a lot of experience in the last 12, 13 years of more than 2,000 patients now of rehab robotics. We just take some case examples with lack of time. We showed you 4 cases in beginning. This family came to us at 1 month post-stroke with an MRI like this. It's a big ICS stenosis, ACMC, global infarct on the left side. But he got good treatment in time. When the family came, they told, no, he is conscious, he's looking around. He has a tracheostomy, an RT, a Foley, and a right hemiparesis. So what you need in comprehensive neuro rehab, you have to give enriched environment first, which means what is the cholinergic mechanism of stroke, secondary prophylaxis, start HBOT for improving sensorium, antispastic medications, botulinum toxins interfering with therapy, pharmacotherapy for cognitive function, linguistic function, donepezil, mementine, fluoroscopy for swallowing, USG, PVR, do all this medical stuff. Along with that, splints, physical therapy, occupational therapy, swallow therapy, speech therapy, bladder, bowel, family, 666. If you can do that, you can have robotic systems to help your patients. And you can see in one session, this boy can take 800 meters, 1.2 steps he can take a day, which he can't take in first 8 weeks in therapy. That's the whole point. You have to simulate hand and leg movements when there is no way to do for humans to do that. And with enriched environment, along with help of robotics, this came first, then came robotics. And then a complement of both helped that boy, and he actually went home walking without tubes. And this is at 6 months. He joined college at 3 years back. This is 14 years back. This is 2012 I'm talking about. He still has anomic aphasia. He still doesn't have full hand function. But he has studied, he has finished his engineering, and he works in a MNC. Another guy had a massive, second slide picture I showed you. This is from Delhi. The family came to us 2 years post brain injury with his previous scan and saying that he has woken up, he looks around, we have decannulated him, but we are unable to make him stand for 2 years. That's very strange. You can't make a patient stand for 2 years. Why? When he came, we saw, and what we saw, there's very bad heterotrophic ossification at the right hip and the left elbow, which was missed. He was like this. Very bad spasticity, very bad rigidity, but he was conscious, following simple commands, has motor aphasia, but very bad spastic rigidity in awful length that they couldn't make him stand. Walking is very secondary thing. Again, you do all this stuff you have to do. You have to do this medication, reduce these AEDs, add cholinergics for PVR, improve vitamin D, give bisphosphonate heteropic ossification, start all therapies, botulinum toxin, corrective casting. We couldn't make him straight. We did the intrathecal baclofen pump trial for him. And the trial was successful, did a pump implantation for him, and that's that first day of trial. After 2 years and 3 months, he took steps first time. And mother only asked us one thing, can you walk to the washroom? That's why we have come to you. Parents and families know the limitation of long-term recovery. We think they don't know. They know. We have to reinforce what is the logical solution outcome. And he went on walking at 3 months. Mother is laughing here. So much effort that he takes. And this is 2 years and 3 months. And after 4 years, when the pump change was scheduled, they called me again. You used to walk yourself at home without a walker. This is 6.5 years post brain injury. And this is 8 years back. And he's still walking better now after that. People can change. We didn't know that human brain has the capability to change. We told them, go home, kuch nahi hone wala. That's a wrong concept actually. Another guy had a pediatric traumatic brain injury. He came to us again at 4-5 months post injury. What I'm showing here is a FDG PET scan of a brain. So brain works on glucose. If you can give a glucose triggered isotope, you can map the brain. If it is taking 100% of glucose or oxygen, it will be bright red. If it's 0, it will be dark blue or purple. This is FDG PET scan at 6 months. This is the CT scan. This is ambulatory status. This is the FDG PET scan. There is nothing in the left motor and language area. Nothing. So plasticity can happen with surrounding networks or from the opposite side. Both help. And this is at discharge at 6 months. This is at 4 years. Even at 12 years now, he can walk independently, but he has motor aphasia and he can't use his right hand. But you look, there's nothing here. But he has changed. There's a evidence by electrophysiology to show that brain can change. Another lady, she came to us with a postpartum ischemic cardiomyopathy, 15% EF. She was told, don't move, you will die. Well, local doctor, your EF is so poor. Now, how she recovered from a stroke-related deficits? And this is a functional MRI. Last was a FDG PET scan. This is a functional MRI. You can see all this white stuff is the damaged brain. And these are the dotted marks. These are the supplementary motor areas for hand and ankle function. And the lady went home walking, underwent a heart transplant after 2 years. This is 2014. She came at 10 years follow-up a couple of years back. She has 2 children and she works independently and takes care of herself. Things can change. Another guy with bad Appler syndrome, very bad ICH. He walks independently, he goes to office, he works. And the last case is this lady, again came from Delhi 2017. She came at 3 months. And as a conventional thing we say in infarcts, 3 months there's no more motor recovery. And she was bedbound, sitting on a wheelchair with a very bad right ankle stroke. Again, you require whole gamut of comprehensive neuro rehab, enriched environment, and then we added robotic training along with that. You can see the Fugelmeyer, the Barthel, the mass changing with time, and the army of power, the army of spring, the Amadeus, and she went home walking, started using her upper limb for daily activities. So what these rehab technologies offer, the advantages. First, there are a wide range of training possibilities which simulate daily tasks. We have engrams in our brain for driving, eating. You have to trigger those engrams again. There's a faster progress through longer and more intensive functional training. Less strain on therapist. One therapist can observe 4 machines together. Patient walking and upper limb movement can be easily supervised and assessed. Gait patterns can be changed. Good motivation. And I have shown one fMRI to you. This is a sequential MRI by Yen et al., where they have shown that people who got significant amount of training on robotics, the relevant areas gained more blood. There's a bold signal in the supplementary motor area. So every 2 weeks they have triggered and they have tracked how people can get more. It's called functional recovery also. Just to summarize a few things. So what do require for plasticity to happen? Task-specific training, repetition, intensity, active participation, afferent feedback, and motivation. This remodeling of circuits can spontaneously happen, but dies down by first few weeks. That's why you need experience, dependent plasticity, and robotics are one agent for that change. What is the evidence? If you see Cochrane review rarely give evidence for rehab for anything. They would say need further trials. But here they have shown that robotic assisted therapy in combination with conventional therapy is more effective. Every fifth dependency in walking could be avoided. Mark my word. In best centers in Europe, 5% of patients with stroke reach for IV thrombolysis. Professor Kaul can vouch me for that. 5% reach for IV thrombolysis in the best centers where they can prove people in an airplane or a helicopter also. Of which, remaining 95%, 2/3 require rehab. So 1/5 is 120 reach in time for thrombolysis, every fifth can be avoided. So if you combine robotic training, you can have a lot of functional outcome. Always also remember, this is only for non-ambulatory patients. Please don't use robotics for ambulatory patients. Gait correction doesn't require robotics. It needs therapist guidance. And we have seen many centers taking patients. I have discharged patients from my hospital. You don't need robotic. They've gone to some other place, spend 5 lakhs in the next 3 months for robotic training. It's not required. It's only for non-ambulatory patients. Also, same thing for upper limb. Same thing for lower limb. You can see in cerebral palsy, it helps. Even the exoskeletons are now approved for community walking. So Rewalk and Endago are now approved for community usage in HCI patients. Even in Parkinson's disease and cerebral palsy and acquired brain injury, pediatric evidence is coming up. One of our studies in traumatic brain injuries have shown that people have better FAC and Figure-Math scores in TBI for dual limb training. Again, upper limb robotic training, again Cochrane review says it is better for ADL, for arm function and arm strength. So impairment and function and ADL, all three are better. This analysis says that very beautifully. Again, upper limb robotics are to be primarily used in the acute and subacute stage, not in the chronic stage. No point doing armio after 9 months and hoping for hand to move, it will not change. And the clinically meaningful difference of Fugel-Meyer scale is 8.64. 8.64 change in Fugel-Meyer upper limb is a very big change. If you can get it, if you combine training on robotics in the acute and subacute stage along with conventional therapy. Now the Robotas trial have shown that in the end effector type of robotic system, Fugel-Meyer changes by 6 points. But in the exoskeleton groups, it changes by 11 points. So you should start with the exoskeleton and then go to end effector. That's how it actually happens. Again, few more slides. I'm sorry, taking some more time. Gaurav. The limitations people tell, high initial investment, yes. Requires training, yes. Limited accessibility, yes. Fully therapist, yes. Insurance covers now most of it. Cost benefit under research. Let's flip it down. How much it cost? The most expensive robotic system cost $1 billion today, which has high infrastructure and maintenance requirement. Today we have systems outside upper limb which cost $5,000 US. Lower limb, $1,000 US, all made in India. They can reduce your hospital stay, they can reduce long-term disability cost. People ask me many times, "Aap robotic karte ho, the cost is 1 lakh rupees 20 sessions." I asked him, what is the overall cost of managing same patient at home if he is not walking? That cost nobody measures. That cost is lakh rupees a month in Mumbai to have 2 caretakers to handle the patient. Also, what is the cost of therapy per patient with robotic systems? In India, it is 1,500 to 5,000 sessions per session depending upon what machine, upper limb, lower limb you have. In US, it's quite expensive, up to $500 per session. India is max 1/5 of that. Also, they have compared robotic therapy versus conventional therapy in US. Robotic therapy is cheaper. They're expensive, their manpower is very expensive in America. So, the conventional concept of traditional one-to-one therapist versus one therapist seeing 3-4 patients or robotics also make it much more cost effective. So one is the advantage it is offering in efficacy for reducing the impairment. Second, is the how many patients can be seen by same manpower and that allotted time. So just to summarize, we all know this, we can reperfuse the brain in first few hours. Very well studies for IV, TPA, thrombectomy, removing the clot, decompression. Brain settles down in first few weeks. Previous speaker spoke about it. Brain tried to change itself. That finishes by 3 months. That's why we were told when we were studying medicine, 3 months के बाद motor recovery, language recovery नहीं होता. It's a wrong concept. If you start intensive training, new protocols in this time period with 666, 6612, the model you can deliver, you get something new, which is training, induce reorganization. That doesn't die down very soon. That can work for long. So always remember, we were taught in medicine the disability model of rehabilitation. If you can't walk, give a stick. Can't talk, teach sign language. Can't eat, put Ryle's tube. So we were taught. And what it led, one, we only focused on the disability. And we forgot the patient's ability. We gave him more learn non-use. What he could achieve, he could never achieve that because we never knew in medicine that brain can change. So current focus of modern rehab is to treat the impairment. You treat cognition, vision, behavior, speech, language, swallow, mobility, bladder, bowel, all 10 things together in a comprehensive rehab, patient do better. And those 4 patients you can see again with their scans, they all are living independently in the community. And those same myths, patients with massive stroke and brain injury need to be transferred to a specialized center offering comprehensive inpatient neuro rehab. That is the first myth. Second, functional recovery can happen in up to a few years after insult and patient get proper care and therapy. Inpatient rehab can significantly reduce death, dependency, installation. These all are proven by multicentric trials. Every 5th dependency in stroke can be avoided if rehab robotics are used in conjunction in non-ambulatory patients. And Fugel-Meyer score can improve by 11 points in the 6 points in the end effector group, 11 points in the exoskeleton group, especially in acute and subacute settings with real-world functional gains. Thank you very much.
Thank you very much, sir. Right, starting from the myths and concluding towards the costing of the robotics, how important it is, as well as talking about the facts. He has made it absolutely crystal clear. Thank you for your time and indeed the explanation. And now I would like to invite our expert speaker to talk about right patient on the right robotic device. Dr. Supraja, please put your hands together for the lady, consultant PMR KIMS Hyderabad. I'm over to you.
A very good afternoon to you all. First of all, I would like to thank the organizers for giving me this opportunity. And I'm happy to be here today, and especially because I have to present in front of my teachers today. My professors are here today. Professor Yusing and Professor Yadav are here. So I was remembering my postgraduate days while after seeing them. Whenever we had to present in a conference, we were supposed to rehearse at least 5 times. So I felt like a student today again, and Professor Kaul and other old friends are here today, and Dr. Naveen Mehrotra as well. We all worked at various places earlier at Nizam's Institute also. And I have to thank Dr. Vijay from Civitas. While we were discussing about the topic, he said, you worked on different kind of robotics. So why don't you just speak about the experience what you had over the past 10 years. So that was the right suggestion which he gave, and I thought that would be the best thing to present whatever I have experienced with my patients. And I have to thank all the previous speakers who spoke about the importance of acute rehabilitation, which was missing for many years. And I was fortunate to be at Apollo Hospitals earlier, where we were the first hospital in the world to be accredited by JCI for the management of acute stroke. So we learned how important is implementation of rehab protocols in the acute care is important. And we saw wonderful outcomes when we implemented the rehab strategies in the acute care. Then as Abhishek said earlier in the last slide, we are moving from pathology to the functional impairments. It's important to know the pathology because that gives us an idea how the patient is going to behave, what are the prognostic factors, what are the outcomes we can expect. But as far as the recovery pattern is concerned, we focus on the functional limitations as such. So before we move on to the actual topic on robotics, it's very important to know what are the factors affecting the outcomes in rehabilitation. It's the quality of care at each level which matters and the clinical pathway which is followed, preferably across all the centers where your patient is going to move next. Because in one hospital they follow one kind of pathway, and when they move to the next level, it becomes easier to communicate if everybody speaks the same language, follows the same outcome scores, and follows the same kind of communication which they maintain with the patient. So we in Hyderabad are trying to associate with multiple people. We work in a collaborative model, and we try to communicate frequently, and we talk about the objective outcomes, not about actually the recovery only. Then other important factor which predicts the outcomes is the discharge criteria from the acute care. So this again might differ in stroke patients. It could be maybe 2 to 3 days, but timing doesn't matter. As Dr. Naveen Mehrotra mentioned very clearly that the patient's condition has to be evaluated, and the reason why we are keeping the patient in the ICU has to be defined, because then we know how intense rehabilitation has to go into the acute care as well. And measurable outcomes are one of the things which will give us objective identification of the features. Then follow-up till the highest possible level of functional recovery is very important. And as we all know, now over the past maybe 20 years, acute care interventions have improved a lot. But post-acute care is not structured, fragmented, and it gets neglected, which in fact maximizes the potential for recovery and thus further reintegration into the society, which is the main important factor why we are all sitting here today. Because the recovery and early integration into the family as well as community matters the most. So this again, as per the WHO guidelines, earlier we used to talk about rehabilitation in much later phase. But now WHO's Call for Action 2030 plan says that it has to be integrated from acute care and it continues as long as the patient survives. So it is along the continuum of care rather than at one particular level. So this is a disclaimer. As I can see, people from different companies are there who manufacture robotic devices. That's the reason I would like to mention that in case if any, this is not to promote or refute any product, and name of the equipment if mentioned is only for the sake of easier communication and not to promote any particular brand or company. Once neurotechnologies have developed in a huge way over the past around 10-15 years. And it's very difficult to decide which robotic equipment to be there in particular facility. So several technological advancements have happened to restore mobility, function, as well as cognitive functions. So I was fortunate enough to have the first exoskeletal device in the country in our center, a wearable exoskeletal device. And we also had robotic tilt table and the robotic arm trainer. So this was the first exoskeleton which we had in our unit in 2015. Now, as again Dr. Abhishek said, it doesn't depend on the pathology, but it depends on the functional impairment with which the patient presents to you. So I would like to just give two different examples of hemiplegia as well as paraplegia patients. So here if you see a 32-year-old male with left-sided hemiplegia who was treated in the same hospital in the acute care was shifted to our unit on day 5 of stroke, and as he was very young, we started giving the therapy on the robotic device, and within a month he was able to walk. He regained the tone of the muscles, and then he was able to walk and manage the things independently. However, upper limb recovery took longer because he has flaccid paralysis of the upper limb as well. Then there was another patient, 63-year-old male with left-sided hemiplegia who had grade 2 spasticity. So I wanted to mention this because just because we had the robotic device, we did not place the patient on that, because that patient who had severe spasticity and elderly, he was not ready for the robotic device as such at that time. So our plan was to manage spasticity, get it under control, then take him onto the robotic device. And other major factor was he had lateralization towards the unaffected side. So then it becomes very difficult to maneuver the robotic device. This is just to give an example where every patient will not fit into the kind of device which we have. We need to define the criteria based on the impairment with which he presents. So that's the reason clinical examination and reassessment are extremely important in deciding which patient to be put on which machine. Then again, paraplegic patients, 2 patients. One patient was a 38-year-old male, and he did not have any control. Our main indication to put the patient on that was to gain hip flexors so that we could give a better caliper, and we wanted to send him back to his country. So the indication was clear, and we were able to achieve the target, and patient was happy, and obviously medical team was happy. Whereas another patient, 30-year-old male with transverse myelitis, who had again flaccidity of both lower limbs, presented immediately after the acute event. Here we gave the robotic therapy, and patient improved and went back to his work. So we were clear with the intention with which we were putting the patient on the machine, and we were clear with the outcomes, and we were able to achieve. In case we do not achieve, we communicate with the patient transparently, and we stop the therapy. So this is again one of the robotic tilt table where we can place the patient on the machine as early as possible. Even the patients from ICU can be shifted there and can be used. And this is the robotic arm trainer. Again, this can be used for flaccid paralysis patients as well. And when I moved to another hospital, Medanta, in 2019, we had the opportunity to have the functional electrical stimulation along with the robotic tilt table. This again was very helpful in getting back the patient's power and the movement. Then we had the robotic gait trainer, which again was one of the first and foremost ones in the country, as Dr. Abhishek has mentioned. So on this also, I'd like to just mention about 2 patients who had different indications. One patient had traumatic paraplegia, and then we wanted to send her back as early as possible to work. So we were able to achieve that, whereas other patient was just the maintenance therapy. It was not for improvements. So this is other overground trainer. I'm just taking you to, and this is the recent machine on which the last patient we worked. This is again wearable robotic device, and she had doubtful contracture of the tendo Achilles. So before going on to any surgical procedure, we wanted to see if we can stretch the joint or not. We were able to achieve that, and people who have attended the Botox workshop yesterday, botulinum toxin workshop, we injected, and we were able to achieve the result. So we prevented surgical intervention in this. So what I would like to convey is the realistic goal setting, considering the limitations, and the right patients on the right device matters a lot. And knowing the competencies of each profession and recognizing the limitations of each profession is very important in a multidisciplinary collaborative work team. So, and the last but not the least, a right patient on right device defines start and stop points. We need to know when to put the patient, when to stop, when to move to the next kind of equipment, or when to give more of manual therapy like that. Then high quality care implies better outcomes, then high physician satisfaction, And undeniably, this is all for the founders and the investors. It undeniably builds trust and unfolds the ROI on the machine. So trust me. So thank you for giving me this opportunity. And teamwork generally matters. Questions now or later?
Thank you very much, Dr. Supraja. I'm really sorry that the music tin 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 actually disturbed, but it brought a smile on your face too. I request that our speakers, though we have been already delayed 40 minutes almost, I request you to please keep the time in mind. We also have the timer running along your sides on the monitor. So 10 minutes is for all the speakers. I am really sorry to say that, but then we will have to just keep up with that. Also, ladies and gentlemen, I want to inform you that the questions, please write it down. Even if we don't take it after this session, we might take it during the lunch break because we are already getting a little delayed on that. Anyone feeling hungry? You'll have to just hold on because soon after this, we will be taking up with the inaugural ceremony. Though we know for the fact that Health Minister of Telangana is the chief guest. However, we also have the Prime Minister, Shri Narendra Modi ji, visiting Hyderabad today. And because of that schedule, our chief guest might get delayed, but he promised that if it is possible for him, he will drop down even before evening whenever possible. So fingers crossed, we'll wait for that. Without any further ado, I would request our next speaker to please join us for the topic linking technology to fastest recovery and making it affordable. Mr. Stafford, please join us. Let's put our hands together for him. CTO PRS Neuroscience Bangalore. Over to you, sir.
Good afternoon, everyone. Dignitaries on the dais and dignitary off the dais and my dear audience. I'm Stafford Mikhail. I think I come from the industry of IT than from the doctors because I see everybody here are doctors in medicine. I'm an engineer who is working in the field of healthcare from past 4 years and building multiple products in this field. So let me give you some of the examples of what I was doing from past 15 years and my introduction about it. So I was an engineer who started along being a professor in engineering college in Mysore, in Karnataka. So I used to be building robots there. I started having a grant from government of Karnataka where I built about 30 lakhs. I got a grant and I built multiple products and also for karate because I have a passion for karate. I'm a Commonwealth referee for karate and 5th belt black belt also. So I'm also been a president of VRAR Association of Bangalore and worked on various projects for Indian Army, ISRO, and multiple in the field of robotics. So this was my first product when I built across after I jumped out of being a professor because I thought that my talent was getting wasted over being in the college. So started my entrepreneurial journey in 2017. And this was a product which is called Hollow Suit, which is a motion capture suit where you can see that I'm wearing a suit, I'm doing all the motions, everything is being captured. This is an era where even VR and AR was not yet coming into play. And I was starting along with how to digitize the entire body. So this is a complete product, indigenized, made, developed, and designed in India. We hold about 42 patents on this. I also built, in 2019, I guess this was a time of in the COVID, where PUBG and Call of Duty were some of the games which you would have seen, which was so well built across, and people used to use across in multiple sections. So I brought this into defense also, where I built a product like PUBG for them to train on various activities, including visuals and all of this. Why I'm telling all this is because of these experiences is what I'm doing right now. I also had a chance to work along with ISRO, so where I was a project owner of one of the cleaning robot, where you can see that I am using my body motion again to control a digital twin, which is a robot from far away. So I was able to demonstrate 200 kilometers distance where I could see something in VR and control a robot which was like Iron Man that time, you know. So I was very fascinated by looking into this Iron Man, and I wanted to build a suit like that also. So let's start with what is the actual topic of neuro rehab, because I am basically from the original industry of IT, but I understood after coming into neuroscience that I am not from the original industry of IT, but brain, that is what neurosurgeons are doing, is the original industry of IT. Because I can transfer my kidney to you, your kidney to you, it's the same functionality, my heart, your heart, but the brain is something that is identical. We can't transplant it. If I transplant my brain to you, you don't become an engineer. If you transplant your brain to me, I don't become a doctor. So it's not possible at all. So the second chance that changed the life, a stroke, a fall, or a spinal injury, 2 seconds, that is all it takes for a signal from the brain to be cut off. That this is a major highway, because it hardly takes a road traffic accident. As we know that in India, more than 1.5 lakh people, and an average, have been admitted over RTA, that is road traffic accidents. What are we doing in the country? When 4 people got killed by the terrorist, we run a war on the other country. What are we doing inside when 1.5 lakh people who are getting these damages? And you know how much impact it's happening on the family, on the country. Each person earning about 10 or 15,000 per month, that much amount of GDP is lost, that much amount of money is lost from the caregivers and the patient itself. So we need to do something very strong on that. But what we do if we have to rebuild that connection? If this highway is gone, so neurorobotics is one of the sections that we can look into. This is a story that I'm going to tell today. Rehab hasn't changed enough. The therapist repeat the motion 100 times. It's powerful but exhausting. Robots can repeat it perfectly, but they are truly rehabilitating the humans, because motion without intention is just motion but not healing. So you have to think about that. What is the intention that we are doing this across? What is the process that is happening in order to move or drink or eat? What all activities that is happening? What is the intention behind it is very important, and how do we measure it? So I started along with a exoskeleton myself. So I built an exoskeleton for Indian Army in 2020 and 2021. So I'm going to talk about my inventions, my work that I have been doing across in this field, and how I brought it across into the field of healthcare. So wearable robotic suits is nothing but mimicking your human motion on top of it. It can flex, extend, rotate like Iron Man suit for rehab, but most cases the motion comes from the machine and not from the mind. So it's very important for us to see where it is getting originated and how are we going to link it. So are we training the robot or are we retraining the brain is the question that we need to ask. Movement versus mind. So motion not equal to recovery. Every true recovery starts inside from the electrical spark in the brain without a signal. The body moves, but the mind stays still. So we need to understand how motion and recovery has to work hand in hand with each other. So I developed a system which is a low-cost system, again using just your phones is enough, because I started seeing that people are investing so much money, and I have a business which is running across in PRS neuroscience, and I can't put more money on top of my patients to say, I've got a new robotic instrument, you have to pay extra amount on top of this. This is like $200, this is like $300. Now still we are talking in dollars and not in rupees, you see. So the reason is these equipments are all in dollars, not in rupees. So I have brought it down to rupees. So this is what is that we are doing. We are designing, making in India and manufacturing also in India. So this is one of a product which looks into a camera. You can use any of your webcam, your phone or your laptop existing, your TV which is already present, which can plug and play across. It gives you all the analysis of your body. How does it do that? The real journey actually starts from brain, spinal cord, muscles, movement, feedback and back to the brain. So this is a closed loop system that we have to understand. So rehab is equal to reconnecting this loop, entire thing. So because the neurosurgeons only do the intervention part of it, but reconnecting them back to the community is what we have to think across. So injury breaks the highway. Our mission in neuro rehab is to rebuild this wire by wire. It cannot be done at one go, but we have to do it by step by step by step. So in order to understand what is brain, so there is a system called brain-computer interface. So whenever we see an exoskeleton, nothing is driven by the brain or by the spine or by the muscles. It is driven by the machine itself. So what we do is, we take the signals from the brain, we take the signals from the spine, we take the signals from the muscles, and then move the exo. If there is no intent to move, it won't move. So this is one of our systems that we have built, which is the brain-computer interface, which reads the system. We have an EMG also, which also detects the muscular activity, also as well as some activity that is happening on the system while we are putting them on the robotics. So we have one more product, which is a Poise 360, again wearable. You saw me wearing a suit, so I couldn't give them the whole suit, so I made them individual nodes so that you can use your left arm only 2 nodes, so reduces the cost by 1/3. So every product I want to bring it into thousands for the centers, not for the patients. So it becomes much more lesser. You can do a freemium like how Google is doing. So we have one more system which is called BrainPad. This is for cognitive. So asking questions to patients to say, because every time we ask them to play on the table, to pick this, sort out your pebbles, all of this, they don't feel excited being in the Gen Z system. So we need to work on that to make them be more excited to do neuro rehab than to feel it's a pain. So we also have an additive manufacturing system, because as you know that some of the people cannot hold a spoon. So we need to modify the spoon based on their conditions. So we have our own 3D printing systems. You can also introduce them where you can make their own spoons, make their own plates, where they can do their functional independence level can be achieved. So this is one of the points that I have to tell, that introduce 3D printing, make customized products based on the patients, because each patient will not have the same condition. You cannot use the same spoon like how normal people use. So we need to modify it. So we also build a neurologics platform. So where you can see on the one side we have natural neural networks, which is all that comes from the doctors that is present across here, from the neurosurgeons, from the therapist and all. The other one is the artificial neural intelligence, which comes from the devices. As you know, ChatGPT, it has a dictionary, which means that it has words which needs to be spoken or told. But is there a data set like that for neuro rehab? So what do we do for that? Where is that dictionary for me, which says what is and, what is all, what is for? Every meaning is important. So this is where our machine converts all the digitization into a machine learning, which can be used across as a data against the natural neural network and use it across over a period of time. Over a period of time, my system is learning on its own based on this digitized data, which can give and predict much more. So getting AI into neuro rehab is very important. Nobody spoke about AI here today. I would really suggest that using AI is a first task, because every time you want to get to and on information, normally people do is go on to a Google search or go on to a ChatGPT right now. You ask to say like, what is the first information? So I would say this is the first kind of an information that you can get about what is the prediction, what was his previous state, what is his current state, where he can reach, what is the system. So caregivers get a better understanding about it. So this is one of a product which is like using your phone. You can just use your tracking device, which gives you flexion, extension, abduction, adduction, everything from end-to-end system, just by using this digitization of the entire system. So we also have a hand tracking system. As you can see, when you do a tabletop activity, when you're asking them to sort out something, how do you give quantitative analysis? So there is no such thing that we can do across, but you can see here, I can give multiple of these informations and digitize them, which can help you to give a better report to the caregivers across in order to understand what is the progress they are doing. The same way for that. Yeah. Yes. And this is the exoskeleton that I had developed for the Indian Army, which is again used. I just want to show what I am doing on the other side. So here you can see I am walking and the patient next to me is also walking. So this way of treating the patient to make them understand one by one, also using their brain also, because they have to see what they are doing. They are seeing that I am walking, oh, I have to lift my left leg. They are walking, I have to lift my right leg. Some activities keeps happening on this and they keep moving across. We give a report also, and very importantly, last topic I want to talk about is in neuro rehab there is no standardization. Each center, each hospital have their own ways of doing it. So it's very important to get standardization also onto this. Thank you.
Thank you very much, Mr. Stafford. We couldn't stop ourselves from watching every product developed by you. So many ideas. Really would appreciate that. Just that the time is pressing. And now I would like to invite our next presenter for complementing or replacing the traditional therapy. I request Dr. Vijay Bhatina to please join us, Clinical Director, Atharv, Hyderabad. Let's put our hands together for the speaker.
Thank you so much for inviting me here, and it is really, I draw a lot of pleasure sharing the stage with Dr. Abhishek sir and Supraja ma'am. Actually, the baby steps have started in KDH with Dr. Abhishek sir. I was there with Dr. Rajesh Mistry learning lung transplant program, so that's when I saw robotics in my life first time, and so it's really great occasion to me also. Jumping into the topic, complementing or replacing traditional therapy. I think this entire scenario should be read in a different way. Robotics alone cannot do anything. They are coexisting devices, right? So without physiotherapists, without conventional and traditional model, there is no great yield that a robotics can really give. So I have divided the discussion into certain questions. So the first one is all about, does robotic add value anything other than giving repetitions? Yeah, repetitions are definitely important in driving neuroplasticity, that we all know. But repetitions is not about just repeating the moment. And repetitions, if repetitions are enough, it is very predictable model. But stroke or any other neurological rehabilitation is not about repetition, and then it is not linear progress, right? So what I have done is I have given certain references for review and the research, saying that at what level the impact of robotics along with conventional therapy is effective. When you see in acute phase, that when the patient is in ICU or the ward, it is not that the application of robotics is very low, the yield is very low, but it is little moderate when you compare to subacute and then late acute stage, when the neuroplasticity window has certainly getting down and then the compensations are getting set in. So that's the stage where the maximization of robotics has been seen in literature and in my experience also. So it is not that robotics versus traditional rehabilitation, it is robotics with traditional rehabilitation is what the case that we have to really look at. When we look at certain, a very important RCT says that, when Dr. Abhishek sir was reiterating that, when there is an impairment which was very mild in case where the patient is able to, produce certain contractions which are functional, the effect of robotic is really limited, versus when there is a severe impairment, when the patient is not able to produce certain voluntary contractions also, then triggering that neuroplasticity, robotics are really effective. The second question is all about, can robots replace physiotherapist or the other therapist? So I was thinking how to build this slide. So, but I didn't got right trajectory to do this. So what I have done simple experiment in my rehabilitation center. So this guy is an acute stroke patient who are training with grasp and release scenario, right? And the therapist is next to him. He is actually training him to hold grasp and then keep the bottle next to him, right? So yeah, post which we asked this same patient to continue to do the training with the robot. So he started doing this. So the hand glove is training his hand, but he is looking into YouTube reels. So it is not that robots can add real value without a therapist or robots can only drive recovery. It's all about how do we introduce it to the patient, how do we train it to the patient, right? So what it matters is how do we drive this something called intent, which will make real clinically significant or clinically different functional outcomes. Is all about how do you target the patient and introduce something called selective control. So what we have done, we have given him a gamified solution where he have to really drive that selective control and he have to place or solve some game with his hands. So this really drives that neuroplasticity, this really drives his intent to get into a clinically important difference, that is functional gain. So the third one is robotics is really in a priority list for India. So it is not just India. I think people who see in the Western model, particularly NHS or the model in US, even they are not privileged or got access, that fluent access to use robotics very fluently. Once the Medicare is in US, once the Medicare is done, it is so difficult to get into a simple conventional rehabilitation itself. And we all know about NHS, how burdened it is today. So it is not that India should really focus on getting access to conventional model, but we should not stop thinking about introducing robots or talk about technology either, right? It's an evolution that is going to happen over the time. So I have come across certain technologies. These are not just robots, there are certain technologies which are affordable, can be go to home, can actually help therapists to get neuroplasticity to the patient. So certain devices which I have just seen from IIT Madras collaborating with CMC Vellore, developing indigenous hand rehabilitation device. And I'm sure HCAH is one of the largest users using our physio device since ages. So let me conclude with a simple case study. So we have a female with 40 years old who is medically stable, reasonably gained certain functional scores where her fugal Mayer score is upper limb is 30 and then lower limb is 17. She did gain some functional traction, but she is not self-ambulatory. This is her initial video, great risk of fall. Actually, she experienced 2 episodes of falls. Since then, she became more anxious to walk without having great support, at least 2 people. So we introduced both conventional therapy as well as robotics over the time. This is an end effector robot that we have in our center. If you can see, she is trying to strike her heel. That is where the intent is getting to, get into action. She is trying to achieve that heel strike when you see her. And again, it's a gamified stuff. Slowly, we introduced her arm swing. And sometimes she started walking. That's when we withdraw the effect of the uses of robotics. When she started ambulating. We also started training her upper limbs, so it's a high cord lesion, giving her trunk control. Along with robotics and conventional physical therapy at the center, we encouraged her functional, that's how you translate our gain to the home. Otherwise, see what happens, a lot of patients says that in robotics with conventional therapy, we are doing great in your center, but when the same patient goes to home, they're just sitting on the chair. So we wanted her to, do certain activities that she does before the condition. That's when the real gain has translated from robotics to home. And you can see we got that finest of the finest writing, the grip, and then the precision that she has got with this. And this is not so long, it's just 6 weeks. So she is able to take the stairs without much support or without just supervision. The same person was walking without any assistance. So key takeaways I want to put out is the relevance of robotics lies in the value beyond the quality of conventional therapy. And the robotic intervention is not inherently superior. The effectiveness depends on the context of the introduction of the robotics. robotics finds itself in the greatest role when the conventional therapy is physiologically limited. And then always clinical judgment remains a central determinant of the recovery. Thank you so much.
Thank you very much, Dr. Vijay. And now I would like to invite our next speaker for the topic of impact of advanced therapy and robotics on recovery outcomes, efficiency, patient experience, and economics. Dr. Vijay Janagama, please put your hands together for him. Organizing Secretary, Recovery 1 2026, Director, Medical Operations and Quality, HCAH.
Good afternoon. Thank you, team, for giving me an opportunity to be part of such an esteemed panel here. So without getting into any delay, I will just touch on the topic. As we have seen, right, there is an advanced equipment, latest equipment, impacts are clear. So they should be all over the places where there is a need. In the real world, it does not happen so. So there may be some decisions that are happening beyond that, right? I think that is where we wanted to look at this as a perspective, going through the lens of impact of advanced therapy and rehab through clinical efficiency, patient experience, and economic viability. So I think the fundamentals of neuroplasticity remain same as the nucleus, where there is a high repetition, where you see that you have to create the neuronal pathway reorganizations, and then adding to task specificity will give the cortical remapping opportunity. The consistency will avoid redundancy, and then it will ensure that there are identical trajectories that will come up. And importantly, you have to give that feedback so that the brain starts rewiring again, right? So these are clear advantages, but again, when you're comparing with an existing conventional thing, the fatigue is usually sooner than when compared to robotics, because there is a clear advantage of movement, which is supposed to be around 5 times more than the conventional one, right? Now, to add to this complication, I think the demographic burden is still there. The number of aging group is increasing, and the incidence of stroke, spinal cord injury, and Parkinson's are improving. So it is literally creating and adding more pressure so that the final throughput is being still challenged. So that where clearly to add to that, there is a motivation factor that comes at a psychological level. There is a lack of visibility where you are not seeing the incremental progress, which brings kind of an advantage of advanced robotics. Then there is a low engagement because you are not seeing what's happening. Therapists naturally have their fatigue after a certain time, and this all combined with the emotional put through they are going through the disease phase. Right? This is again covered well, robotics, multiple of them, VR, artificial intelligence, sensors. So I will just get into the next one. Again, clearly proven value for stroke rehab, where there is so much emphasis on strength, regaining, balance training, and spinal cord injury, where there is an ambulation advantage, orthopedic rehabilitation, maintaining the joint level of movement, and Parkinson's geriatric, where you are going to prevent the falls and also work on the mobility factors. Right? This is something which, and in one of the centers which we have picked as an initial one, there is a combination of robotic lab of excellence, where we have almost all of them in place, what we have seen from the senior speakers, right from the gait trainers to the vital stims to the hand rehab, and all of them together. And then we as a company are obsessed about tracking the milestones and see how we are achieving them. And then we have an advantage of comparing it with the centers to centers, right? Then this was just again, this is the last 2 quarters one, where initially these are the prominent milestones, where there are 20 other parameters which we track, but this is about tracheostomy decannulation, feeding tube removal, standing independently. All of them have been tracked. Those there is a baseline, and then there is a progress that we are tracking. So the initial progress is definitely welcoming. This is again coming from the number of just sessions, right? Where if you look at the robotic gait sessions, upper limb sessions, and balance therapy, all of them, the last 6 months, the number of sessions have been improved, right? So there is a direct correlation of that one. So everything, it's clear cut. There is an advantage infrastructure. There is an absolute consistency that we can bring. There is a measurement which gives a feedback, and then there's an exponential growth. Now, there is a motivation factor, which again, if you gamify, there is an engagement. Naturally, amount of duration of therapy is enhancing. Right? This is where the crux of the topic lies. When there is so much of advantage, will it go through as it is? Now, there is an existing thing which again acknowledge there is a high capex, so equipment, the technology comes at a cost. There are infrastructure modifications required. Practically, we see will this center take this or no, and then there is staff investment has to happen with multiplied long-term returns. There is a productivity, there is a patient throughput which improves, there is a reduced length of stay which directly aligns with our mission of fastest recovery. This is where the question now, the ROA is variable. If it would have been straight, then it's a yes for everything, right? So probably you have to look at it slightly larger stance, where initial phase you have to consider it is going to be capex heavy, so you have to invest, and then probably there will be an inflection point, you start seeing the trend, and eventually there is long-term benefits that will come up. So just when we are navigating this decision making, this is a quick, almost just last 2 slides. So the financial constraints, we have to come out with a model where you are not going to hit the heavy capex, so probably some subscription models, and geographic accessibility where there is a still it's focused around metro, so give them an option of tele-rehab and some mobile devices. And then workforce transformation, this is important to make them believe that they are integral part of this change, and the technology acceptance, believing that this is for augmenting our own skills. This is where probably a hybrid model where you are retaining the clinician-specific, human-specific, the strategy, the empathy, complex decision-making, the patient selection and emotional support remains, taking an advantage of infinite repetition, objective data analysis, precise movement and feedback. So this hybrid might be a way to go, right? The take home in terms of for the clinicians, embrace the advanced therapy. There is every opportunity to make your patient better. For healthcare providers, make sure that these are phased in a right strategy where you have to make sure that machine is going to be used. For the policy makers, ensure that the billing ecosystem changes where there is a reimbursement option for all the robotics too. For investors and administrators, you have to put it as a lens of long-term outcomes with long-term financial stability too. Then, this is not that easy. But it is essential to think that, because naturally when you have a clinical efficiency in place, patient experience in place, economic viability has to be properly thought through. That's where I would like to end. It's, as the previous speaker said, it should be the right patient, right device, and right center too. Because if you make sure that machine has a utility, then all the outcomes see different. Otherwise, it will retrospectively strain the entire system, whoever has taken the decisions. So this is where I would ensure that we probably bring up with a hybrid model where we still maintain the human touch and high-tech equipment together. Thank you so much for that.
Thank you very much, Dr. Vijay. And now I would request Dr. Vijay Janagama as well as Dr. Abhishek to please rise, as we would like to take this moment to thank all the other speakers, expert speakers, who've joined us, to present a memento to them, please. Yes. Firstly, can I request Dr. Supraja to please step forward, consultant PMR KIMS Hyderabad. Dr. Supraja mentioned that post-acute care is not structured and which maximizes the potential for recovery, as well as she highlighted where exactly we need to stress upon. Thank you very much, Dr. Supraja, for bringing in your valuable thoughts and insights. And now I request Mrs. Stafford to please step forward. Ahead in time, we are training robots, or the retraining of brain is happening, is what has he questioned. Make in India products, customized 3D products to suit different patients and their own conditions is what he explained, and we would love to know more about the products that you're into. And he stressed on the usage of AI. Thank you, sir. And I request Dr. Vijay Bhattina to please join us now. Let's put our hands together, ladies and gentlemen. Dr. Vijay told us that robotics with traditional rehab is the right combination and not one of them. Technologies that are affordable and help patients to recover faster are now accessible. And I request now Dr. Gaurav to please join me on stage. Dr. Gaurav, I want you now to please felicitate the two dynamic duos on stage. Firstly, can I request Dr. Vijay Janagama to be felicitated, please. With his expertise, he is trying to definitely highlight the impact of advanced therapy and robotics on recovery outcomes. Thank you very much, sir. And finally, to our keynote speaker, let's felicitate Dr. Abhishek, who said that increased dose of therapy improves the results. The more number of therapy, the faster and the quicker the results, the more happier families are. Thank you very much, sir. I request everyone to please join for one group picture. The session beautifully demonstrated how innovation, robotics, and technology are not replacing human care, but empowering faster, smarter, and more accessible rehabilitation outcomes. Thank you very much to the entire set of speakers. Put our hands together once again. Yes, and without any further ado, let's prepare for the inaugural ceremony. As I did mention once again, I would like to reiterate the message that our Health Minister of Telangana, Shri Damodar Rajan Narasimha Garu, will not be able to join the conference right now because of also the due availability of our Prime Minister, Shri Narendra Modi ji, coming to the city. And there are several meetings held up with the government of Telangana along with the Prime Ministerial meetings too. Thank you. While the session is being set up, I would like to officially say that we are thankful for you all joining us together and amidst waiting and hearing the conference. If you have any questions, please do write down, as we would like you to exchange the same during the lunch hour or post the end of the session. If we still have time and we're not too late, we will definitely conduct the same. Now, talking about the inaugural ceremony of Recovery One Conference, that is 2026. I request all the ladies and gentlemen that whenever we are doing something auspicious and something really good, we always pray to the Lord above, right? We express our gratitude for whatever we have today, and we take the blessings of our elders, or we take the blessings of the Lord, whoever we praise to or we believe in the energy of. And similarly, we have amazing minds sitting here today. When I met Dr. Gaurav as well as the team for the very first time for briefing for this event, I was told by them that how important and why exactly we are conducting this event. And this is for the patients who had stroke and they are recovering. And I told him that I can totally relate to what he is saying and the session, because there was a case in my family too. Yes, my mom-in-law had a brain stroke. And I have seen this very closely, how difficult it was for her to remember the names. Instead of calling her son's name, she was calling her brother's name, right? And the movement and all the videos that I have seen today, I was totally able to relate and understand. That's exactly when Dr. Gaurav said, I think you're the right fit for the event, because now you understand how exactly we all are placed together. So thank you very much for having me, Dr. Gaurav. I am totally able to connect, as well as I thank each and every one, all the presenters and the experts here, for taking care of the community and taking care of people. You are amazing. I want to give a big round of applause to all of you on behalf of every individual and families who have been recovered, and you've brought smiles on their faces too. Without any ado or late, I request the following dignitaries to please join me on stage for the inaugural ceremony. As I said, we take the blessings of the Lord above and we ignite a lamp to begin any ceremony, any good thing at home. While the dignitaries on stage will be lighting a lamp by themselves, but every one of us here also can be the part of the same lamp lighting, taking the blessings of the Lord by being in your own places and praying 100%. So please join us, everyone. And firstly, can I please call Dr. U. Singh to please join me, retired professor and HOD, PMR AIMS, Delhi. Put our hands together for the gentleman. I would say the Dhurandhar of this evening. Please be on stage. Alongside, I would like to call Dr. Gaurav Thukral to please join me on stage for lamp lighting. Organizing Chairman, Recovery One 2026, President and Co-Founder, HCAH. Mr. Ankit Goyal, Treasurer, Recovery One 2026, President and Co-Founder, HCAH, to please join us. I would request Dr. Vijay Janagama, Organizing Secretary, Recovery One 2026, Director, Medical Operations and Quality, HCAH. I would also request Mr. Amit Kumar, Joint Secretary, Recovery One 2026, Director, Operations, HCAH, to please join me on stage. I would also request Mr. Rahul Jain, Mr. Amrinder Singh, and Dr. S.L. Yadav ji to please join us on stage, please. Dr. S.L. Yadav is here gracing the stage with us. Professor, Head, PM&R Services at HCAH. Requiring Mr. Rahul Jain as well to please join us on stage. And can I please invite Mr. Sudhir Bell, Chairman, Saroj Hospitals, Delhi, Board Advisor at HCAH, to please grace the stage. While all of them join us on stage, this is what we can do. Thank you. Having said for the fact that we all are lighting the lamp on stage and doing the inaugural ceremony at this point in time, I request the dignitaries to please proceed for lamp lighting with all the positivities in our minds and soul that this is just the first edition of Recovery One, and many such conferences shall happen and you shall be a part of the same. Shubham Kurutvam Kalyanam Arogyam Dhanasampada Shatru Buddhi Vinashaya Deepam Jyotir Namostute. With this, we take one step closer to the utmost power of wisdom and knowledge, and we take an oath that we continue to spread happiness as much as we can. And I'm sure that the ladies and gentlemen who are sitting over here must have abided by what I requested to also pray from your side wherever you are. I request the dignitaries on the dais to please join in a semicircle for a group picture in favor of a photography team. They are the only ones who have the right to say smile, please. Let's strike our hands together for the lamp lighting inaugural ceremony of Recovery One Conference 2026, ladies and gentlemen. Enabling fastest recovery and reducing the avoidable disability. I request all the dignitaries on dais that now you can take your seats, and I would proceed with the next thing on agenda. Setting the context of the event, to present the welcome address, can I please request Mr. Ankit Goyal, Treasurer, Recovery One 2026, President and Co-Founder at HCAH, to join us. Let's put our hands together for him. Sir, I think there's one thing before you address them, let me teach you. So, can we see your hands up in the air? When I say one, can you clap once? One? No, only one time. One. 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 So I thought when I'm saying put your hands together, everyone forgot. So I'll say, can you put one? One. 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 Thank you. Please keep up the energy of the room. Over to Mr. Ankit.
Good afternoon, everyone. On behalf of HCH, it's a great honor and privilege to welcome you all to the inaugural ceremony of Recovery One Conference 2026. I extend my heartfelt welcome to our distinguished faculty, clinicians, rehabilitation experts, hospital leaders, policymakers, industry partners,
who have joined us from across the country. Today, one thought brings all of us together. India has made a remarkable process in saving lives. But the true success of healthcare cannot end at survival alone. It must also be measured by how well people recover, how confidently they return to their families, their work, and their everyday lives. Because recovery is not just a medical process, it is the journey of restoring strength, mobility, independence, and dignity. Across India, while acute and critical care have advanced rapidly, recovery still remains undervalued for millions of patients. Too often, recovery begins only after discharge, when in reality, as all of our experts have said, it should begin alongside treatment. This is the vision behind Recovery One, a platform created to bring together healthcare, technology, innovation, and policy leaders to collectively shape a stronger and more integrated recovery ecosystem for the country. At HCAH, we believe recovery must become an essential pillar of healthcare delivery. Because the future of healthcare will not only depend on how many lives we save, but also how many lives we help rebuild, restore, how many families we restore. We hope this conference sparks meaningful collaborations, stronger policy conversations, new ideas, and actionable solutions that can transform recovery care across the country. I would also like to express my sincere gratitude to all our sponsors, partners, supporters, speakers, and the entire organizing team whose vision, commitment, and tireless efforts have made Recovery One 2026 possible. Thank you all again for being part of this important movement. Wishing everyone a truly insightful and impactful conference ahead. Thank you.
Thank you very much, Mr. Goel. And now for the inaugural address, can I please invite Dr. Gaurav Tukral to join us on stage. Ladies and gentlemen, let's do the 111s.
It is such an honor and privilege to be speaking in front of luminaries like Dr. Yu Singh, Dr. Yadav, Dr. Srivastav, and many, many friends whom I trust them with, that they were just a call away when I invited them for this conference. My senior from my college who's sitting there, Dr. Kaul, and many more, if I would have, time would have permitted. We are standing between the lunch and this function, so I'll keep it short. Can we start the presentation? So this is the motto of this conference. India must build a recovery-first healthcare system. The silent epidemic of post-acute disability and the model that already exists. Star hospitals, acute care has gone out of the sky, latest gadgets, thrombectomy, whatnot, and at discharge, everything breaks. And the patient and the family are left to fend for themselves. 40% of stroke survivors remain severely disabled at 1 month, and less than 2% of Indians get structured rehabilitation. Well, the disability population figures, official figures says around 27 million. There are some factors which say around 90 million, but 69% of India's disability burden is rural. Daily burden has not changed over the years, but what we are seeing is it is now more from non-communicable diseases. And globally what we are seeing is Delhi's years of healthy life lost to premature death and years of disability. From 2010 to 21, disability is taking the larger ground. I am also facing some problem with this, like Dr. Gupta. Can you go back 3 slides? Go back. Yes. So we all know this. We are short of hospital beds, leave aside rehab beds. National policies से बहुत नीचे हैं, but there are only documented 1,250 stroke centers, government and private, for 1.4 billion population. Whereas all the developed nations have integrated rehab and restoration into the acute care. Next. So the global model is acute care, post-acute care, and integrating back into the community, whereas we are working only on the acute care. Next. So what it does, it has clinical implications, prolonged disability, more complications, loss of functional independence, economic. Most of the time, the earning member of the family is not the one who's earning. It leads to so much of economic burden, and definitely sustained household dependencies and caregiver burnout, which leads to social implications. And 3 to 5% of India's GDP gets lost annually to road injuries. Well, we have spent diagnosing the problem. We all are doctors. We always look at solutions and treatments. So India's first hospital network is not a proposal. It exists, it's measured, and it's scaling. Presenting to you HCAH, rehab and recovery hospitals. From centers, now we have gone to hospitals. 7 hospitals across 5 cities, thousands of recoveries, first time NABH and HCAH accredited, thanks to Dr. Rana sitting here. PMR led, thanks to Dr. Yadav, Dr. Abhishek, and Dr. Yu Singh, who has been a guiding force, who led me into that journey, and definitely supported by insurance. Well, the theme of the whole conference is enabling fastest recovery, reducing avoidable disability. And 2 years back, when I started talking to my team, why don't you tell the patient when the patient will recover? Sir, कैसे बता सकते हैं? हमें क्या पता? कुछ complication हो गया तो. And I said, at least start measuring. And that's where, with that initial, so much of, I would say, rebellion, I would say, not even pushback, right? Sir, we can't write that the patient will start walking in this much time. The guy is sitting and smiling in front of me, right? We can't say that the patient will start swallowing in this much time, eating in this much time, the tracheostomy will be in this much time. And I said, we have so much of data, 10 years of data. Let's crunch that data and see what are our timelines. And what we started doing was, we started getting the families participate into recovery by measuring timelines. At the time of admission, we started saying that we will predict the recoveries. We might go wrong. The recovery might happen on time. It might happen delayed. And at that time, everybody is saying, sir, delay ho gaya to family kya bolegi? And I said, you'll have a reason. You'll discuss with the family. And what we realized is that the milestones started achieving before time. And that built the confidence of the team. And over time, if you see 70% of our, so we did a very nice color coding. Everything which is on time, green, aage nikal jao. Everything which is delayed, you need to stop, yellow. And everything which is before time, B for before, B for blue. Blue line. And 70% of our patients started recovering on time or before time. And the delays reduced from 10% to less than 2%. And this all happened just by measuring recovery. And today I proudly say that we are recovering our patients fastest, for that patient at least. For that patient who wants to recover fastest, is able to see a measurable recovery. So what were the ingredients? The ingredients were, as Dr. Abhishek said, intensive therapy. So we have a multidisciplinary team, which I think very few centers or very few hospitals in the country have. We have a full team of PT, OT, RT, ST, CT. And all of them, Dr. Abhishek, when first time I met him, he said, build the team first. Baki sab kuch baad mein ho jayega. So that ingredient, supervision by the physical medicine and rehab experts with the collaborations from neurologists, neurosurgeons, intensivists, pulmonologists, nephrologists, all of them. And then having a mix of long-term care, inpatient rehab facility, and skilled nursing facility, and LTAC. So if an IRF patient gets sick, can go to a LTAC, which is long-term acute care, and if has to stay for a long time and will not recover maybe to the level they should, they can go into an LTAC also. And then, how do we send them home? We have our another vertical of home care, which we started 15 years back, and that led us to train the family and to integrate the patient back into. So all these were ingredients of faster recovery. And then we put in a layer of technology to make it fastest recovery. Robotics-enabled therapy for lower limb, gait, upper limb, balance, visual reality, vital stims, AI-driven personalization, each to his own, and then consistency. And I completely agree with the speakers before me. This was a mix of our experts, our multidisciplinary team, our doctors, and then technology. And letting the family feel so. The first question, how's my patient doing? When will he sit? When will he walk? When will he talk? When will he eat? Building all this transparency through our patient app, which we call Iris, and sending all these milestones in the most transparent manner. And with this, the trust in healthcare, where the Achilles heel is billing everything attached to this app through AI and through our own built software. Next slide, please. Well, we wanted all this to be turned into evidence, because I know doctors in this room will debate fastest kaise bol sakte ho. But then we have a DNA of generating evidence, citing evidence, and publishing evidence. 35 plus citations, 10 plus presentations in national and global conferences. This is the good work being done by my team, led by Dr. Vijay Jangwa, who's also the curator of this conference. Next. And then how do we let the medical community know of what is the good work we are doing? I can't have this conference every month. It's once in a year thing. So what we started doing is, we made these two properties, recovery pearls. So we started sending out our publications and our data to doctors, to all the doctors for whom recovery matters, through these recovery pearls, and also the latest research happening, the latest know-how happening in the world through these Excel sheets. Next. And then, to reach to the consumer, we had 1,000+ mentions in the media of all this evidence, of all these happy stories, of all these recoveries in the last 1 year. So to wind up, I would say this conference aims to integrate, bring post-acute rehabilitation into government schemes. Private insurance will not be able to do everything. Expand, scale rehab infrastructure, target recovery beds alongside acute beds. Strengthen, build the training pipeline for rehabilitation physicians. We have an acute shortage of rehab physicians, and we have the pioneers sitting in front of me. And shift the mindset. Recovery must be prescribed. It just can't be left for people to fend for themselves. It has to be measured, it has to be prioritized. Next. Saving lives is essential, it's not sufficient. The true measure of a healthcare system is its ability to restore function, reduce long-term disability, and return people to independent, productive lives. Recognizing rehabilitation as a fundamental pillar of care is no longer an option, it is urgent. Thank you so much.
Thank you very much, Dr. Gaurav. In a short time, he pointed out correctly who we are, what we do, why us, and why together. And now, ladies and gentlemen, it's an absolute honor for me to introduce you to the stalwart in the field of physical medicine and rehabilitation. I would like to tell you that the gentleman who's going to come up next, with an illustrious medical journey spanning nearly 4 decades at the AIIMS Delhi. He played a pioneering role in shaping rehabilitation medicine and improving the quality of life of countless people. His expertise spans over musculoskeletal rehabilitation, spinal cord injury management. An inspiring teacher, respected leader, he has served as a HOD for more than 22+ years and has mentored generations of rehabilitation specialized across the country. His contribution to the PMR has left an enduring impact on both academia and clinical practice. We are truly honored to have a personality whose work life reflects compassion, innovation, commitment to enabling recovery and restoring dignity through rehabilitation. None other than only one gentleman who has been witnessing every presentation without a blink of an eye, understanding everything through. Please put your hands together for Dr. U. Singh. Sir, manch pe padhare. We would request you to please join us on stage and we would like to hear from you. Over to you, sir.
Thank you so much indeed for such a wonderful introduction. I'm truly humbled. And thank you, HCAH, for inviting me for this wonderful conference. In fact, I was feeling so small waiting until this time with illustrious speakers giving such wonderful presentations to the depth. And I was feeling that I am going to speak very, very basic, maybe below the earth, at the seed level of rehabilitation when I talk about my presentation. So can we have the presentation, please? So going by the theme of the conference, primarily we are looking at the recovery and making the recovery fast. And naturally, we have to understand that to have good recovery, we need to have the early diagnosis and treatment, the primary, secondary prevention, not the primary prevention, secondary prevention. And when we talk of rehab, it's a tertiary prevention. But tertiary prevention, we have to combine with the primary preventions to prevent the complications. Please, let me do this. Let me do this. So we have to restore the functions, and when we have to prevent the complications, we know that we can do an early diagnosis, early treatment with the aid of technology. We can do it fast, but the ride with the preventing complications is a little bumpy. It is full of speed breakers, and we have understood at various levels. It may be at the doctor's level, patient level, family level, government level, and so forth. So to understand what entails rehabilitation and what entails the person, like Dr. Gaurav was just now talking about, and Dr. Cole initially also mentioned, the core of rehabilitation. We have to look at the basics. To understand the disease, we have to look at the basic molecular, biochemical structures. And going further deep into that, Higgs boson, the God particle, that is smaller than the atom. Maybe we'll find something beyond that someday. And we know next comes the atom, and various atoms make the molecules. And various molecules, we also have various kinds of the elements that we say in Hindu mythology that it is made, earth is made of all these four things, even life is made of all these four things. To understand earth having all these things, Earth is part of a galaxy. It's a solar system and various galaxies put together. And we impose that and try and see human being is also made of all these things, number of molecules, number of atoms and things like interacting biochemical things, and we make tissues out of that. And from the tissues we have the various organs and the various regions of the body. And all these things make up a human being, just trying to understand that what all is comprising of a particular human being, what are the functions, where we attack, what system, what molecular level, what tissue level. As doctors, we understand that, but as PMR specialists, we look at the person in the earth, on the earth. And earth is part of a solar system and a part of galaxy. So we think of a Higgs boson at one point of time in the whole universe, and we look at a particular something going wrong, an abnormality, even as small as having a diabetes in the whole universe. If we think that, only then we can understand the true sense of rehabilitation. Because as humans, we don't live in isolation, and we don't also suffer in isolation. We are part of a whole universe, and we have to place that system in that universe to think about recovery and care, which are more or less proportional. The points of view of recovery are different. We basically focus our attention as doctors. And at the most, we think about what the patients would be thinking. We forget about everything else. But in case we place that Higgs boson in the universe, place that single human being in the world, and see what is happening. So we have to look at recovery at all those levels. So we'll talk about this one by one. As doctors, what we see, we basically look at what is the condition, at what level the patient came to us with the kind of presentations, and whatever medical or the surgical interventions we had to do, we do that. And we look at what complications are there at that particular moment and try to treat that. That is the sphere of a doctor, as most of the doctors, leave aside the people in PMR, do. But once the optimal is reached in all this, what is presented to us by the patients, we call it a day. Oh, ghar jao, maze karo. But it doesn't really happen. Many a times, do we really find a cure? No. Many a times it leaves lot many scars, lot many impairments, lot many traumas, which are there for the rest of their lives. And if we look at it from the patient's point of view, the patient may be having a fever, or a bodily issue, or a physical issue, which we mostly look at: pain, fever, weakness, paralysis, some kind of a deformity, some kind of an injury, part of a loss of a part, etc. So that is one part most of the patients see. Some get cured. Then there's a big question mark whether they really get cured. It's only the body which gets affected, or they have lost a part, they have lost it permanently, or whether something else is also being bothered. And we hardly ever look at getting back the functionality which the patient requires to get back into life, to get back into doing what the person was doing previously. And look at the family. The family is primarily giving the care. Somebody falls ill, they come together and they give absolute care to the person, bring them to the hospital. When they go to the family, when they go back to the home, they look after the patient till the time the patient recovers, with the hope that the patient will recover and get back to functionality. And they keep on giving the care till the time the patient gets back into some kind of independent living, which may or may not happen. So till the time the journey of being absolutely sick to getting back, or maybe not, to the functionality level, they give some kind of a care. And whether that care can be continued for the rest of the life in case the recovery doesn't happen fully, the patient doesn't get back to functionality, that's a very big question. So again, it will all depend upon how much cure and at what level. So we have to bring the person back to functionality so that the family recovery, the family can reduce down the intensivity of their presence or their additional care. Now again, coming back to who provides the care to bring the restoration. We have all these people, medical, nursing, we all know, and the person himself who is suffering, the care for himself. And we have to look at how the family is looking after, and when the person gets back into society, gets back into work, gets back to living in the universe, we require the government also, the legislation also. So all this care needs to be important. So looking at the medical or the nursing, we all know very much, mostly it is done in the hospital in the beginning, or maybe continued at home, and maybe beyond. Some people may require occasional medical management, but lifelong nursing care. Some people may require continued nursing care till the time they get back to their functionality. And the doctor's responsibility, of course, does not end when the acute illness is ended or when the surgery is over, when the amputation is done. Everybody knows that's very simple. The person had a stroke and his acute condition is over, he's not having any problem. So the doctor has to think beyond. And the medical care can never be complete till the person with whatever illness or the residual disability is able to live and work with it, whatever is left of him. And the beginning of rehabilitation care is right at the onset of the illness, without making that illness cause a disability, let it be temporary. Excuse me, the reception is calling me again and again. Somebody should be going to them and telling them. Okay. We say that it's important that we don't wait until the patient leaves the hospital bed. Many a times it used to happen in our hospital that the patient with stroke or some other spinal cord injury has been there in neurosurgery or in neurology, and on the day of discharge they say, PMR, come and do rehab, and by the time we go and see the patient in the evening, the patient has already left home and he hardly ever returns back. So that is absolutely not right. Like since the morning we've been saying, rehab intervention right at the time of surgery, right at the time of admission has to begin. So that is the most important thing. Because the late start impedes the maximal restoration. That proof has already been given in the morning. Coming to the patient, caring for the self, that is very important. Because we have to train the patient into being independent in his self-care, which is grooming, eating, dressing, etc. At least the private things. And other activities of daily living is important. And whether the patient becomes independent or the person becomes independent or not, that is a very big thing. So how much independence, what is the level of independence, that is the concern of the patient so that it has to get back into life. Unless we train the patient to get back into life and we half do our job, it will be like lifting a very heavy weight when I am not trained. You ask me to lift 50 kilos, I will collapse and rather have another disability. So care has to be continued and appropriately how much the person has to do himself, how much support is to be given by somebody, and when to withdraw the support by somebody else, then the person can carry on with some devices or with the regained power or the regained training to get back into life. So that is the most important thing. So gradually withdraw the assistance rather than giving the stopping it or absolutely continuing to give the assistance. So it can be the person supervised, as you see the photograph on the left, or the person trying to do everything independently with the aids or things like that. It is very common for us, it has been emphasized that all stroke patients have depression. We have to treat depression. Depression, anxiety, denial, anger, all these things are very common. It causes a lot of stress. And stress affects the adaptation to the new normal as well as reduces down the neuroplasticity. So that also hampers the functional recovery. And there have been studies which say that now we can turn the stress into useful physiological adaptation or activation for recovery. So this is an important thing we have to learn, use the stress for the betterment. And self-care has to be while the patient is in the bed, and the depth of care has to gradually be withdrawn from the level of assistance to absolute assistance, to some assistance, to just supervision. But it doesn't end there. We have seen that in case we do the self-care in the hospital and the patient goes home, he forgets because the environment is different. So I was working in Stoke Mandeville Hospital in Aylesbury, UK, which is a pioneer center for spinal cord injury, and this had halfway homes. Even in the ward, they had acute care ward, like the intensive care, then high dependency, then the doctor visiting every day twice or thrice, and the nurses every 2 hourly, and then the patients who are getting back into rehab and they have learned some bit of self-care and the assistance in case required. Once they are ready to go home with their final achievement, there was a halfway home where the doctors and the nurses will not go unless the patient calls them, so that they get the confidence of living independently. But that itself was not enough, because when they go back home or they go back to work, it becomes very difficult for them to adapt. Whatever they have learned in the hospital or the halfway homes, they think that was a very protected environment. And that environment reduces down further when they go home and find challenges. So an important thing that Stoke Mandeville people used to do was to send people to the patient's home and follow up and see how they are doing. And or have a simulated environment. We used to say, okay, bring the videos, bring the photos, have a diagram, and make your, make the environment as if you are at home or in the office, and how will you fare. Initially, imagine, have a simulation, and then actually go and visit those people. So this is a very important step which we all have to learn to make the person independent. From the family's point of view, the care. We have to give care at all levels. When the patient is in the hospital bed, absolute care. At the same time, they have to pay, they have to look after the patient's psyche as well as their own. They are away from their own work, they are spending extra money. And in India, as we say, tan man dhan se seva is the most important thing people have to do. And we often forget. We remember only the patient. We forget the caregiver. And there have been studies which says a caregiver is a hidden patient there itself. They are getting so much stressed. Like in the neurosurgery, neurosurgeon was speaking in the morning. The day of surgery of the patient, the wife went to watch a movie because she was all the time very much, herself affected by the poor husband in the hospital and looking at the other problems. To make this happen, we have to understand what are the potentials. And we can do that only when we sit down with the patients, have a good communication, being one with the patient and the family, and understand what the patient wants, what the family wants, what are his impairments, and look at the potentials which are there, and then finding means to achieve with our rehab team completely. So the important aspects are, one must have a family support, because unless you have family support, you can't really get back to normalcy. You can't have that. Every step is important. Involve the patients and the family or the caregivers who are primarily going to be with them. Never ever tell them, somebody who is not likely to recover, that you will have so much recovery. Of course, with this much impairment, this is likely to happen, this is mostly which can happen, and this is the max we can achieve. But we don't limit ourselves by saying, this is a max you can achieve. We have to be realistic at the same time, make the patient think beyond. Most of the patients do this, maybe you can go beyond. People have gone right up to Mount Everest with an amputated leg or with paralysis. So give wholesome information so that the patient can also work out what is important. And to understand that, it's very important to understand, put yourself in the patient's shoe and think, if I was having that problem, what will I do, what will I face, and try to suggest that is the best way we can do it. Next point is the societal and the government. We alone can't do it, but collectively we can definitely do it. Previously, the government made an act for the persons with a disability where they said, in case we have means, we should do that, and it was part of a charity. It doesn't remain to be charity anymore. It is not that we don't have funds or we don't have means to do it. It is now a right for the person with disability, and there is a punishment in case we don't let those rights be enjoyed by the person with disability, so we can be sued as doctors also. So we need concerted efforts, but of course individually, we have to bring it to the government and the world that this has to be required. Rehabilitation looks like a big word, but it has a very big purpose as well. So it's very important. So we have to make the person aware of his potential, and we have to provide means of attaining whatever is the maximum. Of course, the aims of restoration everybody knows, but the feeling of being worthy, living a dignified life with a sense of accomplishment is the most important thing in life. So level of recovery will be dependent on the condition, on the will of the patient. It can be just independence to be around the home itself, or maybe doing some recreational activities up to a level which you can't ever imagine. People have been doing so much. And important thing is, I remember one serial by Ali Bakr, that there was a person with a mental disability and the family never exposed that person outside the family. Unless a person understands the disability and accepts it and brings it, without fearing, comes into the open and socializes, that is the important point from the point of view of the patient, as well as the society, to accept that patient as one. So one has to walk along with the others, just like the God particle or a small amputation. The person can think about being integrated into the galaxy, the same person with the amputation being integrated as one into the masses without being ever, I would say, singled out. So it is good that the person himself makes an effort to be part, as if what they would likely do, not having or despite the disability, integrated into the society and doing what anybody with not having those disability would be doing. So one has to do that. So it is very important for the person to be integrated, like the torch bearer here for the Olympics is an amputee and is running with others, normals, in the same stride and being lost in the, I would say lost, that is not pointed out, singled out in the mob, maybe for the sake of some achievement, doing something great is okay, but not being singled out, this person is handicapped. Because it is very important to understand, bring the person back to life is important. And Voltaire, long time ago, said that people who are occupied in the restoration of health, like the doctors, are above the great on the earth. Like we used to say, doctor is like a god. So Voltaire said that. But to preserve and renew is almost as noble as to create. Who is the creator? God. So this emphasizes the role of rehab person, or the rehab is like a godly thing to do. So in case we wish, we can definitely do it, irrespective of what the illness is. And I will not stop here by saying that if we try, we can break all barriers. And those are only mostly in our minds. And I was working in Mahatma Gandhi Hospital, and the emeritus chairperson, Professor Swarnkar, he said when we were having a presentation and the doctor said that this part was very difficult. He said, nothing is difficult. We only have to try in case we have to achieve it. So with that note, I will end here. Thank you very much.
Thank you very much, Dr. Yu Singh. Also, your presentation, your personality truly speaks very dynamism. And on the content that you have delivered, we are highly honored you are here with us. I would require Dr. Gaurav to please join me on stage, along with Dr. Ankit, please to join us on stage to take a moment to thank our guests here today. Can I request Mr. Ankit Goyal to please join us on stage? Yes, both of you are here. And with this honor, I will request the team to present the memento and thank Dr. Yu Singh for joining us today. And thank you for all your support always. Let's put our hands together, ladies and gentlemen. What a moment of sight this is. Indeed, an impeccable one. The moment that we've been waiting for. And please continue to extend your support always. With all the best endeavors, let's present the memento. Thank you very much to all the dignitaries on the stage. And with this, we take a lunch break of half an hour. An important announcement for all our faculty that the faculty lunch is happening at the hall adjacent to the registration desk. All the delegates can please proceed for the lunch too. Faculty lunch is in the adjacent hall, which is near the registration counter. Let's all meet again at 3:30 back in the same hall, please. Everybody. Please join us back 3:30. started with the second half of the session. Let me just check. Are we all again with energy? Or is that only me? All right, so let's transform this energy from my side to yours, okay? Because I don't want only this side of it to be loud and clear. Everyone put your hands up. Hands up, haath upar. Place it tight hai kya? Hands up, come on everyone, hands up, 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 up. Very good. Arre, keep it up, Baba. Look at me, everyone. I'm not even having a mic in my hand. Shake your fingers, shake your hands, everyone. Now, I am the dawn of this place right now. Everyone have to follow me. Hands up, hands down, up, down, hands up, and down, and wider. And the Shah Rukh Khan pose. बैठे हुए हिल जाओ थोड़ा towards on your right side. All right. And now when I say hey, you say ho. All right. Hey. Hey. ऐसा o नहीं. It's not like a कोयल वाला o. It is a proper ho. Hey. You feeling sleepy? Hey. Sir, you yourself also, please. I request you also to participate. I do not want anyone to sleep because we are quickly getting started with the session. Hey. Sir, आप नहीं करेंगे ना सेशन शुरू नहीं करेंगे. Hey, ho, mind absent, body present. Hey, hey, hey. Keep the mobile phone down. Hands up, everyone. Hands up, haath upar. Hey, not ho. It is ho. Hey, hey, hey. Very good. I think that's all today. Enough, jitna crowd hai utne mein hi sahi hai. All right, so my dear friends, it's now time that we get started. 6 chairs. That now we get started with our platinum sponsor, Gen Robotics, to please present their part of presentation. Thank you very much for being our great, great sponsors. With all pride and honor, can I please invite the COO of Gen Robotics, Miss Nisha, on stage. Let's put our hands together for her. I just tried to set some.
Thank you. I appreciate the energy.
Sit down, everyone. The exercise is over.
This side, I think. Yeah.
Bro, check.
It's shared right now. I know everyone's little lethargic after lunch. Thank you so much for giving us this time. Thank you to the sponsors to allowing us this time to introduce Gen Robotics. My name is Nisha. I manage the operations for Gen Robotics. Yeah, I'm so sorry, but there's a technical glitch. The videos, there's a PPT presentation. Okay. So Gen Robotics, just to share our vision, we basically are a robotics research as well as manufacturing organization headquartered out of Kerala, Trivandrum. Our vision is to try and solve problems and using AI as well as robotics to try and find solutions for problems which make human life more dangerous. So our journey, just to give you a quick brief, we started off in 2017. We're a set of actually engineers, as my colleague earlier said, we were a set of engineers who graduated and built an exoskeleton, as you can see, as part of our college robot or college project. Based on that, in 2017, we got the problem of manual scavenging. And we've reached, in India, we've reached the moon, but still, when we look at the manholes and the sewage lines, human beings have to go down and clean. So we found a solution, a robotic innovation called Bandicoot in 2017. I'm very happy to tell you that in India right now, 300 plus robots are deployed across the municipal corporations, and we've tried to eliminate manual scavenging completely. By solving this particular problem, we've then moved on into the medical field. In medical, we're very happy to let you know that we've been able to launch G-Gator in the year 2021, which is again an Indian-made exoskeleton RAGT for neurological rehab primarily. We now, as a company, work in 4 verticals. So we have the clean tech and robotics that we talked about in the sanitation vertical. We have medical and mobility. We have oil and gas, and we have space and defense as well. Just to give you a glimpse of our robots in these different segments, I've added one slide just to quickly give you a brief. So we are into the, again, clean technology. It is manhole-based cleaning robots that we've deployed. There's Bandicoot, there's Wilbur, and there's an entire AI-based system in place so that the municipal corporations can solve manual scavenging. We are also in the defense segment, very, very importantly, working with semi-humanoid robots and humanoid robots. Very importantly, completely made in India, based out of our Palakkad production units. So when we're talking about the medical wing, as you know, a lot of experts are here. The doctors would know that the gait disabilities, one of the major causes of them is stroke, Parkinson's disease, spinal cord injury, cerebral palsy, also TBI. So based on these problems, we have a patient demographic of somewhere close to 15 million patients across the globe that are being affected by stroke as well as spinal cord injuries, just to give you the scale of the problem that we're dealing with. Conventional therapies, as you know, with the barbell, parallelograms, some body weight support is what we've been doing till date. Conventional methods, again, just to give you guys an idea of the problems, I'm sure the experts know, the monitoring of patient improvement is very, very difficult. Like sir was saying, measuring of recovery and measuring of improvements is very, very important, which becomes very difficult in the conventional methodologies. Similarly, there is also a patient safety-based problem that we face when we're doing with the conventional methods. To solve these problems, we have launched in 2021 our own RAGT. It's an exoskeleton RAGT called G-Gator. Just to give you a quick brief, again, it has 3 therapy modes. It has an active, assistive, as well as a passive therapy mode. The exoskeleton is adjustable based on the patient's requirement. We can adjust the exoskeleton. It is, of course, very, very important, like you were talking about, AI-powered exoskeleton and gait pattern that we have, actually, very importantly. I'll give you a little bit more info about it later on. We also have an intelligent spasm detection with the Gator. Yeah, it's immersive VR technology. Again, you know the importance of VR. very importantly, what makes us stand out is the G-plot technology. I'll go a little bit technical now here, the engineering part of it. So we're the only company that builds RAGTs with pneumatics. Most of the other RAGTs in functioning are motor-based. Now, benefits, of course, there will be a debate if I come up with it, but what we can do is definitely it's a lot more flexible, very little noise when we're talking about pneumatics, a lot lighter exoskeleton also for the patients. So those are the benefits of the pneumatic technology. We have, again, the G-plot technology is a patented technology in the name of Gen Robotics. Yeah, so I was talking about AI, very interesting, sir. I think a few of my colleagues earlier did talk about the importance of AI. Now, in the assistive mode, I talked about 3 therapy modes for G-Gator. In the assistive mode, what basically G-Gator does is understands the patient's effort level, and based on the effort level, it again adjusts the robotic effort that needs to be put in. So that's something that we're doing with AI. Again, reporting like sir was talking about, it's very, very important to have detailed reports for the doctors to understand also how well the patient is doing. So we do have detailed reports in terms of the effort that the patient is putting, their range of motion, their improvement over a period of time. We also have a pediatric version of G-Gator, which again with immersive technology for the children to get along and start walking on their own. Motivational elements are there. A few of the Gate VR-based games that we have. Now again, with Gator, the 3rd version that we have in place is actually the G-Gator Advanced. G-Gator Advanced, again, is the only RAGT which actually allows for adult as well as pediatric patients to get therapy in the same module without any change of the exoskeleton. A lot of the robots that you see require some changes in the exoskeleton for it to, adjust to the pediatric measurements. But G-Gator Advanced is something that allows for both patients to be handled in the same exoskeleton. Yeah, that's the feature that I was talking about primarily. We have a clinical study published also, yeah. So it's telling me that very little time, so I'll try and move on. So there's a clinical study that talks about stroke patients and the improvement in stroke patients. Very proud to tell you that we've been able to do 7.5 million robotic steps over the past couple of years, 10,000 plus sessions, 16 plus installations, including HCAH, AIMS, Nagpur now. So we're very, very proud to be able to solve this problem with a made in India product, yeah. This is just a few of our clients and a very good word that we've received from them. A few, very, very importantly, a few of the good words that we received from our patients. This is from a patient in GH, actually. Again, very honestly, we try to make robotics solutions in India for the world and for all across India as well. So thank you so much. I think I'll leave you with a short video, if you allow me. Time, literally 2 minutes. Okay. Thank you so much in that case. Thank you so much.
Thank you, Ms. Nishra, for the interesting presentation. And we are also extremely proud of you. Let's hear it for Gen Robotics and Ms. Nishra, everyone. And now we move to the next segment, and that is the panel discussion, an interesting one, where the topic says policy and accreditation from proof of concept to system-wide commitment, ensuring standards for recovery excellence across hospitals, government, and insurers. Proudly inviting the moderator of this panel, Dr. Gaurav Thukral. Put your hands together. And the panelists join us one by one. Dr. Vikram Agarwal, Vice President and Facility Director, Fortis Escorts Hospital. Dr. Pavan Kumar, CEO, Care Group of Hospitals, Hyderabad. Dr. Vishal Telyani to please join us. Put your hands together, ladies and gentlemen. Dr. B.K. Rana, CEO, QAI, NCR. Please put your hands together. Dr. Suparna Gangopadhyay, Director, Department of Neuro Rehabilitation, Dr. P. Kishan, IMA, State President, Telangana, and Ms. Priya Deshmukh, Head, Health Products, Operations and Services. All right. Dr. Saurabh, sir, please join us on stage. Ladies and gentlemen, post-lunch session has to be quite interesting. And to make it interesting, can we all put our hands together louder and clear and show that you are present here? Body, mind, both are present. Thank you. And over to Dr. Gaurav for the session.
Thank you, Jyoti. This is a very, very specially curated panel discussion. 5 years of being into rehab and recovery, post we joined hands with Suvitas, Dr. Vijay. There are many questions which came up, and I thought, why not to get all my friends, mentors, guides, industry people, right, to discuss all this thing in a very free and frank manner. So let me introduce this very, very, as I said, specially curated panel. And I know them very, very, all of them very personally. So I'm not going to introduce them in a very official manner, right? Jyoti has already done that. So I have with me Dr. Vikram. Dr. Vikram is a trained cardiac anesthesiologist turned hospital administrator. And he runs the flagship hospital of Fortis Escorts, where when we, Fortis, when we बोलता हूँ कि I'm ex-Fortis, right? When we took over, it was one of the most prestigious hospitals and still is. Managing that hospital is not an easy job, and he's doing that perfectly. So he represents the hospital industry. Welcome, Dr. Vikram.
So much. Thank you so much, Dr. Gaurav.
Next, I have Dr. Vishal Tehliani. कल मैंने फ़ोन किया, सर पैनल पे आ जाओगे? And ये सर है हमारे क्योंकि he's 5 years senior to me in college. A very unique doctor. Did his MD, and उसके बाद इनको चस्का लग गया टेक्नोलॉजी का और ये IT में चले गए. इन्होंने HCL में काम किया. He has worked across the globe. और जो ये जो jargon बोलते हैं, which is both medical and techno, मेरे तो सब ऊपर से निकल जाता है. And आज के दिन में AI पे बोलने के लिए in a medical conference, I could not have a better panelist. Welcome, Tehliani, sir.
Thank you.
And then I have jet setter B.K. Rana, sir. पराग से गए कायरो, कायरो से सीधे लैंड किए हैदराबाद, बीमार चल रहे हैं, and still he is such a great person, such a devoted person that 15 years back when we started home healthcare in the country and he started QI as the founding CEO of QI, एक फोरम में मिले हम, फिक्की की एक मीटिंग में हम मिले एंड मैंने कहा सर ये NABH वाले ना होम केयर के स्टैंडर्ड्स नहीं बना रहे. तो इन्होंने कहा कि अच्छा ऐसी बात है, चलो हम बना देते हैं. You won't believe in the next 3 months, he put me as a chair of the technical committee. We had the standards ready. And in the 6 months, we were the first organization to get accredited with QI. And today, QI has 23 standards, right from stroke to ambulances, to hospitals, to post-rehab, home care. And now he's telling me कि headache clinics पे भी एक standards बना रहे हैं. तो मैं तो बोलता हूँ जब भी कोई नया स्टैंडर्ड बनाना हो सुबह बता दो राणा सर को, शाम तक बन जाएगा. That's his speed. And then I have a very young and dynamic Suparno sir. I love his dressing sense. He has created history in the city of Kolkata, where in Institute of Neurology and Neurosciences, Kolkata, he started the department of PR, where he truly demonstrates a multidisciplinary approach. When I first met him, he was so proud of his team. आपको पता है मेरे पास इतने फिजियोथेरेपिस्ट हैं, इतने स्पीच थेरेपिस्ट हैं, इतने ऑक्यूपेशनल थेरेपिस्ट हैं, and I was like, wow, somebody is speaking my language. And he's the one who believes in outcomes. And today he's representing Indian Association of Physical Medicine and Rehab. He's represented from the IPMR, which is our support association. Thank you for coming, Dr. Pudna. And I have another very, very unique personality, जो कि मुझे अभी थोड़ी देर पहले पता चला. Dr. P. Kishan, he represents IMA Telangana. He's the president of IMA Telangana. But he's a psychiatrist who has combined psychiatry with spirituality.
So sir, आपने आज मुझे बताया कि you are a very spiritual person and you work in wellness psychiatry, but I am going to ask you very difficult questions. Welcome, sir. And then I have my very dear friend Saurabh Lal, who has recently joined KIMS Secunderabad as the Chief Operating Officer. I have known Saurabh also for I think a decade and a half when we just started HCH. He has grown up the ranks through Max Healthcare, multiple hospitals of Max, was the director of Marengo Asia Hospitals, and now I'm so proud of him that he's come to the city of Hyderabad to take this city to the next level. Welcome, Saurabh. So I think बहुत सारे facts हमने करे हैं, and all those facts just lead to one thing, that rehabilitation is very, very fragmented. कब शुरू करना है, किसको शुरू करना है, कहाँ करना है, कितना करना है, डॉक्टर का क्या रोल है, इंडस्ट्री का क्या रोल है, एक्रेडिटेशन का क्या रोल है, गवर्नमेंट का क्या रोल है, पेयर का क्या रोल है. All these questions are unanswered. And today, this panel is going to answer some very, very difficult questions. So my first question is to Dr. Vikram. Sir, आपके पास best robotic surgery के devices हैं, best surgeons हैं, best ICUs हैं, best doctors हैं, best nurses हैं, acute care में सब कुछ solve कर दिया आपने. JC accredited हो आप. But my question is, from a hospital operation standpoint, where does this disconnect that the recovery does not begin with the discharge of a patient at the hospital? Ye disconnect, from where does this emerge?
So first of all, Dr. Gaurav, thanks for inviting me here. It has been a wonderful conference since morning, and the type of energy which we have seen in all the participants and all the esteemed personalities whom you have gotten here is really wonderful. And I believe what HCH is doing to the, not to the patients now alone, I mean they cannot be the patients, they are part, they're in that part of the journey where they're transitioning from being a patient to again a fruitful member of the family or a fruitful member of the society, is huge. Why? Because this has always been an unmet need, a need which was never explicitly stated by either the patient or the doctors or us, the providers or the payers. So now with I would say, with prosperity coming in, Indian economy growing, people becoming more aware, of course, IT is playing a part. So home healthcare, transitioning of acute care to recovery, and such components are actually becoming important for such set of patients. Coming to the hospitals, you know, hospital as a set or as a environment is there for acute care, right? We get the patients, so a patient is coming to us with, say, a heart attack or a person who needs stents or a person who needs a tumor surgery. Please understand, my whole system is attuned to making him correct or to correct his body for that particular disease or that particular flaw in the body. Let's call it a flaw in the body. So we'll put a stent, the coronaries will be opened, and the patient will go back home. If it's a tumor, we'll remove the tumor, full or partial, and the patient will go back home, right? Our job is done, doctor's job is done, nurse's job is done, system's job is done, but till a point. What happens beyond that point is where it's the need of the hour, and that need of the hour is taken care of by HCH along with the family. Till now, I believe this need was never in the forefront, or it was there, but it was never, I mean, people are not made aware of that. Now is the time when satisfaction has become important, and since satisfaction is coming, productivity has become important, efficiency has become important, people are living long, and they want to have a productive life. So if they want to have a productive life, they need to get on their feet as soon as possible. This cannot be done in the hospital, right? By simple, there are other patients waiting to come in the hospital, right? And yes, you raised an important point, which is about the payer. So all the payers are just taking care till a part when there are patients in the hospital. I believe that is something which needs to be solved, and that is what will further pull in the plugs in this puzzle and help solve it.
Thank you, Dr. Vikram. I absolutely agree. I have been part of your journey, and as a hospital director, हमारा सबसे बड़ा endeavor ही होता था कि बाहर जो patient wait कर रहे हैं, अंदर कैसे आएंगे. और discharge planning was कि तुम ठीक ठाक बस इतना सीख के घर चले जाओ. I think over the time, and our medical schools also never taught us that there is a restorative care or a rehabilitation care. So the whole system is driven for acute care, for episodic care, and that's where the integration of care pathways of rehabilitation makes a lot of sense. I'll go to Dr. Suparno from here. So Dr. Suparno, I met a physiatrist from Canada, right, in the recent WFNR, and he said that we have integrated rehabilitation from ICU to discharge through the physiatrist. So there is a physiatrist consult which happens in the acute care hospital, which decides that where the patient will go, whether at home or whether to IRF or whether to SNF, and that's how the restorative care is happening. But you representing IPMR, my biggest problem is that we have a few hundred physiatrists in this country. What do you think that how we are going to cope up with this growing population, this disability burden, and how we are going to create more and more physiatrists which integrate into the acute care pathways?
First of all, thank you, Dr. Gaurav and HCAH for inviting me to this lovely conference. Lots of speakers from the morning, and everything was very focused, and to be honest, I've learned quite a bit from every one of you, and I hope I'll be able to integrate that into my practice as well. So now, in terms of rehabilitation setup, we always need to know that the rehab doesn't just start from the chronic phase. It should start from the acute phase, and there are lots of evidence backing that. So acute neuro rehab is something which should start from the ventilatory phase. Now, in terms of a PMS specialist like us, it's actually a team effort where we have physiotherapists, occupational therapists, speeches, rehab psychologists, medical social workers, rehab nursing staff, orthotists and prosthetists. But what I think our role as a PMR specialist or a physiatrist is basically a Zubin Mehta of this orchestra, because this is an orchestra. And any part of that orchestra which is not in tune, the patient suffers. Now, there are lots of things that a PMR specialist can do. First of all, the main job of us is to set a goal. Goal setting is so important in rehab. It has to be immediate goal setting, short term and long term. And now extrapolating that, it should be from IBR to CBR. So it's basically an institutional based rehab through transitional care and community based rehab. Now, we as a physiatrist should be taking care of this whole thing. Our job is to find the exact goal and let the therapists and the rest of the team implement that. Now, IPMR, because I'm representing IPMR and Dr. Jadhav is here as well. He has been a very senior physiatrist. I would say, well, there are thorns and that there have to be roses for that as well. Now, in terms of thorns, still PMR is still not integrated into the UG course. And I think over the years, PMR has taken a stand, IPMR has taken a stand to take it forward. I am sure that will be integrated soon. Because that is probably a very important step towards making us aware. Now, just a short background of myself. I used to be a gynecologist. I did my DGO, I did my DNB in OG. Then I switched over to PMR. Why? I still remember when I used to do my DNB, there used to be a small physiotherapy unit at one of the hospitals. And then these patients whom we delivered, their mothers used to come down, and few of them used to come with developmental anomalies. Now, they used to do physiotherapy, which is a part of PMR. It's not just PMR. So, it intrigued me that this guy or this kid has a few muscle problems, but what happens to their speech problems, their swallowing problems, their functionality? So here actually the role of a PMR is very important. Now, if this is not met, two things. One is an immense burden on the family members, society, and at the end, it's a socio-economic burden on the country as well. With the advancement of medical and surgical treatment, the treatment has improved, survival has improved, but has the recovery improved? I don't think so. I still don't think so. Like, if we compare with the Western countries, I don't think we are much behind the Western countries in terms of improvement in functionality. So, like as Dr. Gaurav was asking, the only answer to my question would be that representing IIPMR, I would definitely look forward to see that there are more PMR doctors getting inducted into the system, good rehabilitation, multidisciplinary rehabilitation centers with proper documentations, validated and structured programs, integrating both man and machine so that the marriage lasts long.
Thank you, Dr. Suparna. That makes a lot of sense. I think the journey has started, और एक बार शुरू हो गए तो कहीं ना कहीं तो पहुंच ही जाएंगे. My next question is to Dr. P. Kishan. Dr. P. Kishan, you are representing the largest association of doctors, right? And for doctors, as Dr. Suparna said, that rehab is equivalent to physiotherapy. But the problem is even more. Why rehabilitation is still not routinely being prescribed in India? And what do you think policy, insurance and physician behavior changes are needed कि prescription के अंदर ही आए कि now you need to be referred to a PMR because now you need rehabilitation?
Yeah, I think the question itself having multi dimensions in that. First of all, I'm the president of Indian Medical Association of Telangana, and a part of Indian Medical Association National. We are having 4,20,000 members, doctors, as of now, which is the world's biggest association, NGO. The problem here, present position of the medical society, we are producing 1 lakh doctors per year now. At the whole doctors in India is 15 to around 16 lakh doctors are there in India. Including some of the other all medical professionals. This now the old phase when Indian Medical Association formed in Calcutta in it is a centenary year of Indian Medical Association. It is 232 members there by B.C. Roy. So now almost 4,20,000 members are there. 4,20,000 members died, our own members. So this is a situation where the first phase of our freedom, how to increase the lifespan, that was the concentration of our health services. It's not the recovery and all these things. How to improve, how to prevent the communicable diseases, how to prevent cholera. That is over. Now we are having very good manpower, very good health system, and advanced care, and lot of cities are now, Hyderabad is a hub of medical tourism, including wellness tourism. It's a part of, we are getting lot of dollars in Hyderabad. So this is the stage where we are now thinking about the recovery, wellness, and quality of life, and wise living. Whether, and the people, I'm very lucky to come to here, thanks to Gaurav. On 20th, I'm presenting my experience since last 18 years of my wellness clinic. I'm a psychiatrist, my both sons are psychiatrists, I'm having 2 psychiatrists at Karimnagar. I'm having 81,000 patient database with me. I'm presenting wellness therapies of, which is, there are psychological wellness and well-beingness and all the things that I am going to present on 20th afternoon session of American Psychiatric Class in San Francisco. Last year they invited me for in Los Angeles that wellness of physicians. I think they was impressed with that presentation. They asked me for 90 minutes presentation now. So here what is happening, we are recovery model. First there is a first wellness clinic started by Trevor, so in California. We are treating the patient. Whenever a patient comes, we have diagnosis, diagnostic formulation, and management and prognosis. This is the way a doctor approaches the patient. So where first, in the first day itself, when during formulation itself, whether patient illness, how to treat, how to make him normal. That is the concentration of whole health system, whether maybe private or public sector. After normalcy, you are not talking about the wellness view. Illness, wellness continuum. There's a dimension of wellness and illness continuum, and you have to start formulation at the time when the patient enters into a chamber or the system. You have to formulation in such a way that diagnostic formulation and therapeutic formulation, as well as the how to make him a well-being. Because the definition of health itself a well-beingness, we defined it. Whether our health whole system is to make individuals to well-being or not. So that's it, that planning itself, formulation itself, to treat, make him normal, after normalcy, complete recovery, then preventive things, and reintegration, rehabilitation to society, and whether the quality of life, their emotional IQ, and social IQ, social dimension of health, physical dimension of health, psychological dimension, and spiritual dimension of health. SQ, social, spiritual quotient, and social quotient, everything, whether you are working in that. I think I want to expand this model, what is presented today, discussed, to little higher level. Whether you are taking a human being to wise or otherwise. You have to do. There is a model of Dilip Jaste, American Psychiatric Society president, who migrated from Bombay to Hyderabad, and he produced tons of literature on well-beingness. He developed a lot of literature on wisdom science, how to live wisely, successful aging. Even aging should be successful. And doctor community should see that every human being, not only illness, prevention, wellness, reintegration, and rehabilitation, and making them to live long with good quality of life, not giving an age also.
Absolutely.
It should not be a burden to the globe. So this is the modules are coming up, and I think now we are in correct position in manpower, advancement of sciences. Now our whole Indian module, because we are floating ourselves as world gurus. Now Modi, present government, Indian Meditation Day came, Yoga Day came. Now we produced with the help of the NIMHANS, National Institute of Mental Health. Science of Yoga we produced, Science of Wellness we produced lot of modules for each thing.
Definitely.
And meditation science is coming with how to utilize all these sciences in rehabilitation sciences, not only physical, mental, psychologically, even spiritual, whether he is having satisfaction of life for himself and whether he is connected with the world or not.
Absolutely, sir.
Thank you.
Thanks
Thank
for
you.
that very, very comprehensive picture, sir. Rana, sir.
Yes, boss.
You are the doyen of quality, not in India, but
I'm a
over the
kid.
world.
I'm a
right?
student of quality.
Yeah, that you always say. So the question to you is that most of the accreditations today, they evaluate hospital infrastructures or physical buildings, documentations, compliances. But increasingly, the global healthcare quality is being linked to patient outcomes, measurable patient outcomes. Do you believe India is now ready for that?
Thank you, Gaurav. Thank you. An apology for my sleeping voice. Thank you for having me here. Very dangerous questions you ask, because I will be pleasing one community and displeasing the another one within the healthcare system. As they say, there are two India, one is Bharat. Healthcare also have two healthcare. One is which has advanced and one is evolving. And it will always be like that. You can't have everyone together at the same platform with using robotics. No, everyone cannot in India or anywhere in the world for that matter. So when you talk about accreditation, as you says, and hospitals going for any systems, so there are three pillars of accreditation: structures, processes, and outcomes. So outcome is very much one of the strong pillar of accreditation. But in last 20 years in India of accreditation existence, and about close to now 80 years in globally, very few hospitals, very few systems has gone towards outcome measurement. So most of the processes in accreditation and most of the accreditation bodies globally, including India, they are based on structures and processes. We have not gone towards outcomes. So it's globally, it's not just India. So we are not lagging behind, but yes, we are behind because we started too late. When US started, North America started in 1955, we started in 2005. So we are already late at that time, so it'll take times to catch up. But nothing to dishearten for that, because still we are able to catch up. And the moment we think about what we are doing in India, and as you see, including me since morning, thanks to you and your team for bringing this recovery one conference, bringing a lot of experts together of different specializations. So I think there are many hospitals which are still lacking the structures, the basic fundamental structures which are required by way of law through clinical establishment act. I think so many hospitals lacking structures. And then obviously processes. So outcomes are very difficult, but we started going towards that measurements of outcomes in a small way. And I think in time to come, we should be focusing more on outcomes. And as you mentioned, the payment system, the insurance companies started talking about it very strongly. It's like pay for performance. So when you say pay for performance, it's not performance that how many patients you get, but is how many patients you get up right and make them well. The performance is going to be measured. So I think we are slowly moving towards that, and I'm hopeful with the second healthcare system, which is India of healthcare system, perhaps would be doing its best to reach to that level. And globally, whether it talks about North America or Europe, I think most of the health systems, not even facilities, the health systems are struggling with that. NHS for that matter in UK, that how to really measure outcomes, because there are different perceptions. And that's why we started looking at patient-reported outcome measures, prompts they call. Very difficult. Patient-reported experience measures. It's not just a feedback, which you have a tablet and you say, can you give you feedback? 4 smile, 5 smile, like that. It's not, it's beyond how the patient during the stay feels and communicate, which really helps hospitals to really work on to improve. So, and though physical comfort and clinical comfort do a different thing. A 5-star hospital may not offer a good clinical outcome compared to a 3-star. So I think physical facilities does matter, but how clinical protocols put in place are really more important for the better outcomes for the patient. So I think we are moving, but we are quite far for that measurement things. Thank you.
The beginning has already happened.
Beginning started, yes.
Coming to Vishal sir, my Revit senior, so sir ने बात करी structure, process, and then outcomes. And I think AI has a very big role to streamline, standardize processes, and then to calculate over the data and work over it. At HCAH, I'm very proud to say that our technology team led by my co-founder Ankit and Amrinder, we have actually done a lot of work in automating the processes using AI to crunch the data. In the morning, what I was showing, that we are now able to build recoveries and outcomes and measure them. So sir, being in a very unique position that you are a doctor, right? And then you have excelled in various courses in AI. My question to you is that globally rehabilitation is now entering an AI-enabled era, where predictive analytics, remote monitoring, digital biomarkers, intelligent recovery pathways are the norm. From your perspective, how can AI help India build faster, more standardized and outcome-driven recovery?
First of all, thanks Gaurav for inviting me. Thanks HCAH. And it has been a great learning since morning. I've been listening to all the discussions. And I was thinking that how technology and AI connects to all the paths, everything. If we take it as an enabler, we will understand very easily. Starting from your preventive care, early detection, acute care we discussed in detail, monitoring the care, outcome of the care as we call it in US, value-based care, the outcome-based care, then rehab, and then even continuous improvement. So everything can be switched together using technology. And when I say technology, it also includes AI. Now, if specific to AI, a lot of work is being done, starting from early detection. I have been working closely with devices where they are working and using AI for early detection, acute care monitoring, and then there are devices which are related to rehab, how the improvement is being done. But saying so, still in AI, it's just the starting. We have to understand some basics that AI is not a magic. AI is basically maths. It's basically maths, algorithms, and data, which helps you to create your logic. And currently, what we are using is completely that data is based on US healthcare, US patients. In India, we don't have much data on which we have created models. So many things are there which we have to work on. And as you said, India, there's a lot of work being done in India. Even Indian government has come up with several projects like Bodhi, where we have the data available specific to Indian population. Then we have Sahi, we have AI platform by by Indian government on healthcare. And then we have e-Sanjeevani, telemedicine concept. So a lot of data is now coming into the database for us to work on. You have to understand one thing, when we talk about AI, the most important thing is data, and that data has to be standardized. In India, that's a big challenge because we do not capture data. Even if we capture, it's not standardized. I have worked with Fortis, I have worked in Indian healthcare. The only data which I was able to get was billing data.
That has to be accurate.
So people are only interested in billing data, and that is all what I get when I go to hospitals to create any AI system. So a lot of work has to be done, standardization has to be there. There are startups working on it, but we need to take some initiatives. And coming to rehab, rehab and acute care, there's a huge difference, what we have been discussing. Acute care is time bound. Rehab, you don't know, right? And rehab is very specific, personalized. You don't know which patient is going to improve in how many days, how he is going to perform. That is where I see the role of AI. Yes. You can personalize the healthcare for that particular patient based on his performance, fatigue levels, and other things. You can program your model, which will learn and create tasks based on that. So that is where some startups are working. It's a very interesting space. But again, we need data, we need standards, and I see a huge potential. But we need to take some steps, like I personally feel we should have committees, we should have something like AI-driven rehab committee, or which has to set up standards. At this moment, we don't have any standards in AI. So we have to understand data security is a big challenge. Now in India, we have DPDP Act, which is something like HIPAA in US. but still the implementation is at a very, very basic level. Penalties are high, but people are not aware of that.
Absolutely.
All that awareness and lot of data initiatives have to go in, but I see a huge potential.
Thank you for that ray of hope, sir. I am always remembered of this example that Indians are known to leapfrog. अमेरिका में, यूरोप में लैंडलाइन सब जगह पहुंचा. इंडिया में लैंडलाइन इससे पहले पहुंचता जियो बन गया और सब जगह जियो पहुंच गया. So we know how to innovate. हमें जुगाड़ आता है. And I think people sitting in this panel in this hall, you have enough experts to create these committees, and we can leapfrog. So I go to my dear friend Dr. Saurav. So Dr. Saurav, you yesterday only told me that now you lead a 1,000-bed hospital. Now, given the large hospital systems which people are like you are leading, you are under constant pressure. Occupancy, ARPOB, ALOS, operational efficiencies, manpower challenges. Now, in that environment, do you believe that the large hospitals should build the entire rehab or recovery ecosystem internally, or they should partner with somebody who can do that in partnership with these large hospitals?
Thanks, Dr. Gaurav. So I think, first of all, changing gears towards efficiency and numbers, I think it's a complete antithesis for a large hospital like ours to really look at rehab. You know, that's a blanket statement. And why I say that is that we have a constant pressure of ALOS. Our intent is to move the patient out as soon as we can. I was doing a little bit of a study, not really published data, but practically the useful days of a patient in a hospital are the first 1.5 days, specifically if I talk about a surgical patient. So anything beyond 1.5 days eventually starts coming to the hospital as a loss.
Absolutely.
And I think expecting a hospital, a tertiary quaternary care hospital, to really do effective rehab is like judging a fish on its capability to climb a tree. So it's a complete antithesis. I believe that the only way for large organizations to do effective rehabs is to have a separate SBU. And as we all talk about a lot of services which are out of hospital services, I personally believe rehab is an out of hospital service. Rehab does not treat patients. The patients get discharged and then go into a rehab center. They are no longer patients. They've recovered, at least medically or surgically recovered, and they move into a setup where it is a facilitation towards normalcy or normal health. The huge lacuna that I see in today's hospital systems and the rehab models is that there is a huge void between transition, or rather, facilitation from hospital-based care to out-of-hospital care. And that transition has a huge gap where patients leak through. So today, if I talk of any hospital system, most hospitals build in very basic rehab setups only to ensure that the patient at a discharge from a hospital and entry into a rehab center is facilitated, so that rehab is not really a rehab, it's really a bridge between the hospital and the rehab center. My belief is that, like in a relay race, when one person is passing the baton to the other person, they don't just pass the baton, they pass the baton and run for a distance together, and then the first runner leaves the baton and the second one goes away. I think that is the lacuna. There is no overlap in hospital services and rehab services, wherein rehab services need to start getting impregnated into the systems. And I was talking to somebody the other day in the hospital, and I was saying, why does rehab start after discharge? In my opinion, the rehab teams, internal or external, should actually start before discharge, where a hand-holding of the discharge process happens. There is a trust that is built with the patient, and eventually there is a seamless transfer of a patient from a hospital to an out-of-hospital service. So in my opinion, when I talk about the patient services side, it is a huge advantage if I'm able to build this kind of a transition. On the financial side, on the revenue P&L side, it makes complete sense to dissociate out-of-hospital services and in-hospital services. And if I talk of efficiency, the kind of metrics that me and Dr. Vikram, I think we are the only people on the panel working on those metrics, the kind of metrics we work on, we need to understand the antithesis of running out of hospital services within a hospital, because eventually that balance can never be struck. So I think my 2 cents is that the only way of running, if a hospital wants to run out of hospital services, the only way of doing that is either to have an SBU or to have an efficient partner who can kind of take that responsibility, but it has to be a seamless transfer from the hospital outwards.
Thank you, Saurabh. That was very, very well said. And there is one more economic fact that the readmissions which happen because of the lack of recovery, they also hit the brand and the economies of the hospitals. So given that we are constrained with time and our next speakers have to catch flights also, we will quickly wrap up this panel discussion. And I would have one last statement from each of the panelists. Dr. Vikram.
So more than a statement, I'll like to leave with some questions. So one, the recovery part for healthcare should not be integrated while the patient is in the acute care. It should be inbuilt in the clinician's mind, in the patient's mind. Awareness should be made when the patient is coming for the first time in the OPD for the discussion of a disease. Unless that happens and is discussed with the family, presenting it only in the acute care will not be the answer. 2, please understand, I lead a hospital which is a multi-specialty hospital with special interests in cardiac sciences. So since morning, we are discussing about the recovery mode only in neuro patients. Why only neuro? Why is this conference veering only towards neurology and neurosciences? Are the patients who are there in other specialties coming out ready, fit to run and do their jobs? No, there are transplant patients. I mean, I'm just coming out with certain high-risk patients who come out of operations. There's a heart, a liver, a lung, a kidney transplant. They may be going home, they need home care, but there can be a transition of recovery for them also. So how are we planning the recovery for such category of patients? And 3, which is a general question to everyone. See, please understand, a lot of our patients now today either have insurances or many have government panels also. So, and it's coming very slowly. So I think we need to expedite the way insurance companies and the panels look at out of hospital care, the recovery part, so that the end result is more beautiful and it is more productive. So how can we do that? This needs a deeper look by all of us.
Very, very well said. Just to give you comfort, our next session is on a multi-specialty intensive forum, right? We are moving away from neurology and neurosciences. And definitively, Dr. Vikram, over the last 2 years, we have now seen that 30% of our patients are being funded by insurance. So the beginning has already begun. Dr. Vishal Delian.
Yeah, coming to IT and technology, I would say that there's a huge potential. We need to work closely on that. But the most important thing which I see still missing is technology is only controlled by people from technology and BTech background, not from healthcare background. So I need people, because when we talk about AI, it's all about domain and the model. So domain has to step in. Talking about rehab, acute care, we need to have people to design the models specific to India and healthcare needs. And I think that can bring in a huge change. And the other important thing is that technology and AI are enablers. They cannot replace you. Always remember, there is a discussion that AI will replace doctors, AI will replace this. No, it will enable you and it will help you to get more patients and with a better outcome and track that outcome and all that.
Thank you, sir. Dr. B. Kirana, sir.
Thank you. I think one thing is I would like to share with you. There are ISO standard, ISO 42001 for artificial intelligence management system, which the developer and user can use for standardizing things. Number 2 is about, thanks Gaurav and HCAH bringing this conference. And I have been personally, and QI has been in endeavor that we should provide standards for every type of healthcare facility. What we believe in is, if there is no care continuum which is complete, from start to finish, you won't get the patient outcome better. So at QI, we have developed standards which completes pre-hospital, hospital, and post-hospital care, including recovery centers, transition care centers we developed, and SCS was one of the first to get accredited. So we have sets of standards, but the important thing is the users. Do you use them? So But again, one of the question is creating awareness around it. So I must compliment you and your team for creating awareness through this conference about the importance of care continuum, and also the post-discharge, like my colleagues mentioned, is important. So I usually say is that you may be the best hospital in the world, but you may not achieve the best outcome of the patient if patient do not reach in best time, on best conditions. Somebody has a stroke, not taken time, or during the transport, not given what the need to be given. Reaches hospital, you may not get best outcome despite you're the best in the world. And after discharge, you're the best surgeon, best surgery, but not the best outcome because post-operative is not taken care of. So I think is pre-hospital, hospital, and post-hospital care continuum need to be completed. And last comment, as you mentioned, is I believe in saying self-regulation. We have regulation in India, but very limited in healthcare. So I believe in self-regulation, use of standards and accreditation as a tool to self-regulate you to provide the best outcome to your patients. Thank you.
Thank you, Dr. Rana. Dr. Subarno?
Yeah, so my take-home messages would be, number one, what I think that rehab is, like over the last few years, and I think in the next years to come, it won't be a luxury. It has become a necessity. Now, that we understand, but the main thing is that I would definitely want the help through IPMR so that like in the recent future we have a standardized, validated national rehab health policy, because rehab is, it has to be a part of the whole medical system. It shouldn't be just an add-on. It's not a value addition. It is as important as any medical science, medical professions, and it should be a pillar of our health system. So I think this is probably something which we need to look into, and definitely at the end of the day, there's a lot of talk about AI and all. One thing which I understand is AI is never going to replace doctors or the health system. But again, at the end of the day, as one of the panelists were mentioning, that the AI is data driven. So again, that data has to be standardized to have the proper benefit. My last take-home message would be, there has to be man and machine working hand in hand. Thank you.
Thank you, Dr. Subarno. Dr. Kishan?
First of all, I want to congratulate Gaurav, and I wish to travel with you with all courage what you started this area of work. First of all, my opinion is, we have to not only improve the modules and research and measuring the results. Unless you quantify whatever the subjective we feel, it should be objectified and it should scalable. Results should show, then only the insurance services, the insurance people will accept it. That is one thing. Then even the institutionalization, developing modules, sharing the experience internationally, and Royal College is doing a lot of work, George Washington University, even California, all people are doing this area work. Already they are well in advance. So the East and West has to come together for read it, and central government is now pouring dollars in the research, and now present government as well as the state, Telangana state is now started integrating the services available, primary, secondary, tertiary. Like that, the people are now evolving, the health systems are evolving. This is a correct time where the artificial intelligence as well as the machine learning, all these coming to better planning, better research modules, better outcomes. This can be interpreted for human excellence and the quality of life. All these things can be measurable. Then the insurance people will convince, as well as the dollars, international investors will come and pour the dollars into this area of business. It may be business, it may be investment for a better human living. And this, I think we are in that crossroads. And again, I'm congratulating you for initiating this type of thing. Well, let us continue this mission. Thank you.
Thank you, sir. Dr. Saurabh?
Yeah, thanks. So while most of the grassroots stuff and the granular stuff has been mentioned, I just want to say that there is a cultural shift that is required. So today, with all due respect to all the clinicians in the room and beyond, I think as a doctor myself, we don't think of rehab as part of the treatment planning. So our thought of treatment planning finishes at discharge, and by default, like Dr. Saab said, rehab becomes an add-on to the existing treatment. So I think at a 30,000 feet view, we need to first culturally change as a health system and integrate rehab services with the overall treatment, and that can only happen if there is an integration of human beings, if there is integration of accreditations, if there is integration of processes. And I think Dr. Vishal and the likes can be of great assistance to us, because the moment you add that layer of AI and technology, human beings start integrating well. Unfortunately or fortunately, that's what we've seen in healthcare. So I think more than granular level decision making or granular level solutions, we first need to start at the top, where we say that let us consider both parts of the ship as one. And let us also prove this with the only metric of patient outcomes or clinical outcomes. So once that is sorted, I think all the other granular things, people are, we have the best in class clinicians in the world. I think they'll take the rest forward.
Brilliant, Saurav. I think that was the final comment for this very, very nicely done panel discussion. And if I have to just summarize, इस panel ने बोला कि डॉक्टर को पहले रिकवरी पढ़ाओ, फिर डॉक्टर से प्रिस्क्राइब कराओ, जिससे कि शिफ्ट होगा, उसके बाद उस पर एक्रेडिटेशन प्रोसेस, स्टैंडर्डाइजेशन लाओ, और फिर एआई से उसको इतना मेजरेबल बनाओ कि कंज्यूमर खुद मांगे कि मुझे रिकवरी चाहिए. I think that was the essence of this whole panel discussion. So I have in front of me Mr. Amit Kumar. He is our Director Operations. और इससे मैं जब भी पूछता हूँ ना कि ये होगा क्या, तो इसका एक ही जवाब आता है, पूछने में क्या जाता है. और आज हमने यही किया, हमने पूछा. We asked all those difficult questions because we were not afraid to ask those questions. जब questions पूछे जाते हैं, then discussions happen, and then policies are formulated, and then ideas are born. And I think the journey has already begun. Thank you for all of your attention. Thank you so much.
Thank you very much to the moderator as well as all the panelists. We've got all your points jotted. I request now Mr. Sudhir Bal to please join me on stage, Chairman Saroj Hospitals Delhi, Board Advisor HCAH, to please take this moment to thank all the panelists on stage. Let's put our hands together for Mr. Sudhir joining us on stage, ladies and gentlemen. Firstly, I request Dr. Vikram to please step forward. Dr. Vikram mentions patients in other specialties, examples, transplant, they need home care and we need to plan recovery for them. Expedite insurance companies also to assist in the recovery part. Great notes mentioned. Let's put our hands together for Dr. Vikram, everyone. I request Dr. Vishal to please step forward. Government is coming into data by AI and data has to be standardized, which is a challenge really. Technology has to be controlled by people in the health industry too. And technology, AI, are enablers and help us to give more solutions, is what Dr. Vishal says. Thank you very much, sir. Now, we would like to felicitate Dr. B.K. Rana with a memento. Let's put our hands together. Dr. Rana mentions that patient-reported experience measures, clinical protocols kept in place are more important than anything else. Thank you very much, Dr. Rana, for being here with us today. Now I request Dr. Suparno to please come forward. He says, drive care from IBR to CBR, and rehab won't be a luxury in future, it's definitely necessity. In future, we should have national and standardized rehab policy, as rehab is addition but a pillar of health system. Thank you very much, Dr. Suparno, for those comments, which are the pillars really. I request Dr. P. Kishan to come forward. Good manpower advancement of sciences, good well-being in Hyderabad. And now he says, I am ready to join your initiative and mission in hand together. Let's plan together for better outcomes and data measurable. Thank you very much, Dr. Kishan. And I request Dr. Saurabh Lal to please join forward. He mentions that judging capability of a fish to climb a tree, that's something what's happening. Rehab is out of hospital services. Huge gap is in transition from hospital to rehab. And he adds +1 that after the discharge of patient, rehab should be a mandate. And that's how we all can work together for a long term. Thank you very much, everyone. And now, sir, I would request you to please present this memento to our dynamic moderator, Dr. Gaurav. He has summed up this entire panel so beautifully himself. Thank you very much. Let's put our hands together for the initiator on stage. And also please join for a group picture, all my panelists, please. Sir, please join us. Dr. Vijay and Mr. Amit, please join us on stage. Let's have the team on stage for this special picture together. Thank you very much, dear team, for joining us on stage. It was definitely a fruitful discussion and very interesting one. Everyone adds values, and here are these discussions which take things forward. We need only 6 chairs now. We can remove one. And now, ladies and gentlemen, it's time to drive you in the next session. How many sessions do we have left? Can anyone answer? Any more answers? How many of you are saying 3 sessions left? Raise your hand. How many says 1 session? Raise your hand. How many says 2 sessions? Raise your hand. All right, you all are the winners. So we have 2 sessions only left, and those are two of the most awaited ones. So topic of the session 4, long-term acute care, interventions for affordable optimized recovery. I would like to proudly invite the keynote speaker on the stage, please. Yes, once the chairs are settled, I will definitely invite all my speakers. I would request all of you to please make sure that you add on some more energy in the room by putting your hands together and welcoming each one of them. However, by default, you're onto the listening mode, an active mode, so I'm not going that side. So let's put our hands together and welcome Dr. Vishnu Vardhan Raju. Warm welcome to you, a senior consultant, critical care, Renova Hospitals, Hyderabad. And joining him are going to be our expert speakers, Dr. Yashish Paliwal, HOD, critical care, Fortis Hospital, Kolkata. We have Dr. Pooja Wadhwa joining us, Director, Critical Care, Medicine, Maringo, Asia Hospitals, Faridabad and Gurugram. Dr. M. Karthik, HOD, Critical Care, Yashoda Hospitals, Hyderabad. Dr. Rahul Ghia, Consultant Critical Care, Inc., Kolkata. And Dr. Gaurishankar Reddy, MHOD, Critical Care, BGS Hospital, Bangalore. Fantastic. I have all the speakers on stage right now. Do we have Dr. Vijay here with us? Because he has introduced the keynote speaker. Yes, and now I would like to call Dr. Vijay to join us on stage as he would take this initiative on honor to introduce our keynote speaker, Dr. Vishnu Vardhan Raju. Sir, Dr. Vijay, over to you.
Good afternoon, all. I think we will have to slightly change this speak. I will introduce to Dr. Vishnu, and then probably I will request Dr. Pooja to continue with her talk because she has flight training. Right? So Dr. Vishnu Vardhan Raju, right? He's HOD Critical Care at Renova Century Hospitals with 20 plus years of experience in advanced ICU management, ECMO, and multi-organ failure management. He has a natural interest in intensive care, multi-organ failure, and ICU rehabilitation. So he's one of those few doctors in a home when we interact, the concept of LTAC just flows like that. Instead of explaining the concept, he says, okay, oh wow, this is what we have to do and let's do, and we are in the mission of getting this ecosystem sensitized on that. So over to you, Dr. Vishnu, and probably you can just ask Dr. Pooja and then we'll take it over. I'll request Dr. Pooja to take over the press. Thank you.
So good evening, everyone. The second last session, so I hope you all are not too bored by listening to all the speakers. I'll be very short. I'll just give you an overview about the infection control complication and management in long-term ICU stay patients and in chronical ICU patients. Rest detail will be discussed by other speakers as well. So, first, we need to answer a question, which is why long-stay ICU patients matter. So, why these patients matter? Because they form a very big chunk of burden on the hospital industry as well as on the society, as has already been discussed by the previous speakers. It has been seen that ICU-acquired infections lead to 3 times more mortality than patients who have been non-infected in the ICU. So, infections carry a more strong risk of morbidity as well as mortality. Along with that, it increases the length of stay, thereby obviously increasing the morbidity and mortality. Functional outcomes are hampered, delirium and ICU-acquired weaknesses, which are also a strong predictors for the prolonged ventilation, institutionalization, neocognitive decline, and post-ICU syndrome. Now, in this session, I'll just try to touch the defining and identifying the who are these patients whom we define as long-standing ICU patients or chronically ill patients. Review the key acquired infections, and along with that, the non-infective complications. I'll summarize the evidence-based bundles, all the 3, along with pressure injury prevention, discuss the MDR colonization and how to prevent and treat it, and finally, early rehabilitation, how does it help, and how we can do a post-ICU follow-up. So, who are these long-standing or long ICU stay patients or chronically critical illness patient? Working definition is any patient in the ICU who has been there for more than 7 days and requires some kind of support, whether in the form of a renal replacement therapy, a ventilator, or vasopressor therapy or with recurrent sepsis episodes. Chronically critically ill patients are the ones who have been on prolonged ventilation or who have been tracheostomized and require high nursing requirements. Often these are the old, frail, multimorbid with pre-existing functional limitations, and they have very low muscle mass in the form of sarcopenia. So why are they different? They are different because they face a triple threat in the form of that the natural defenses have been breached in the form of multiple catheters, tubes or wounds, exposure to multiple drug-resistant bacteria, and immune exhaustion, which leads to high incidence of ICU-acquired weakness, delirium, dysphagia, ultimately leading to malnutrition and pressure injuries. Threefold higher 5-year mortality rates. Now the spectrum of these complications of a patient who has been in the ICU for a long period of time, they can be divided into infective, non-infective, and post-ICU complications. In infective, it can be ventilator-associated event, bloodstream infection, a urinary tract infection, or bed sores. In non-infective, it could be just contractures, weakness, delirium, sleep disturbances, thromboembolism, stress ulcers. In post-ICU care, the most common is the post-ICU syndrome, manifesting in any form, whether it is physical, cognitive, mental health, or all these things increase the 1 to 5-year mortality rates. They also have decreased healthcare-related quality of life. Now, coming to the ventilator-associated events in long-stay patients, they are at very high risk of catching infections, which typically peaks around 5 days. In large cohorts, it has been found that approximately 17 to 20% of these ventilated patients, they develop some kind of infection within the 7 days of staying in the ICU. Now, how do we identify that which people or which patients are at risk for developing these kind of infections? So any long-stay patient who require repeated reintubations or have difficult weaning are at risk. High sedation exposure, muscle relaxants, supine positioning, poor oral hygiene, all these lead to ventilatory associated event. Underlying comorbid conditions like bronchiectasis, COPDs, obstructive sleep apnea, they also predispose these patients to develop numerous infections. Now to prevent these infections, you have a bundle, which includes the most important is the hand hygiene, head end elevation to typically 30 to 45 degrees, giving daily sedation interruptions, chlorhexidine based oral care. Now the special tweaks are that a patient who a healthcare provider feels that he will require a prolonged ventilation or will have a difficult weaning, early tracheostomy has been shown to decrease that incidence of infection to quite a bit. Systemic dysphagia screening, especially post-extubation, so as to prevent aspiration pneumonia and microaspirations. Active mobilization and chest physiotherapy has been shown to play an important part in preventing this kind of infection. Careful evaluation of topical antimicrobial decontamination strategies, especially balancing the rate of reduction between if they are exposed to MDR or they are not exposed to MDRs. Bloodstream infection prevention by questioning daily whether a patient or the long-term patient, he requires those invasive lines, or if we can do away with those lines. They should be cleaned daily with chlorhexidine alcohol skin preparations, and whenever inserted, preferably should be under an ultrasound guided. Preferably choose the upper body sites because of the lower body closure to the, because of the anatomy, they are prone for infections on the lower part of the body than the upper body. Using antimicrobial catheters if the infection rate is very high, and routinely daily documentation and evaluation of the need of those invasive lines. Same is with Coti bundle. You need to follow all departmental guidelines or your institutional guidelines on how to prevent that daily screening, whether it is required or not. Closed drainage systems should be done, and strict aseptic precautions while insertion. Now, MDR colonization has been shown to increase the length of stay, especially with gram-negative bacteria and in some cases fungal infections as well. Now coming to an important topic, which is ICU-acquired weakness and delirium. It is a very big burden on the long-term care facilities as well as in the hospital. So to prevent, and prevention is the best cure, and early rehabilitation in the form of implementation of the ABCDEF bundle, daily progressive mobilization protocol with safety screenings is a must, avoid deep or prolonged neuromuscular weakening agents, optimize sleep with non-pharmacological measures, minimize nocturnal disruptions, deliriogenic medications should be avoided whenever feasible, integrate early physical, cognitive and psychological rehabilitation. Pressure injuries, oral health and dysphasias. Pressure injuries lead to higher length of stay, higher costs. Oral health there should be a structural oral health care documentation also. Dysphagia, any post-extubation dysphagia should be treated aggressively. Rehabilitation in the form of physical rehabilitation, early mobilization, rehabilitation bundles, and tracking that mobilization is important. I'll just skip this. So bedside checklist for long stay ICU patients should include the devices and bundles, daily documentation, cleaning, and the need to review whether they are required or not. For brain, muscle and skin, the integrity, the cognitive function, they need to be tackled. Prevention is the best cure for that. Antimicrobials and follow-up, although early, we need to, if the patient is in sepsis, you need to start early with the antibiotics, but de-escalation is also equally important to prevent them from becoming susceptible to multi-drug resistant organisms. So the take-home message is, identify the phenotype of patients who are at risk for developing these complications, daily assess the drugs, the delirium and the devices, and think beyond the ICU discharge. Thank you.
Thank you very much, Dr. Pooja, for the presentation, keeping in mind that you have to rush. We would like to take this moment to also thank you for joining us. Can I request Mr. Amit Kumar to please join me on stage? We would like to present the memento to the lady herself. Joint Secretary Recovery 1 2026, Mr. Amit Kumar is here on stage. Let's put our hands together and thank Dr. Pooja Vadhwa for joining us today. Key components of LTAC care, a clinical framework of intensivity, and she has been on dot. She's made very, very clear in a short presentation with the time pressing. Thank you so much, ma'am. And now I would like to invite our keynote speaker, Dr. Vishnuvardhan Raju sir, to take over from here. Let's put our hands together, ladies and gentlemen. All the speakers, can you please join for the group picture? Amit sir. Thank you very much, Dr. Gaurav, for being proactive and letting me know about the same. We would love to have a picture along with Dr. Pooja on stage while she's here with us, travel all far from Gurugram. Thank you, gentlemen. So over to you.
Good evening, everyone. So, we'll discuss about what is LTAC. So, the clinical blueprint for the LTAC. So, optimizing patient outcome from intensive care to long term. So, the patient, how the LTAC behaves as a bridge between the ICU and the home. So, as we all know, once the acute critical phase is over, either the patient discharged directly from the ICU, or they go into chronic critical illness, or people might die. So we talk about the patients who are stay in the ICU for a prolonged duration, who develops chronic critical stable illness. So we'll discuss about these patients. These patients require the LTAC facilities. Okay. So these patients have high morbidity, persisting physical cognitive deficits, and poor long-term quality of life. So about the cost, so severe family and caregiver stress, heavy financial strain, and loss of economic productivity. And it also strains the system like prolonged healthcare utilization, high resource intensive care, and resource allocation challenges. Next, these patients have very high mortality rates and escalating risk of hospital-acquired complications. Okay. So chronic critical illness creates an unsustainable cycle of high patient morbidity and immense systemic costs that traditional acute care is not designed for supporting them the long term. So mapping the patient care continuum, as you all know, so prevention is better. So the primary and prevention, they should have regular checkups and chronic disease managements. But once these patients land up in the acute care, so they have intensive treatment during serious illness to stabilize. So these patients, ultimately, there are three paths, like they discharge, die, or they go into the chronic critical illness stages. These patients require post-acute care because they require extended medical and rehabilitative care, because these patients are treated more than 25 days, more than requiring 25 days. These patients most probably will go into the chronic critical care illness phase. And from there, they go to rehabilitation and home. So LTAC prevents these critical gaps in care, ensuring smooth transition that reduces complications, lowers readmissions, and adapts to changing patient needs. The 5 core advantages of LTAC model: closing the complex care gap, like manages prolonged respiratory failure and multi-organ issues requiring weeks of specialized treatment. Next, decompressing acute ICUs. Okay. So frees up highly resourced intensive acute beds by transitioning stable chronic ill patients. Next is specialized interventions, like provides ventilator weaning, complex wound care, and ongoing IV medications beyond nursing home capacities. And outcome optimization, it focuses relentlessly on long-term recovery, preventing premature discharge to under-equipped facilities. Next, systemic cost effects, delivers a high-cost, efficient, effective continuum of care without compromising complex medical management. And the paradigm shift, so initiating early rehabilitation. So a patient with a standard care, so the functional capacity doesn't improve much. So a patient who was admitted to the early LTAC, so the therapy initiated while clinically stable, even if ventilator dependent, they have the functional capacity improves very fast. Okay, so it prevents weakness by preserving muscle strength through early mobilization, and accelerates weaning by enhancing the respiratory and skeletal muscle function, and reduces complications, lower risk of pressure, ulcers, DVT, and VAP. Okay, so shifting care from simply keeping the patient alive to actively restoring function and independence. The 5-phase stepwise rehabilitation protocol in LTAC, so phase 1 is a passive one. The patients are completely unconscious. So here we do range of motions, twirly, turning, splinting, and chest physiotherapy. Next comes a phase 2, assisted, where the patient is conscious but still requires some sort of care. They require active assisted exercises, bed mobility, rolling, sitting up in the bed. And phase 3 is an active phase, like moving out of the bed, sitting in a chair, and light resistant exercises. And the phase 4 is functional, where restoring independence, so ambulating training, activity of daily activities. And the phase 5 is advanced, So where you increase the endurance, like stair climbing, caregiving training. Next, these are the things which, apart from your general care rehab, we have to even give many implications on neurocognitive, infection control, nutrition, and all those things. I will go through briefly, but our speakers also will go into it deeply. I'll just give an overview of all these things. Neurocognitive restoration. So critical illness often results in delirium, impaired memory, and executive dysfunction. So untreated impairment guarantees poor functional outcomes. So how you assess and try to regain the neurocognitive restoration, like daily assessing the neurological monitoring, like regular GSES assessments, tracking pupil motor responses, and coming to delirium management, reintegration of clocks, calendars, maintaining the sleep-wake cycles, and minimizing sedatives. And cognitive rehab, structured memory recall, attention focusing and problem-solving exercises, and psychological and sensory, managing PTSD, and introducing familiar voices and music to avoid sensory extremes. So reduce delirium duration and better memory recover and higher functional independence if you give more importance to cognitive restoration. Next, as I already told you, so nutrition is very important in acute illness. They almost lose all the muscle and they have a critical weakness. We need to provide adequate nutrition in them to regain the strength as soon as possible. So the core principle is we have to feed this patient as soon as possible via enteral. If not possible, we have tried to use parenteral as well. So enteral nutritional via NG or PEG is strongly preferred over parenteral to preserve the gut function and reduce infection rates. So energy requirements, as we all know, 25 to 30 kilocalories per kg per day we can calculate. Can go up to 35 kilocalories per day in severe stress. So, and the proteins, at least we have to target around 1.2 to 2 grams per kg per day. Crucial to support muscle preservation and wound healing. We can go up to 2.5 grams in catabolic states. Like carbohydrates, we have to maintain around 50 to 60 and fats around 20 to 30%. And fluid management, we have to make sure that there is at least 25 to 30 ml per kg per day. And functional assessment metrics, generally we see how better the muscles are improved or able to have that functional independence. Okay, most common scale we use MRC scale, ICU acquired weakness. So we evaluate 6 bilateral muscles like shoulder, ankle, elbow, wrist, and hip, and we give the power. 0 is no power and 5 is the full power. Based on the score, the total score sums up around 60. Any patient having less than score of 48 indicates ICU acquired weakness. So one more thing is functional independence, where we see feeding, bathing, dressing, toileting, transfer, whether the patient is able to do. So based on that, global outcome scales, we have 2, Barthel index and functional independence measure. So 100, so total independent, anything below 20 is completely dependent. Okay. So bed mobility, sitting, standing, walking, and independent areas. This is the course that we follow in the LTAC. So I won't go very into the ventilator weaning because Dr. Karthik is going to take about that, and tracheostomy also. So daily maintenance of the hygiene, like suctioning, limit passes to 10 to 15 seconds to prevent hypoxia, stoma and cannula care. We have to humidify to prevent thick secretions, tube obstructions, and positioning, like maintaining semi-upright position, and emergency management and risk, like continuously watching for respiratory distress, excessive secretions, and air leaks. And rapid response includes immediate suctioning, oxygenation, and availability of backup of replacement tubes for accidental blockage and decannulations. And next, one more thing is building the infection control sheet. Like we have, we should systemic protocols and standard precautions, device-related precautions. We should have all these systemic protocols in place, like ventilator care bundles. I'm not going into deep because some other speakers are going to take in. So we should have WAP bundles, CLAPSI and COTI bundles. Okay, we should follow antibiotic stewardship to prevent resistant organisms and aggressive surveillance of WBC and cultures. Coming to the economic of recovery and cost-benefit burden, as you all know, acute ICU stay, cost is very high. Benefits and long-term impact, like stabilization of immediate life-threatening illness, deeply resource and intensive, and creates high bottleneck risk for the hospitals. So post-acute care is in between the rehabilitation and acute stay. Initial cost might be high, but ventilator weaning, complex wound care, and monitoring such patients reduces pre-ups, acute beds, and reduces cost readmissions. And rehabilitation is moderate low cost, restores functional independence, dramatically improves the long-term survival. This is the synthesis from survival to independence, the coordinated multidisciplinary LTAC models. So early rehabilitation, neurocognitive care, targeted nutrition, and aggressive infection controls. So sustained functional independence and ventilator rehabilitation, and decompressed ICUs, and reduced total cost of care. True recovery demands that physical, neurological, and metabolic therapies occur simultaneously, not sequentially. So core takeaways, a critical systemic bridge. LTAC is not a waiting room. It is an active specialized intervention zone that prevents fatal gaps between the ICU and the home rehabilitation. And the defining characteristic of successful LTAC is the immediate initiation of physical and cognitive rehabilitation, even while patient remains ventilator dependent. And while upfront costs are substantial, the LTAC continuum systemically reduces extreme ICU expenditures, minimizes devastating complications, and delivers a high return to functional independence. Thank you.
Thank you, Dr. Vishnu, for your presentation. And now we need to understand defining the ICU rehabilitation window, that how early is too early. To present the same, can I please invite Dr. Yashish Paliwal before all of us, HOD Critical Care, Fortis Hospital, Kolkata. Let's put our hands together.
Hi, good afternoon, everyone. This is, I think, one of the sessions towards the fag end of the day, so I will try to keep it crisp. Thank you, Dr. Gaurav, for inviting me here, and this is the first of its kind conference I'm attending, because most of the time, like the other speakers said, we attended our specialty-wise conferences, but never this kind. So yes, it is very, very important, as we have seen. So I think we can start. Okay, so when we look at the optimized outcome, bridging acute ICU care to LTAC, how early we can think about starting the rehabilitation? Well, to be honest, like I think Dr. Sudhi said, when patient comes to us, you are actually thinking out what is wrong with the patient. You're not thinking about recovery or rehabilitation in your mind. So once you figured out what's wrong with them, you start treating them with whatever is required. And once the post-stabilization, then you think about what more I can do with the person. So that is how it goes. So I think if I look at that, so I would like to let you know about the rehabilitation window. We discussed specifically about neurological patients. Okay, the window is quite short. Okay, so we have to start early, because that is the time when we have where the neuroplastic state is there. If we lose that window, then even if we do our rehabilitation, the advantage, as we have known with different trials, whether it's AVERT trial or Neurological Society guidelines, is not that much. So we have a specific window to get the optimal outcome, beyond which we may not get the same outcome even if we do the same things. Okay, so of course, first, how early is early? Can we do it in the day one? Yes, in my mind, if patient is not stable, you can't really do any of those things. But once the acute phase is over, especially after first 24 hours, I think we can start depending on what the patient's situation is. We should not try for the moon. We can start something little and build upon it. As simple as mobility within the bed, passive movement, and then gradually increase the intensity. So maintaining the physiological stability is very, very important. And while we are trying to do the rehabilitation, we need to understand we should not do too much and harm the patient. Okay, so we have to understand, start with low and then build it up, and at the same time, avoid learned non-use. So if we don't use at all, even a passive exercise is a part of rehabilitation. So we must do that. Though I think we most of the time we say less is more in our line of work, okay? We don't need very high pressures, that's okay. We don't need too much of oxygenation. Above 90 or 92 is we are good. Don't feed too much, but feed something. So I think if I take a corollary to that, here, probably it's what we have seen during the day that applies here as well. So when somebody is sick, we have to give food, okay? Lots of protein, patient is blocking. But we have to understand when patient is acutely unwell, they are in a catabolic state. When they are in a catabolic state, even if you feed them high protein diet, it's not going to benefit. So when the patient is going from catabolic to anabolic, that is the time where if you give them the raw material, they will build up and get out of it. So that is why currently, if we look at it, frailty is one of the key marker for anybody in ICU to survive that illness. So frailty is very, very important. Similarly, any of those patients who are in ICU, who are the sickest patient, okay, leave aside neuro patients. They have come with different organ failures, different infections, they are on ventilators, vasopressors, getting steroid, antibiotic, especially aminoglycoside, and all of it cause weakness. I think Dr. Pooja did touch upon ICU-acquired weakness. I think if you start looking at how much weakness it can cause, every single day in ICU in such a patient on full Monty will have 1.5 to 2% loss of muscle mass every single day. So you can understand within a week how weak they will be and how difficult it will be. So what do we do in ICU? We measure it, how weak they are, by using different technology. It's simple, like you said, MRC score less than 48, ICU-acquired weakness, or you use ultrasound to look at the diaphragm, different muscles, different other structural and functional characteristic of it. So similarly, I think we can use all those things here as well to adapt to our patients' recovery and rehabilitation. So I think we should start building on the initial in-bed rehabilitation, make sure they are not in pain, they are comfortable, and make sure they are able to swallow. So simple things, and if not, then use advanced therapies like sensory stimulations and in bed, the other things, the robotics that we have discussed, different kind of robotics to help us to get there. So why we are impressing upon that early is better? Because when we start early, we decrease the time of these patients stay in ICU or in the hospital. We can discharge them early, and their mind works better, because we say now every day we have to doing exercise every day is non-negotiable. Like each one of us, especially after you have crossed 50 or maybe 40s. So similarly here, doing this is non-negotiable. When we work out, we know our mood is better, we feel better, we are more confident. That is not something very different for our patients too. So doing it early will decrease all those things, and when you are not delirious, your mind is working, you can participate in your own treatment and you get out of the hospital quicker. So remember, patients whose mind is working will definitely have a better outcome compared to the one whose mind is not working. So these are the different things. Our trial clearly shows us don't do more. More can do harm. Doing little less of something is beneficial. That team study is mainly on the ventilator patients. If we start them mobilizing early, that's better. That is again, the ICH guideline says the same. So when we started, say 20 years back, we thought about, okay, if we do not put them to sleep, in too deep or give them sedation hold, we can get them awake early and we can move them out early. Then somebody says, okay, now let's start moving them early. So from that trial is early awakening trial, which is one of the landmark trials in the intensive care. So we start moving out. It's the same thing that we do, but some smarter like try to put in an evidence, and then now everybody's saying with the open eyes, yes, that's the right thing to do. So I think that is what is important is, similarly, when we used to prone patients, of course you can't do. We used to put the patient on ECMO, we think, okay, no, now we can't mobilize them. Until later down the line you say, no, even the patients on ECMO, you can actually get them to do some rehabilitation and exercise. Especially if you have seen, go to the cardiac transplant centers, they are patients who are waiting to do ECMO or after the transplant. They are awake on ECMO and they can do certain things. Even during COVID, we have seen the patients on ECMO, we combine them with the proning. So it's a mindset. We can achieve that. When we do that, of course, we have a less ICU acquired weakness. We can get them out of the hospital earlier. Once they are better, you are using less and less invasive therapy, less and less chances of different sort of ICU problems you will come across. So this we have discussed, yes. So different kind of weaknesses that we have simply because of not using it, or could be of critical illness, polyneuropathy, myopathy, or a combination of those things. And of course it affects. So I think these are the different kind of things that we can do in the ICU, and of course they are helpful in getting them, whether it's a weaning from the ventilator therapy, or weaning them from ICU to the HDU to the ward and home. So all those parameters are we can control, and it is very effective if we do this. So if we don't do because of the cost, then costs will get increased by all of these problems that we have discussed so far. And yeah, we can decrease ventilator-free days. We have discussed that. Okay, I think we have discussed that, so I'll skip that. Okay. Yeah, I think very, very important things I would like to say. I'll probably go to that towards the end. And just give me 1 minute. When we should not do it. We should not do it, like we said, when they are not ready for it. So they have to be stable cardiorespiratory wise, neurology wise, or no spine fractures and things like that. Or even when they are improving or decreasing all these supports below a particular level, we can start the physiotherapies. Okay? And yeah. So I think we need to understand the concept of rehabilitation comes after the initial stabilization. Until you have not stabilized, that rehabilitation cannot start. And remember, passive rehab is still a rehab, okay? And just like exercise is not negotiable, rehab is also not negotiable. So we need to keep it in mind, okay? So it's, in principle, I would say it's not a separate phase after survival. It has to happen simultaneously from the day one, and start early, not with the high intensity and more frequent, low in intensity and less frequent, and build upon it. And of course, I think I will skip. So this is how you will go about it when they are not ready versus when they are gradually getting better, and you increase the intensity and the dose of the rehabilitation and physiotherapy. And I think I'll skip that bit, yeah. That's about it. So I think in nutshell, starting early with something is better, but not try to do too much too soon. Okay, so I will end with that. Thank you.
Thank you, Dr. Yashish. And now to talk about ventilator weaning and respiratory rehabilitation in LTAC. Can I please invite Dr. M. Karthik to join us? HOD Critical Care, Yashoda Hospitals, Hyderabad. Ladies and gentlemen, let's strike our hands together to Ventil gentlemen, please.
Right. Good afternoon. And let me take this opportunity, Dr. Gaurav. Okay, Dr. Vijay, yeah, thank you for having me here. And let me put my perspective of ventilation in this whole gamut of discussion. So let me sum up where we are right now. So we discussed about where the role of LTAC comes into the picture once the patient is out of acute recovery from an ICU. Then we talked about few nuances of what goes on in LTAC. So Dr. Pooja was talking about infection control. Dr. Yashesh was talking about rehabilitation care in LTAC. What I'm going to touch upon is a small but very important aspect of LTAC, which is respiratory rehabilitation and as well as ventilator weaning, right? So as you know, the core chunk of treating patients who come to LTAC are either hemodynamically unstable or they are finding time where they cannot come out of ventilator in critical care units. The reasons may be many, but the discussion as of what we were having is more about what happens in this LTAC, but how do we go about treating these patients in LTAC is what my presentation would focus mostly upon. So 40% of the patients in ICUs who are getting prolonged ventilated patients having ventilated stay more than 21 days, and these are those cases that define the eligibility of LTAC ventilator cases. And when these patients came into LTAC unit, these are some of the data that is driven from the Western literature, had a successful weaning of around 60 to 80% of them were successfully weaned. This could have been done in critical care ICUs as well, but you know the cost effectiveness and the kind of human manpower and the labor that goes into, and we are short of beds, which needless to say all of us appreciate about. So what are the core of patients that go into LTAC units with vis-a-vis respiratory physiology derangements? Those are post-ARDS patients. Patients who are having neuromuscular dysfunctions like your GBS, myasthenia. Patients who are dependent on tracheostomy, your neurocognitive problems, your stroke patients who are having difficult time clearing up their secretions, and multimorbid patients who are obese, having cardiovascular problems, going into in and out complaints of respiratory distress and are stuck somewhere in the hospital. So now the scenario for these patients who are requiring POSI requirement of ventilator stay are those patients where you could think of moving them to your LTAC units. So if you have to have a weaning pathway, naturally when these patients are coming to an LTAC unit with ongoing ventilation support, whether it's an LTAC unit or whether it's an ICU, the medical principles remain the same. So all the speakers, what they were speaking are these core medical principles that who better than an intensivist can guide you upon these aspects. So we deal at more serious level in ICUs, but the principles remains the same. You stabilize this patient, you assess their neuromuscular conditions when they land in your LTAC units, and you segregate these patients depending on the severity of the problems. Then you assess their nutritional status, and you try to reverse their factors which are reversible, right? So these are some of the things that you do in the first 5 days when you land in LTAC units. Then you progressively try to wean these patients off ventilator with TP's trials. These are something that we do in a graded fashion, monitoring the vitals so that these patients are off ventilation. Some patients land up with tracheostomy, and tracheostomy care, needless to say, is a cumbersome thing. So as an critical care head, as an infection prevention control head of my hospital, I know how difficult it is, and every day you need to look into those tracheostomy tubes that are getting blocked or not. So many a times these patients, when they are going to wards, physicians are more happy sending them to LTAC unit where the concentration is more upon these aspects, whether in the ward the concentration or the severity at which we look at them is slightly lesser. So the tracheostomy management is a tricky part, so we have to deal with it in an LTAC unit. And then when you transition them out of a tracheostomy or you transition them from a respiratory distress patient to a stabilizing case, then you need to bridge these patients and you need to train the family in order to manage them when they go into a rehab or when they go into the home. So the respiratory rehabilitation, if I have to sum up the whole gamut of medical jargons that I can speak about, but if I have to put it in a simple language, would land up into the 6 core pillars for the respiratory rehabilitation. Inspiratory muscle training, airway clearance, early mobilization, which Dr. Yashish was talking about, nutritional support, very, very important, and cognitive psychological support, and you should have a good communication with the family. These are things which we do in an intensive care unit at a very great depths. So the principles remain the same, but the severity of them slightly mild down in an LTAC unit, but this is what are the core principles when we are dealing with a patient who's on ventilator in an LTAC unit. So a multidisciplinary team, wherever you go, these are patients where you should have a multidisciplinary team in LTAC unit as well as we have in critical care units. You need to have an intensivist, a respiratory therapist, a physiotherapist, a swallowing therapist, dietitian, and a psychologist. Very, very neglected part, but very important part, a psychologist. So these 6 people together see the cases, whether you have a 6-bed LTAC, you have an 8-bed LTAC. Needless to say, you have to move in your team. The team has to move and has to analyze every patient in these 6 core principles or core specialities, and you have to put a plan to your patients who are admitted in an LTAC unit. So these LTAC units, this is a literature-driven data that is predominantly coming from an Western setup where the tertiary unit care costing, a step-down HDU costing, and an LTAC unit, and LTAC with a structured rehab protocol. So what is an LTAC with structured rehab protocol? We'll discuss it, but you need to move towards that setup where you have an LTAC with a structured rehabilitation protocol has been proven to be a cost-effective intervention. So the measurable outcomes have been they have been 68% of successful weaning, 22 days of median LTAC length of stay in a ventilated patients could be reduced, and the VAP rate has come down 42%. But I tell you, this is a Western literature driven data. We need to have our own literature and then we can come to a conclusion on it. And you could see improvement in power and muscle functions. So how do you implement it? You have a foundation, you have a pilot phase where you start off with 3 patients or a small number to start off with, see your data, how it is going about, scale up your LTAC beds, and then consolidate it on your problems that you're facing in an LTAC unit. What we'll cover today in the respiratory physiology, these are again medical core issues that I'm going to talk about: tracheostomy management, ventilator weaning, how do you decannulate patients, how do you provide respiratory physiology, physiotherapy, nutrition, rehabilitation, and infection control in long-staying patients in LTAC unit. So indications of tracheostomy, I'll not go into them. They are mostly prolonged ventilation. Most of them come with a tracheostomy tube to the LTAC units. So when do you do it? How do you do it? And what are the kinds of tubes that you're going to get in an LTAC unit when they are coming from an ICU? You need to know few basics of that, that is cuffed, standard, fenestrated, adjustable flange tracheostomy tubes. So these are some of the information that we need to take from the patient when he lands up in an LTAC unit. And you need to have a structured approach to liberation. Whether you're working in a hospital, you're working in an ICU or an LTAC unit, you cannot put your entire concentration for every patient. You need to have standard operating protocols. Until you have your standard operating protocols, you're not going to generalize the outcome of your LTAC unit patients. So you should have a SBT readiness criteria. So you have to check every day for spontaneous breathing trials. When you do it, when the acceptable oxygen requirement is there and SATs are around 92 and above, and you have minimal requirement of ventilation, you have hemodynamic stability, you have a good respiratory drive of that patient, and you don't have a need for ongoing analgesic and sedative requirements. Those are patients that you see for readiness criteria. Once you see that they're ready, then you go into breathing trials, and then you do breathing trials with a TPs or with a pressure support on the ventilator, or you gradually reduce your SIMV support and gradually you bring down the ventilator, and then you liberate the patients from a ventilator support. And sometimes you can bridge this gap with the help of non-invasive ventilation. So that's a mode that you have in a ventilator apart from invasive ventilation, where you can bridge over the crisis period. So this is a structured way how you liberate the patients from a ventilator. Why patients fail to wean and how do you prevent it? So patients fail to wean when their physiological problems are not settled. You're not addressing the underlying heart failure, you're not addressing the kidney injury, you're not addressing the infection. Then do what the patient is not going to come out of ventilation. So you have to address those reversible problems that are there in the patient. And you need to put in process, you need to put in system, you need to put in standard operating protocols, and then you need to diligently follow them every day with your multidisciplinary team and see to that your process is not failing. If your process doesn't fail, then your outcome is also bound not to fail. And the protocol gaps, when you assess data, like you have every monthly, you need to have quality assessment. Now that you are having NABH and you are having QIA, I'm sure the quality parameters, the quality teams also will end up into rehab care, where you monitor all these aspects of infection control, about ventilation weaning, about failure of ventilation weaning. The data needs to come up, the data needs to be discussed with the team members, and you need to stopgap those gaps in your LTAC unit. So now what is this embedded rehab, and how do you inculcate into the LTAC? So the embedded rehab components are early mobilization, what Dr. Yashish was talking about, the respiratory muscle training, the neuromuscular electrical stimulation if you have limb weakness patients, cough assist devices, physiotherapy progression, and a multidisciplinary team. So if you can incorporate nutrition, rehabilitation, and you incorporate the help of a reversible physiological problems, then your embedded rehab interventions can bring a better outcome in weaning the patients from ventilator support. So I'll not go into the nutrition part. Already it was been dealt by Dr. Vishnu, where how many calories you should maintain, what protein you should give, and how much of nutrition that you should provide. So these are, needless to say, very important even in an LTAC unit. And you have to have a protocol when you want to decannulate this patient, have a protocol, have a readiness criteria where you see saturations, where you see the breathing efforts of the patient, and you have an intact swallowing function, you have a speech therapist, and then these protocols, you can deflate the cuff, put the cap tube, and then go for decannulation, and then after decannulation, you need to have care of these decannulated patients. This is an infection control practices that even in an LTAC unit is viable, and this is a very, very tricky and difficult stage. So this requires, needless to say, even in the best of the ICU setups across India, the infection rates is a big problem to deal with, and I'm sure in LTAC unit also we have to deal with this issue. So who does what? So the intensivist takes care of the medical treatment, that is you're seeing for your SBT and SAT review, having a weaning protocols. The respiratory therapist comes into the ventilator management, conducting the SBT, doing the secretions analysis, thick, thin, copious or not. Physiotherapist deals with early mobilization, and your dietitian stopgaps those dietary requirements, and speech therapist looks at whether you can decannulate the patients from the tracheostomy, and the pharmacist will look at the drugs that are being given which are impeding your weaning from ventilation. So these are the core participants in your LTAC unit for weaning, and metrics matter. So you have to look at your VAP rate, you have to look at your SBT failure, you have to look at your successful decannulation rate, and track to decannulation duration. These are some of the parameters that you need to monitor in your LTAC unit to do the process and see your outcome indicators. So build up this ICU program kind of a scenario even for LTAC units. So these are the 6 points. You have a SAT and SBT bundle. You have a tracheostomy decisions which should be proactive, and you should be in a position where you reduce the VAP rates, weakness, and stay in the LTAC units. Decannulation should be safe and it should be protocolized, and you should embed your physiotherapy, rehab, and nutritional care into your weaning process. infection control bundle practices, your VAP bundle, CRBSA bundle, COTI bundle, these bundles have to be maintained even in an LTAC unit. And a multidisciplinary team forms the core. If you have a good multidisciplinary team round in the morning, that solves 50% of your problem. So have a good multidisciplinary team and do a round, document it, assess it and reassess it. That's the way you go forward in weaning the patients from a ventilator support. So these are some of my opinions that I wanted to put forth in this audience, and thank you for your patient hearing.
Thank you very much, Dr. Karthik, for the technical presentation. And now I would request Dr. Rahul Ghia to please join us for infection control and complication management in long stay patients topic. Over to you, sir. Can we put our hands together for the gentlemen, ladies?
Good evening, everyone. First of all, I would like to thank the organizer for inviting me. So now coming to the topic, when we say about long-term critically ill patients, the ultimate goal is not the survival. It's the overall functional recovery. But when we talk about the functional recovery, we have seen that this is often delayed and it is derailed. This is not because it is often derailed and deranged and derailed. This is because of the infections and other complications that always present when the patient stays in ICU for a very longer duration of time. So in next few slides, I will be discussing regarding what are the infections and the complications that we see in the long stay critically ill patients and how we can deal with it. So to start with, so these are the five silent saboteurs of the long-term acute care recovery, these that we often see. First of all is healthcare-associated infections that comprises of VAP, CLAPSI, COTI, C. diff toxin infections, and SI, the surgical site infections. Followed by MDRO colonization. It has been seen that MDRO, the multi-drug resistance colonizations, it around 3 to 5 times more comparison to the acute care hospital ICU setups. Then it is followed by the pressure injuries and immobilities, the deep tissue injuries over the sacrum and the occipits. Since the patient has been bedridden for longer duration of time, it causes joint contractions. There is an elevated risk of DVTs and PE, which is seen in this type of patients. Next complications that we talk about is delirium and cognitive decline. As we see that the patient we have seen that there is overuse of benzodiazepines and other drugs which are delirinogenic in the ICUs. And definitely that will cause the hypoactive delirium and that can be masked with as a coma. The sleep-wake cycle is also disrupted as there is sleep hygiene is not maintained. There is impaired participations by the families and others that will result in delirium and cognitive decline. Last and most important aspect that we usually don't take care much in the ICUs is nutritional deficiencies and sarcopenia. When the patient is admitted in the ICU stay in the ICUs, it is in the catabolic state. So there is severe protein energy, malnourishment, and profound muscle wasting happens in the early stage of life, early stage in the care. So obviously, nutritional deficiency and sarcopenia is one of the factors that to be taken care in long-term and LTAC patients. So why the complications are higher in the LTAC patients? First and foremost important thing is prolonged device care. The patient in the LTACs remains in the longer ventilator days. The patient have tracheostomies. The patients have external devices like the Foleys, the central lines, and these all increases the chances of VAP, CLAPSI, and COTI risk. Second is the patient has been exposed to repeated antibiotic exposures. The patient has been given broad-spectrum antibiotics which result in selected organisms, resistant organisms, and increases the risk of Clostridium difficile risk. Third is immobility and skin breakdown. The immobility drives the secretions, retentions, pressure injuries, which can ultimately result in DVTs and deconditioning. Fourth is altered sensorium and dysphagia. We have already discussed. Malnourishment and sarcopenia that will result in poor wound healing, ventilator weaning, and rehab intolerance later on. Surveillance gaps and handover. It is often missed when the patient is being transferred from the ICU to the LTAC or the SDU levels. We have also often seen that the changing teams can miss the device reviews, the culture follow-ups, and the daily goals. So it is very important that the complications in the LTE, LTAC are cumulative, so prevention may be daily, structure, and multidisciplinary. So now we will discuss what are the preventive bundles that can be implemented in LTAC so as to prevent the infections and other complications. First and foremost importance is the VAP preventive bundles in LTAC. So according to the ADSA 2022, these are the few steps like head elevation 30 to 45 degree that will minimize the aspiration risk, daily sedation, interruptions, and spontaneous breathing trial, oral care and toothbrushing, oral care chlorhexidine mouthwash every 6 to 8 hourly. The studies have shown that daily toothbrushing associated with significant lower VAP rates, shorter duration of mechanical ventilations, and shorter ICU length of stay. Subglottic suctioning, use specialized ED tubes to actively clear the subglottic secretions. Cuff pressures to be maintained around 20 to 30 centimeter of water to prevent microaspirations. DVT and stress ulcers, daily assessment and administration of prophylaxis should be given. And most important step is early mobilization, the physical therapy and early tracheostomy when prolonged ventilation is accepted. We all know that none of this care is basically causes a dramatic changes. These are all very boring, repetitive, and daily practice that needs to be followed every day so as to prevent the patient going into pneumonia and other complications. Now coming towards the CLAPSI and the COTI, the catheter blunder. The first and foremost thing that we have to take into consideration is daily necessity review. Whether my patients require the catheter or not. It is very important. So the CLAPSI bundle, so central line associated bloodstream infections. The first and foremost is while inserting the catheter, hand hygiene and maximum barrier precautions. The chlorhexidine antisepsis should be maintained. Optimal site selection is very important. We should avoid femoral as basically it causes the high rate chances of infections. First and foremost things, daily necessity review, whether the patient require the central line or not. Chlorhexidine bathing in every patient is necessary. And while using the central line every time, the scrub, we have to scrub the hub with the chlorhexidine. Now coming towards the COTI blunder. We should be very cautious while inserting a urinary catheter. Insert only when strictly indicated, not for the convenience of the staff or the nursing staff. While during insertion, the aseptic insertion should be maintained, maintain the closed drainage. In this also, we should daily review whether the patient requires or not. In case of long-term patients, like in neuro patients, consider intermittent catheter or external devices. Avoid routine irrigations. Educate the staffs, patients, and families. The foremost thing is remove early. Every additional day with line or Foley's is raise the exponentially add risk. Now coming towards the Clostridium difficile in LTAC. For Clostridium difficile thrives in LTAC environment because all the boxes are tick for them. The risk factors like prolonged broad spectrum antibiotics, the patient on PPI, the patient advancing age and immobility. So how we can prevent the Clostridium difficile or treat it? First and foremost is antiviral stewardship NEF is most important, impactful factors. In this, we should narrow the spectrum and we should stop the antibiotic when not required. Contact precautions, use soap and water. Hand hygiene is very much important. And we should know that alcohol gel not kill the spore. Once the patient is being identified with Clostridium difficile, we should isolate the patient and we should go for sporocidal cleaning. We should avoid the use of unnecessary PPI and we should only target testing in those patients who are symptomatic, not the asymptomatic patients and colonizations. Now coming towards the MDRO containment strategies, obviously they can be treated with either the horizontal and vertically. So horizontal is for all the patients, irrespective there is colonization or not. In this, foremost important is hand hygiene compliance more than 90%. Chlorhexidine bathing in all the patients who are having CVC patients or tracheotomized patients. Environmental clinic audit should be done. Antimicrobial stewardship program should be maintained. In vertical approach, it should be targeted for the patient who have colonization like active surveillance culture in the patient who are been suspected to have this MDRO. In all the patients, we can go for MRSA nears or CRE rectal swabs. Contact precautions, strict adherence to the gowns and the gloves protocols for all the MDRO patients should be done. Coordinating and dedicated staffs, geographic separations of the carriers and assigning dedicated nursings when feasible is mandatory. Combined horizontal plus vertical strategies is the greatest reduction in MDRO transmission. Now coming towards beyond the infections, there are other big 4 complications that we see in LTAC patients. First is the pressure injuries. So how we can prevent the pressure injuries? By 2 hourly turning protocols, specialty pressure mattresses like air mattresses, nutritional optimization, a high protein diet of 1.5 gram per kg, adding the micronutrients, daily Brandon score assessment should be done. DVT and pulmonary embolism, obviously at the time of the ICU admission, the patient should be given the mechanical prophylaxis like intermittent pneumatic compression devices. And once the bleeding has been ruled out after 24 to 72 hours, the patient can be started with pharmacological prophylaxis. And in case of doubt, always go for duplex ultrasounds and daily reassessment should be done. Third is the delirium. CAM ICU screening should be done and should be done in every shift. Obviously, the sleep hygiene or the environment should be maintained. Day and night cycling should be done. The family interaction should be more. Minimize the use of the benzodiazepines and early mobilization is necessary. Lastly, the nutrition. Obviously, we have to start the enteral nutrition as early as possible within 24 to 48 of the ICU admissions. Protein intake is 1.2 to 2 grams, then we gradually increase. Dietitian-led monitoring and weekly reassessment should be done. And once we are starting on the PO trials, the FES assessment and the manual assessment by the speech and language therapist is very necessary. These are the silent determinants of the LTAC functional recovery, functional outcomes, equal weight to the infection control. So the key takeaways is basically LTAC act as a clinical bridge. So once the patient is admitted in the ICUs, we should decide that this is the patient for the LTAC, and at that point, we should not waste the time more keeping that patient into the acute care or ICU setups. Second thing is that if we know that the patient is there for a longer duration of stay, is a high risk of hospital-acquired infections, so preventive measures should be done rather than treating the cause. Now coming to the third is the antimicrobial stewardshipness. It is the cornerstones for multi-drug resistant organism colonizations and clostridium difficile preventions. Fourth and most important thing is daily device necessity review for the lines, Foley's and ET tube. It is the cheapest and the most effective intervention to remove the devices. Lastly, it is a multidisciplinary culture and the intensivist should remain the clinical anchor across the continuum. Thank you.
Thank you very much, Dr. Rahul, for speeding up in the last minute and going it through very fast and furiously. And now I would like to call Dr. Gaurishankar Reddy to please join us to present the topic of capacity building training teams for LTAC specific neuro rehabilitation. Let's do this, everyone together. Thank you. Over to you, sir.
A very good evening to all. We have been listening since morning about why do we start rehabilitation, when do we start rehabilitation, then how do we do it. So it's actually done by the teams and at the ground level, and what does it require to train those teams, how do we do it. So let's just dive into it. So capacity building training teams for LTAC specific neuro rehabilitation generally requires multidisciplinary approach. Okay, it's a multidisciplinary team, and along the side high acuity medical management in LTAC care centers. Okay, right. So the unique challenges that LTAC neuro rehabilitation faces is the patients, unlike in inpatient rehabilitation facilities, they have to, the LTAC facilities with limited resources have to face the challenges of ventilator dependence, disorders of consciousness, autonomic instability, and secondary complications like contractures, pressure injuries, DVT, aspiration pneumonia. So when it comes to ventilator dependence, managing tracheostomy patients, managing mechanically ventilated patients, and the patients are in coma stage, vegetative state, so the communication is difficult. Autonomic instability patients with spinal cord injuries, they present with difficult complications like autonomic dysreflexia and paroxysmal sympathetic hyperactivity. and other hemodynamic fluctuations. So what are the core competencies that go in training a neuro rehab in LTAC is advanced neurological assessment. So every person part of neuro rehabilitation should know about advanced neurological assessment. What is simple scales like GCS, Ranko-Los Amigos level scales, NIHS scores. What is neurovital recognition, how to manage autonomic dysfunctions. We also have to train them in medically fragile mobility protocols and neuro-respiratory integration. What do we do in diaphragmatic pacing, speech walls, swallow coordination, respiratory muscle strengthening, and last but not the least, cognitive and behavioral protocols like prevention of delirium, agitation management, advanced alternative communication devices, communication strategies. Okay. So the first one being neurological assessment. So we all know the common scores, and there is also we have seen couple of cases in our ICUs. I will quote the examples while I go through the slides. So what is neurovital recognition? So staffs learn here to identify subtle signs of increased intracranial pressure. So you are moving a patient with, say, VP shunt in C2. Suddenly there is block in your VP shunt, there is raised intracranial pressure. So how do you recognize it? That's a key component. If you don't recognize it, you will not be able to treat it, right? How do you recognize a vasospasm in a subarachnoid hemorrhage patient, right? How do you recognize paroxysmal sympathetic hyperactivity, autonomic dysreflexia? So consider this as a case like, you have a patient with spinal cord injury above the T6 level, you are trying to mobilize him, suddenly the patient goes into tachycardia, sweating, okay, severe headache, okay, then you don't know what to do. So it could be one of the autonomic dysreflexia complications that we encounter. So you suddenly lower the legs of the patient, treat the hypertension, and see what are the triggering factors. The factors could be simple like, a bladder full, constipation, tight clothings, some pressing bandage. Right? There is also something called as other neurological complications. Will not go into much detail. Next is how do we mobilize medically fragile patients with ventilator and tracheostomy in C2? How do we secure your tracheostomy? How do you secure your lines and tubes? We do mobilize patients with ECMO. The ECMO is has a very wide tubes, pumping blood up to 5 liters per minute. And how do you manage orthostatic hypotension? So all these trainings have to be inculcated so that you avoid complications. So the optimizing early ICU mobilization and rehabilitation includes multidisciplinary team, and you have to concentrate on quality improvement process. What are the identify the barriers and implement the facilitators. Communication is very important. There are few patient preferences need to be addressed. Safety criteria. Implement bundles for pain, sedation, and sleep and delirium. How many of us offer patients eye blinds in the ICU? How many of us offer earbuds to the patients in the ICU? Do we actually ask them next day morning, oh, how did you have? Was your sleep good enough? Do you actually take the history of alcohol abuse or some other abuse that is, hampering their cognitive behavior in the ICU? Okay, all these things. And often evaluate optimal timing, dose of interventions, and you have to also evaluate the performance. So this is a mobilization of an unconscious patient on ventilator from bed to chair using a hoist. So it is passive mobilization. Even though the patient is on ventilator, we can do. These are a few examples of patients being mobilized on a tilt table with ventilator and patient on ventilator being walking, right? So whenever you think of mobilizing a patient, we use something called as Plan B. Plan B basically means that how do you respond to some complication, unintended complication that happens. The same is being used as a mnemonic. First you prepare for mobilization, discuss the case with the team. The team consists of a physician or intensivist, anesthetist, you have physiotherapy, you have respiratory therapy, you have psychologist, you have a family member around, right? Discuss the case. The patient is also made aware that you will be mobilized out of the bed. You will be mobilized from sitting to standing. You will be mobilized on a wheelchair, right? Then you keep the equipment ready, make the appropriate preparation, then communicate. The leader takes the role of communicating. Airway and emergency equipment is ready. You never know when the decannulation will happen, when the lines will come out, when there will be bleeding. So when we are mobilizing a ECMO patient, we keep a CTVS surgeon beside us. If at all there is some decannulation, he can secure the lines ASAP. You are managing a neurosurgical patient, we have a neurosurgical resident or a junior consultant around us. So you decide the number of staff and you have a backup plan. If something goes wrong, what do you do, right? Then comes diaphragmatic pacing and training for respiratory muscles, speech and swallow therapy. Cognitive part, mostly it is neglected, so you have to prevent delirium. Prevention of the delirium is best intervention to avoid delirium. Okay, you have to preserve the sleep-wake cycle, environmental modifications, sensory stimulation protocols, and we have to manage agitation with appropriate drugs. And communication, most of the times it's simple communication, the language barrier that will make the patient calm. So it is a multidisciplinary team, and the roles are very clear. May it be nursing, respiratory therapy, physical therapy, occupational, speech language, and the physicians. They have their designated roles and they have to act accordingly. So how do you, the strategy is simple. First, give them the training, then use a simulation-based scenarios. For example, in ACLS, we do something called as mega codes. We create a scenario. You have a patient, he has arrested, how do you act? Similarly, you are rehabilitating a patient, ECMO patient, or an intubated patient, suddenly the tube comes out, what do you do? So create those scenarios. Then create champions out of them. We call neuro champions. Create a champion out of them who will train further his teammates. And there is continuous quality improvement. You can do your checks by performance indicators. You look at your clinical outcomes. What was your time to ventilator weaning? How many pressure injuries happened? How many successful transitions happened? What is your fall ratio? Unexplained extubations? How many lines get dislodged? Okay. And staff metrics also depends. Okay. So to summarize, the traditional way of rehabilitation with the help of advanced AI and robotics are coming in, and the core principle remains same. It is integrating rehabilitation with acute medical management. So the rehabilitation from passive to proactive, it is multidisciplinary. The culture is not as optional, it is essential. Educate, engage, execute and evaluate. Involve family. So here are, can you play this video please? Yeah, this is the last slide. So here is a patient who is on ECMO, on ventilator, tracheostomized, made to sit out of the bed on a chair, and he is barely able to move his fingers to throw the ball, but rehabilitation still continues in the ICU. Can we have next slide please? Play the video please. She was a patient who was waiting for lung transplant. This is after lung transplant, on ECMO, moving. We have a family member ahead encouraging her. We have a physiotherapist, team taking care of the mobility. We have respiratory therapist and the intensivist. So on ECMO, the patient is walking. Yeah, and there are many more cases. And this is how we move patients in the ICU. Thank you very much.
Thank you very much, Dr. Reddy. What a fantastic, full-on technical and full information-filled session. To honor you guys, I request Mr. Amit Kumar to please join me on stage. Ladies and gentlemen, joining us on stage, Joint Secretary Recovery 1 2026, Mr. Amit Kumar. Let's bring in the memento for Dr. Yashish Paliwal, please. Thank you, Dr. Yashish, for joining us today. He spoke on how early is too early, defining the ICU rehabilitation window. I request Dr. M. Karthik to please join us. Thank you very much, Dr. Karthik, for being so energetic since morning. We've completed a fabulous session with you. So today we have a special award for the best cheerer in the room, and let me see who gets that. Definitely you. Can I request now Dr. Rahul Ghia to please step forward? You want the award? Thank you very much, Dr. Rahul, for joining us today. Consultant Critical Care Inc., Kolkata, gentleman belong from. And Dr. Gauri Shankar Reddy, also enthusiastic player in the room, stepping forward. You can put your hands together. Nobody in this room is stopping you from this, trust me. And finally, inviting a keynote speaker, Dr. Vishnu Vardhan Raju sir. The discussions today emphasize the importance of structured long-term acute care systems in enabling sustainable recovery outcomes, reducing complications, and improving quality of life for patients transitioning beyond intensive care. Thank you very much, all the gentlemen. We've taken the group picture when Ms. Pooja was here with us. Thank you. Please have your seats. It was great having you. And now it's time we move to the final session, the session 6. How many of you are ready for the last session? Can I see your hands up? All right, especially for the people at the back, they are the ones who are raising their hands. Can I see your hands up, people at the back, everyone? They are the ones who are actively listening. Am I right or am I right? Yes? Can you show me the thumbs up if I'm right? Fantastic. Moving straight away into the session, we need 6 chairs on the stage. Multidisciplinary recovery, enhancing outcomes through collaborations. Proudly, I would like to invite our keynote speaker, Dr. Professor S.L. Yadav, Head PMR Services, HCAH, India. Please join us, sir. I would also like to invite Dr. Rakesh Nair, Senior Consultant, Ayurved, Bangalore. Dr. B.K. Yamini, Professor and Head Department of Speech Pathology and Audiology, NIMS Hans, Bangalore. Dr. Shiva Shankar, President IAPE and Chief Clinical Nutritionist, Tata Memorial Hospital, Mumbai. Dr. J.N. Stravana Kumar, HOD, Physiotherapy, NIMS, Hyderabad. And Dr. Soumyakanta Sahu, Co-Founder, Director, Samagam Therapeutics. And now, as we have been waiting for all of them to join us, let's put our hands together for all the panelists, please. I request Dr. Saurabha Mandal, Head of Occupational Therapy, Department, Continental Hospitals, Hyderabad, to please join us on stage. You are taking that special award, and I got it. You are clapping from everywhere in the corner. Since morning, I have been observing you. All right, so I request now Dr. Professor S.L. Yadav to please come forward and present. Let's give a huge round of applause to the speakers. You are fantastic since morning. Let's go for it. Sir,
I think it's a last session for the day, or maybe for the conference. So, good evening, everyone. At the outset, I would like to congratulate Dr. Vijay, Dr. Prateek, for their taking this conference up within a very short span of period, like maybe less than 3 months. So the way fast as they conceived the idea, they proven it, and they made to the reality, that's really aligned with the theme of the faster recovery. And under the great leadership of Dr. Tokral, Amit, both the Amits, and I'm not able to see the naughty boy, Dr. Nishant. He also provided a lot of input to have this conference very successful. You're welcome, sir. I cannot. Okay. Okay. So my task has been already, made very simplified since the morning. The first speaker to until now, whatever, all of them I heard, and I find that my task has been already summed up by all the speakers. So I really don't know that what I need to speak now. So anyway, I'll just take you through like whatever slides are there. Okay. And I will not stand along between you and the esteemed panel which is sitting here, so probably you would like to hear them most rather than me alone. So I think there is some technicality issues. No problem, then you can. Dr. Shiv. Oh, sorry. Should I think Dr. Shiv Shankar can come and present, meanwhile, because they are taking care of it. Okay. Okay. Okay, for everybody. Oh, yeah.
So while we all know how to best utilize the time, while the system is restarting, we should do the memento presentation and a group picture before we actually do the session. So can I please invite Mr. Rahul Jain and Mr. Aminder to please join me on stage, please? Yes, yes, yes. And we are very good at managing time. I'm sure the department that we all belong to, we know what to do, when, and how to fill in the time. So, Mr. Aminder Malik, Committee Member, Recovery 1 2026, as well as Mr. Rahul Jain, in charge Social Media and PR, Recovery 1 2026, are on the stage. And let's bring in the memento for Dr. and Professor S.L. Yadav. And the picture and the smile has to be like the session is over. Alright, you have to smile that way, not like we have not started the session. So let's do justice with the photograph at least. And now I request Dr. Rakesh Nair to please step forward. Thank you very much, sir, for joining us. We are waiting to hear you. And now I request Dr. B.K. Yamineji to come forward, please. Ma'am is practicing a smile right from there. I would like to invite Dr. Shiva Shankar to please come forward. Dr. J.N. Shravana Kumar. And now I request the most beautiful smile this evening, Mr. Saurabh Mandal, to please come forward. He has been literally blushing the moment he entered on the stage. Let's put our hands together for the gentleman, please. And now for the group picture, I invite everyone to please join at the center stage, please. Please join the picture. Dr. Gaurav, you would like to please join the picture. If I'm missing anything, please let me know. Yes, Mr. Ankit Goel. Yes. Careful, please. Everybody on a successful event, Recovery 1 2026. All right, so you all took the mementos and picture feeling like the session is over, but the session is not over. Session will start now and we will get started with Dr. Shiva Shankar. Sir, over to you.
Again, a history is being created without the presentation. Someone else was speaking and I have taken the ahead of it. I have just 5 to 7 minutes left, so I'm going to speak regarding the nutritional aspect in the rehabilitation. In 2023, India Association for Parental-Enteral Nutrition came out with a Chennai Declaration. During that Chennai Declaration, yes, this is the one, we did mention about the importance of nutrition, and it is a fundamental right of every patient walking into a hospital. So every patient who walks into a hospital, they have to get the nutritional attention. That was the most important thing. Should I change the slide or? Okay, we all know where the malnutrition is, even though it is just next to us, but we always give a blind eye and it still remains unresolved. And we did have a survey done by the IAP in India, and we found that out of 423 hospitals where we surveyed, 87 hospitals didn't have a dietetic services. So how is that those patients may get a nutritional attention? Why malnutrition is an important factor to be addressed? It has the ability to heal, adapt and respond to the treatment, but whereas during the malnutrition, the body behaves in a very different way. There's a delayed wound healing, there's a weakness of the muscles, and there's a loss of strength, there's an immobility, and the nutrients such as collagen or arginine, omega-3 fatty acids, or HMB, these are the nutrients which are not being taken into consideration while recommending a diet. Also, the chances of infection and the anastomotic leak and the other infections and the patient becoming a dependent post the treatment is again a challenge. How far the patient remains productive during post the treatment if the rehabilitation is not as good as we actually are debating upon these things. Yes, there is an altered pharmacokinetics if there is a muscle mass loss and the drugs requirement normally increases. Ultimately, the end result is the quality of life, what is affecting to the patient. So what happens after the surgery is it's a stress which makes a lot of hormones to be released like cortisol, catecholamines, and the inflammatory cytokines. These are the ones which will directly attack the muscle mass. And as a nutritionist, our focus will be to retain the muscle mass as far as possible, just not by the diet, even with the physical activities and the resistance exercise. Protein is the only nutrient in the body where without any exercise, it wouldn't be stored in the body. Whereas fat, carbohydrates, and other nutrients can get stored, but not the protein. That is why the mobility is so important over here. And all these catecholamines and the cortisol and the inflammatory cytokines do induce insulin resistance, and insulin resistance increases the hyperglycemia incidence. And hyperglycemia is the one which will induce lot of chances for the infection part. As we heard, the previous speakers do speak about these matters. So the impact of the surgery are many. I wouldn't go into the details of this. Many people have already spoken about it. But when it comes to the rehabilitation, the second part, the green one, what you can see is again I come to the point stating that the retaining of the muscle mass and the building of the muscle mass is the most important thing. And the delayed wound healing, can be expedited for the wound healing, what are the nutrients which are required, mainly the arginine, omega-3 and the nucleotides which have been considered to be expediting the wound healing process, and the altered body composition. That is what I keep on saying. Once the patient is being discharged, within a year, they normally increase around 20 to 25% of fat mass, not the fat-free mass. So the fat mass is the ones, what is going to be increased is going to be a kind of a new situation where more chronic diseases are being welcomed over here. Even the patient has gone treated from the hospital. So the body thinks surgery is an attack, and the brain actually induces a lot of wrong signals, and all those cortisols and catecholamines, what I mentioned about, the hormones are being released and the immune system is at challenge. And this leads to the situations where the release of these stress hormones and the activation of the inflammation, which leads to the increased energy demand. Are we feeding these increased demand adequately? Again, a question marks. Every time we keep speaking about the protein content, but are we really meeting even the energy post the surgeries? That is, I would say it's again a very challenging, because the feeding itself becomes very compromised. So nutrition care process for faster recovery, there is an SOP, whether it can be started before the treatment or it can be started after the treatment at the time of recovery and rehabilitation. Nutrition screening is the starting point where it has to be done almost to all the patients walking into the hospital. If the screening is positive, the patient has to go for nutritional assessment, a proper nutritional dialogue by a qualified dietitians, then the diet planning. Diet planning involves a lot of the counseling or the ONS or the ENPN, any kind of a regimen which would like to be meeting the patient's requirement. A structured follow-up and the nutritional changes, whichever is required in between the treatment and the peri-treatment, when we talk about the peri-treatment nutrition, that is the immunonutrients 5 to 7 days before the surgery, 5 to 7 days after the surgery, along with the physical activities, may change the desired, may promote the desired end result of the treatment, what the surgeon is trying to look out for. Early mobilization, expedite recovery and the rehabilitation and the survivorship, that is where actually the nutritional intervention stops over there. It is just not the treatment. When it gets over, our treatment, the nutritional intervention stops. Earlier speakers have already spoken about the importance of the nutrition. I wouldn't go into that one, but I would like to emphasize on that the particular nutrients like arginine, glutamine, omega-3 fatty acids, vitamin C, zinc and vitamin D3 are the ones which we need to really focus upon. So advantages of early nutrition, yes, it preserves the gut integrity, infection chances are being reduced, catabolic responses are being better handled, wound healing is expedited, immune function is being activated, and the hospital stay and recovery time is being reduced, post-operative complications are reduced, better glycemic control, and the contraindications for early feeding, because we now say ki immediately after the surgery, within 24 hours, we need to start feeding the patient. Hemodynamic instability is the one where we need to be careful while feeding the patients. Uncontrolled sepsis, intestinal obstructions, bowel ischemia and perforation, high output of fistula, and severe malabsorption or intolerance, and active gastrointestinal bleeding, along with risk of aspiration. These are the conditions where we need to go for slow feedings. Why insulin resistance matters? It increases the chances of infection, it delays the wound healing, chances of sepsis are high, muscle breakdown increases, hospital stay and recovery lengthens, post-operative complications and mortality increases. This is a 100-year-old photograph. This patient was discharged from the European hospital, and even now also in some of the government hospitals, similar kind of pictures we can see. So we need to really come together and understand the importance of the nutrition. It has to start as early as possible, and the nutritional assessment has to be a part of the medical diagnosis. This is again a part of the Chennai Declaration, what I spoke in the beginning. The nutritional evaluation has to be the first time when the doctor is meeting the patient and evaluating and recommending all the investigation. At the same time, the nutritional evaluation has to be recommended on the first meeting itself. Though screening is the beginning, and this is a very simple tool which India Association for Parental Nutrition has recommended for the Indian population. Very simple, easy to be translated into any of the Indian languages, and it can be screened by the patient himself. You don't need a qualified person to do that one. If the answer is yes for any one of the questions, the patient has to be referred to the dietitian. Malnutrition care workflow is very simplified by the theories, and very few hospitals are practicing the way the workflow has been prescribed. It is a screening followed by assessment, followed by the nutritional diagnosis, well-planned care development, interventional implementations, and the monitoring and evaluation of discharge plannings. So thank you all for listening me, and thank you for considering me for promotion of my talk. Thank you once again. I may not be here for any question answer.
Thank you very much, sir. You are not here for question answer, but I have a question for you. Did you plan to register your name in Guinness Book of World Record for being the fastest presenter ever? Non-stop, without even breathing. Let's hear it for the gentleman, everyone. I would now request Dr. S.L. Yadav to please take over. Thank you. And thank you very much once again, Dr. Shiv Shankar. I know he is in a hurry and his presentation has also been fast and furious.
This one, no? Okay. Yeah, sorry for the inconvenience. So I'm back now again. So I will be just taking you through multidisciplinary rehabilitation team and what are the models being practiced in India. As we all know, like there is a growing population and the age-related complications and non-communicable diseases are on the rise. So the patient for the rehab services had become the need of the hour these days. And there is, despite of, the available facility, there are so many challenges in the India available because now there is an increase in the survival rate. So survival rate is the final, what goes beyond the survival, because nobody talks about the functionality. So where we come rehab people that they should have the functional recovery so they can go back to the community again and maybe, they can earn the livelihood. So there is a need of the hour is the early multidisciplinary rehabilitation. So, and the multidisciplinary rehabilitation required from the ICU to the inpatient rehabilitation. And early rehabilitation prevent the complications and the accelerate the functional recovery. That's why, since morning everybody you are talking about that aspect, that early rehabilitation is the need of the hour to have the better recovery. Then comes to the transitional care to the community rehabilitation, what the HCAH is doing at the moment. And I think they are the first pioneer. They started this transitional care program. Afterwards, so many other, the corporate hospitals, they have chosen to have this transitional care model in their practice. because rehabilitation should continue beyond discharge until meaningful community participation achieved. So that is the motto of the Transition Care Rehabilitation Program. As we all know, the PMR physician integrates the multiple disciplines into the coordinated recovery pathway. So that way, the team leader is a very important component for any rehab program. And as we all aware, there is a multiply disciplinary team is comprised of the physiotherapists, occupational therapy, speech and language therapists, rehabilitation nurse, clinical psychologist. So one team, many skills, but there is one goal, that's a better life for the person who is undergoing the rehab program. So other team members like dietitian, which you have heard very recently, like that was the role of the dietitian into the rehab program. So then question comes, then why multidisciplinary rehabilitation? Because there is evidences and the impact of the multiple disciplinary team. And also, like there is a goal, one goal with the multiple disciplinary team is the restoring function, enabling independence and enhancing the lives. So the approach should be the right team, right intervention at the right time to have the better outcome. Across the country, there is so many rehabilitation models are being practiced, like from institutional-based rehabilitation to home-based to community to NGO-based rehabilitation program. But having said that, the different models, but the goal is one, to have the better recovery for all individuals. So the transitional care model, which is ensuring continuity in rehabilitation, they helps to have the early discharge planning. There is interdisciplinary coordination. So the caregivers also being trained that after the discharge from the transitional care at the home setup, that what sort of things they need to do with those patients who have been discharged at home, then home modification assessment or tele-rehabilitation follow-up. Because to have any successful rehabilitation is not defined only by discharge, but the continuity of the recovery after discharge. That's a very important component that we need to understand. So what HCAH is doing is a transitional care which reduces the complications and ensuring the continuum of care after the hospitalization patient and before they're being discharged to the home. So they give the personalized care designed to meet the individual's patient's need to have the better outcome. And like they also provide the easy and accessible rehabilitation program, and like which is convenient and state-of-the-art facilities under the one roof and at the same time with low cost. With optimum care with the low cost is the motto of the HCAH transitional care. Then been already discussed about the technology, what technology is there and what are the challenges and the opportunities. So India needs a scalable rehabilitation system connecting hospitals, homes and the communities. So that's what HCAH is doing currently. So the take-home message is like the multidisciplinary rehabilitation is essential for the optimal recovery, and there has to be continuum care from the acute to until they're established in the community. So for that matter, the right intervention at right time with the right team should be the approach which currently is being practiced at the HCAH. Thank you very much for patient hearing. Thank you very much.
Thank you very much, sir. I request you to please stay back on stage with us. I request Dr. Munim and Dr. Shankar to please join us on stage. And I request you to present the mementos for them, please. And hence such a hurry. Otherwise, you would also leave. Sorry, ke saath jana hai. Presenting the memento to Dr. Munim, please. Let's put our hands together, ladies and gentlemen. Can we have the photographer joining us if he stepped out for a bio break maybe? And Dr. Shankar to step forward, please. Thank you very much, dear doctors, for all the contributions from your end towards making Recovery One Conference 2026 a superb grand success. Thank you very much, Professor, for joining us as well. And now I request Dr. B.K. Yamini ma'am to please step forward for the presentation. Thank you very much, sir. We've heard that even ma'am has a flight to catch. Let's hear it for her, everyone.
Good evening, everyone. At the outset, I thank Dr. Gaurav and Dr. Vijay, the organizers of this conference, and Dr. Divya and team, Dr. Supreet and team for all the organization and the hospitality. Thank you very much. Thank the Rehab Hosps for inviting me to speak on this. So the title is, Does the Professional Audiologist and Speech Language Pathologist Really Matter in Recovery? I'm not sure how many of you are aware of the presence of the profession itself. It is of late that the people are aware. And I see that in a lot of previous presentations, the role is emphasized. I thank them all for it. Yes. So, I went back. Right. So, there is a role in the ICU. How? Because there is going to be add-on information by the ASLP. What is it that the person is going to add on? A lot of information related to hearing, the past communication. So, for example, someone who has had a hearing loss must have had a stroke. So, and then they would have recorded it as someone with hearing loss had a stroke. We want to know whether the hearing loss was asymmetric. Was the person using a hearing aid? So, this way, the ASLP plays a huge role in giving us more information, adding on to the history itself. Yes. Then, of course, during the wakefulness, the dysphagia status, as mentioned earlier also, will be looked into, the screening, the secretion management, the swallow issues. And it is important, and the decision is taken whether, the instrumental assessment has to be done or just a bedside screening is sufficient. All this can be done by the ASLP. Apart from that, we'll join the tracheostomy team in the tracheostomy care as well as weaning. Then even looking into the communication management, assessment and the management, because it's very important when somebody is on a ventilator, they'll be using gestures for communication. So a lot of this can be looked into. And once the person is extubated, how was the voice, what is the recover, how is the voice going to recover, will it recover or not? So a lot of this, because we know that there can be an inflammation or there could be subluxation, various reasons why, such a, the voice recovery can be inhibited. So that can be looked into. And AAC, definitely, low-tech AAC, because the person is in the ICU initially, and something like, photographs, pictures, or icons can be used, and to determine communication, and then, of course, participate in the cognitive rehabilitation. Patients are very often, can sometimes be in the near coma state, so it's very important during the sensory stimulation that caution is executed, that it's not overstimulation because the brain gets habituated. So the right amount of sensory stimulation needs to be provided, so that can also be provided by the ASLP. So the key focus areas would be the early intervention, the patient safety and advocacy, and hence the quality of life is taken care of by, for the patient, definitely. So I'm going to just present you a study. Now I'm going to cover just two conditions which we very commonly see. Fall not just in ICU, but just after that, the aphasia, which is post-stroke, and 21 to 38% of them have aphasia in the acute period. So I'm presenting a study here wherein what they looked at was the role of a SLP in speech-language intervention according to the arterial involvement and lesion location. Okay, so they did a aphasia assessment and they found, the MCA, those with, MCA artery infarct had a bad score. So they asked the SLP to provide the treatment, and they found that those with MCA territory infarct improved significantly than one compared to the other, that is the ACA as well as the PCA. Possibly one reason is, the PCA and the ACA may not have so much of language speech impairment as much as that of the MCA, because we know that the areas related to related to language are all there in this particular area. So, yes, so then I'm going to look at, so which means that the ASLP can start the intervention program at the earliest, and then has apply the strategies and look for improvement in communication. So what about in conditions with dementia and mild cognitive impairment? So here again, it is possible to do a direct assessment. There are plenty of scales, and treatment of communication strategies is possible. Then dysphagia rehab is also possible, but not only that, we do a lot of counseling, collaboration, prevention, and wellness. So what is this counseling? According to American Speech and Hearing Association, it says interactions related to emotional reactions, thoughts, feelings, and behaviors that result from living with communication disorder, feeding and swallowing disorder, or related disorders. So it's important to tackle that part, otherwise there will be no progress made in communication, or there would be no improvement in the quality of life. And prevention and wellness. So this is another thing. For example, it would be, one of the strategies that, there could be a patient who says, I still would like to go out for a walk all alone. A person with dementia, I want to go out for a walk all alone. But will he come back safely? So how do we work on that? So it is important to give him a paradigm so that he reads every board. So literacy, reading, comprehension, and communication is emphasized at this stage, so that he reads every the name of the, let's say 10th main, 11th main, and then he comes back to his own residence very safely. So a lot of such communication strategies can be provided in order to prevent further problems, complications as a result of a particular neurological condition or a neuropsychiatric condition. Then collaboration, of course, that is communicating with the rest of the team. Yes. So is it possible for a person that is an ASLP to actually perform this? The answer is yes, because they have clinics every day. They see patients every day in their undergrad program, and they have a whole lot of courses related to speech pathology and audiology, which train them so that they can get into such intensive areas of assessment and intervention. I'm presenting this because there are a lot of individuals who are unaware of the profession, the role of the professional, to approach this professional to seek their services. So that is the reason, the mother for the presentation. So yes, so in other way around, the ASLP, the audiologist and speech language pathologist, has a huge role to play, right, at every point of time, to enable fastest recovery and reduce the avoidable disability. Thank you, one and all.
Thank you very much, ma'am, on highlighting the role of the audiologist and speech language therapist, because I myself know a few friends and have family members who are serving this role, and they come extremely happy while coming back by treating so many people at hand. And thank you so much for your time.
Thank you very much.
I would like to now invite Dr. Rakesh Nair to please take the podium and go for the presentation. Thank you. Let's have a round of applause for the gentleman. Dr. Rakesh Nair, over to you.
Very good evening, one and all. Firstly, I thank Dr. Gaurav and the organizing team for giving an opportunity to speak about my topic in front of the experts. Ladies and gentlemen, distinguished speakers, and esteemed colleagues and fellow healers. After this insightful and depth exploration of rehab techniques and having an illumination of the frontiers and of recovery and resilience, let us now turn to an ancient time of healing, timeless, but a very good ally, Ayurveda. Ayurveda, a profound science of holistic healing. So, as respected Dr. Yu Singh had quoted from volatile previous part, occupied in the restoration of health in sync with the universe, Ayurveda doesn't stand apart, but it weaves seamlessly into it, harmonizing the body's innate wisdom with targeted intervention, not to restore function, but vitality. So, for a recovery, there are barriers. We, rehabilitation specialist, has multiple barriers. It could be apoptosis, it could be psychological conditions such as anxiety, depression, impeded BBB, or anosmia, or associated comorbidities. And it can also be systemic and chronic inflammation, or the atrophy penalty, which is the strength loss, or it could be spasticity, right? And majority being the pain. So, while the team is onto this kind of symptoms, Ayurveda can be a part of the healing in accelerated recovery, right? How does it tackle? It tackles the host microenvironment. That is, it tackles the gut inflammation. We all know there is something like the gut-brain axis, and the role of metabolism plays a crucial part in inflammation. Ayurveda, as an ancient healing, tries to tackle the gut in its whole part. As a result, the patient is treated holistically, what we call as a whole person care, and not the symptoms or the diseases. So, how does it define? As early as 600 BC, Acharya Sushruta, the father of Indian surgery, has always defined health as samadosha, samagnischa, samadhatu, malakriya, prasanna atma manahindriya. That is not only the physical, but the manas, atma, and the sense organs, both vital sense organs as well as the physical organs, which we call it as the virtuous cycle of good health. Now, when we say virtuous cycle of good health, it means not only the physical activities, it means good appetite, good metabolism, good sleep, clear excretion, both solid and liquid excretion, clear senses, the alertness, cheerful, calm self-affair, the vitality, and the longevity. So, while the major core treatment is going on, Ayurveda in parallel can tackle these conditions for every patient, irrespective of any conditions, let it be prehab, rehab, or any conditions, wellness, things like that. So what does this integrative neuro rehab program means? It means that it's a holistic assessment and evaluation of the disease etiopathogenesis. We all spoke from the evolution of the disease, but we on our evaluation, why did that disease occur? Except for road traffic accidents. It could be a stroke. Why did an ischemic stroke occur? Why did a bleeding stroke occur? So these are the conditions where why did that patient suffer that condition? So the disease etiopathogenesis on a proper consultation or proper assessment evolves. Why did that occur? It also assesses the residual impairment, which means once the recovery is going on, what could be the possible residual impairment a patient can occur? It also stages the functional limitations and participation disability. And overall, the very important part, which is the metabolism status and the inflammation status. By doing this, it also gives an assessment of symptoms, what needs to be elevated on top priority. It also gives us the whole person healing part. So, is it been done? So, the moment we say Ayurveda, we all think it is tel ka malish, tel malish. No. It is not like that. It's not massages included. It involves a proper assessment of a disease condition, its staging, and how is the functional health parameters, and what is the strength of the patient as told in Ayurvedic texts, right? It also, after a proper assessment, gives a proper planning on diet and lifestyle based on the constitution of the body. So we have something like the physical constitution, right? We call it as a prakriti of the body. So what is the food which is very good for our prakriti, and what is the food which is not good for the present conditions? It also gives the nature of the morbidity. It analyzes the body components affected and understands the vigor of the diseases and plan an effective treatment blueprint. So these things can be very good in theoretical. Is it well practiced? Yes, it is well practiced. So these are the therapeutic management, which is called as the preparatory therapies. So the patient is not put into therapies at a stretch. There's a set of preparation. The preparation is being assessed. Is it been got all the treatments? What is being done to the patient is being properly managed, monitored, and then go to the main treatment, which is called as the cleansing treatment or the panchakarma. So what happens when an integrative rehab? So while the protocols are there, from morning we have been hearing this, but when we add Ayurveda as a part of the team, it also gives an added benefit for the patient, one, to reduce the inflammation. It also promotes cognitive healing because the moment the gut is being tackled, the cognition improves. It doesn't go into decline. It also improves the functional health parameters. The functional health parameters here means the sleep and other parameters which I've showed in the earlier slides. It also restores the gut microbiome. So the extra medications which is required to assist the gut can be weaned. It also regulates the circadian rhythm. Circadian rhythm means day in, day out syndrome. So the patient doesn't know what is day in, what is morning, what is night. So by doing these therapies, it always limits or it always accesses to the circadian rhythm, the sunrise, sunset protocols, and also reduces the oxidative stress. So it starts with something like the bedside therapies, right? And something like a external therapies as simple as for this condition where this elderly gentleman had global aphasia. This has been treated with one of our centers in HCAH Suvitas, Hyderabad. So he was hesitant to speak, he was not speaking. Can I have the volume, please? Volume. So by the way, the first word this elderly gentleman tells is Amma. And I take this opportunity to wish the ladies a very warm, happy Mother's Day. You have sacrificed this day for this program, hence this also. So it's not only for the age limited. So once the patient gets like this kind of recoveries by using a small therapies, it is a joy for the whole team when the recovery is there. So this is another case where we had jointly dealt in HCAH Suvitas with multiple diagnoses, septic shock, you see, the wedge compression fracture, hypokalemia, but she had her very nagging symptom of abdomen pain, very bad abdominal pain, treated recently, where the patient had to transfer from our center to the main hospital to and fro for the pain, right? Just with some small application of medicated paste on the umbilical region, the pain was subsided from 5 to 2. That is, the NSAIDs were weaned, the pain was sustainable, the pain was cleared, and the condition what we tell was just a flatus. So just by application of medicated paste on the umbilical, the flatus was released, and the pain was, released. So these are the small therapies which we can help in the patient's recovery when they have an associated problems. So how is it done? What is the dynamics of an integrative neuro rehab program? So we don't stop the conventional medicines, we don't stop the conventional, the therapies and things like that. But added to that, if we do a diet, as the previous speaker has told, keeping in mind on your digestion, metabolism, inflammations, the lifestyle, the medicine and the therapies, when it goes hand in hand with rehab, the recovery is accelerated, right? So this is one of the example where the acute phase is done by the neurosurgery, which is phase 1 and phase 2. Once the acute phase is finished, then a team headed by neurosurgery along with Ayurveda and physiatry takes care of the neuro rehab. So I also would like to clarify that the objectives between the neuro rehabs, physiatry and Ayurveda doesn't clash, right? By doing that, the outcome scales is being marked and it has been improved. So what is differentiated from the other Ayurveda players is a 360 degrees outcome tracking. It's not only the specific biomarkers, it is not only the international outcome scales, but it is also the functional health and also the customer delight post discharge. So this is what you can expect through an integrative recovery program, a holistic 360 degrees recovery from higher mental function, sympathetic and parasympathetic activity, sensory motor function, oromotor system, bowel bladder health. So truly co-managed care, integrative care is a patient-centric care, right? And we have that data with 4,250 patients with not only the thing, but the whole teams aligned with the clarity of objectives with multiple care. Thank you.
Thank you very much, Dr. Rakesh Nair, for stressing on how important Ayurveda is in terms with our event today. Thank you so much. And now I would like to invite Dr. J. N. Shravan Kumar to present, please. Let's put our hands together for the gentleman, our last second speaker for the day, everyone.
Good evening, everyone. At this outset, I'd like to thank Dr. Vijay and Dr. Supraja for inviting me for the conference. And also, I would like to congratulate Suvitas, for putting up a great show in Hyderabad. So today, I will be talking about, blood flow restriction training. So blood flow restriction training has gained a lot of attention in the past decade. So initially, blood flow restriction training was used exclusively for athletes. Mostly athletes, most of you would have seen, athletes wearing a cuffs and, walking, running, jogging, or doing the weights in the gymnasiums. But later, blood flow restriction training has been used in rehab for treating most of the musculoskeletal problems. Now, there is a lot of research on blood flow restriction training where BFR is also used in patients in ICUs. So if you look at any individual, the main problem any person faces is, sarcopenia. So they end up with, muscle weakness. So that is the main factor. Most of the patients, they suffer at the end stages of their life. So it might be because of, multiple factors such as, the lifestyle, the biological factors, and the psychosocial factors. All these contribute for sarcopenia. So as a therapist, the biggest challenge is, how to tackle this sarcopenia. That is the biggest challenge as a therapist. So if you look at the strength decline, so whatever strength you attain till 25 years of your age is the maximum strength. After 25 years of age, there is a scope for you to maintain the muscle strength, or otherwise, it keeps rapidly declining at a rate of 8% per year from 40 to 70 years of age. So after 70 years of age, the strength declines, at a rate of, 15%, per year, which is very, very, critical after 70 years of age. So it is very, very essential that each and every person, has to maintain the strength. Otherwise, it becomes very difficult in the recovery process. So now, as a therapist, my challenge is, how to improve the strength. The book says that, if you want to improve the strength, you have to exercise at a rate of 60 to 70% of one repetition maximum. But what about people who are in the ICUs? What about people who are chronically bedridden for a longer duration of a time? So is it possible to make them exercise with 60 to 70% of RM? So we have two different protocols for strength training. One is called as an Oxford protocol, and the next one is called as a DLOMS protocol. The Oxford protocol says that you have to lift weight 100% of one RM in the first set, and the second set is 75% of the RM, and the third set is 50% of the RM. So all these protocols were designed or developed 75 years ago. So contradicting to Oxford protocol, DLOM has come up with a different protocol where it is not essential, it is not suitable for patients to lift at 100% of RM. So gradually he has come with the first set of 50% of RM, 75 and 100% of RMs. So but in the rehab process, when a patient is bedridden or because of injury, because of sickness, or because of illness or multiple factors, it becomes very difficult for a therapist to practice these principles, so Oxford and as well as DLOM. So in this era, blood flow restriction training, is gaining popularity. Is gaining popularity in order to counteract muscle weakness. So suppose if a patient's, one limb is fractured or he is immobilized, but he is unable to move the other limb, as a result he develops sarcopenia. So in those cases, in order to prevent atrophy of that muscle, you can use blood flow restriction training. So the main principle of blood flow restriction training is that the arterial blood flow is partially restricted, whereas venous blood flow is completely restricted. As a result, there is hypoxia and there is pooling of blood. The muscle maintains its anabolic effect. This is the main principle of blood flow restriction training. So apart from this, blood flow restriction training, there's a lot of research, which has been emphasized by a Japanese person called as a Katsu. Katsu was the first person who was taken a lot of time in inventing, different devices of blood flow restriction training, and he has, published many articles on these devices. And if you can see now, as most of the Japanese and as well as the Chinese, in order to improve their strength, they lift less amount of weight and they improve their muscle strength. So if you look at these devices, which are available, there are different types of devices. One is called as an auto-regulated device, and the next one is called as a non-auto-regulated device. Auto-regulated device, the pressure is constant, throughout the movement. Whereas non-auto-regulated device, the pressure is not constant. It is not regulated with the blood flow. So there are different types of cuffs, which are available. Each and every color indicates, the different types of limbs where you can apply the cuff. The cuffs also come with, different contours. You have got, straight cuffs. You also have got contour cuffs. You also have got multi-chambered cuffs, and you also have got a single-chambered cuff. Based on the requirement, the cuffs can be selected by the therapist and can be used for the exercise and as well as the rehab program. So what is known, till now about the blood flow restriction training is only a tip of an iceberg. There is so much to be studied, especially in areas with patients who are in ICUs. But moreover, so blood flow restriction training has been successfully studied in conditions like sarcopenia, in geriatric populations, in arthritis and all the other clinical conditions as well. So main thing is that the application of the cuff is very, very important. The cuff is always applied proximal to the limbs. It's always applied proximal to the limb, and the cuff should not be very tight whenever you apply it. So the blood flow restriction can be training can be used as a passive modality. Suppose if the patient is bedridden, if he is unable to move, so the patient ultimately ends up with atrophy. In order to counteract the atrophy, you can use the blood flow restriction device in a passive mode in order to maintain the circulation and also to improve the muscle strength. So for people who are bedridden, the blood flow restriction training can be used along with neuromuscular electrical stimulation. For people who are active, it can be used during aerobic exercises and as well as resistance exercises. So blood flow restriction training, the physiological effects of the BFR are not only limited to a particular joint. It has got a proximal effect, it has got a distal effect, and it also has got a contralateral effect. So the maximum beneficial effects are more towards the distal side. But however, the proximal and the contralateral side also has got the same beneficial effect. So these are all the physiological mechanism how BFR works. It creates an hypoxia, where it creates a metabolic stress. There is a hormonal response. Because of the hormonal response, there is myokine production, and there are neurological adaptations which happen, and there is satellite cell proliferation and muscle repair. There are anabolic pathways which gets stimulated, and the muscle fibers, they get recruited. As a result, the muscle strength also improves. So these are the guidelines for BFR. So there are different protocols where BFR is usually used. So unlike DLUMS and Oxford protocols, you can use where the DLUMS and Oxford use, they use only a 10 repetition maximum. But whereas in BFR, you can use 30 repetitions in the first set, followed by 15, 15, and 15 in the subsequent sets. Can you go to the next slide, please? So the BFR program is very, very beneficial, and also it is also associated with some risks, and also there are few contraindications. These are the risks and as well as the contraindications. It is completely contraindicated in people with DVT. DVT assessment has to be done before applying the BFR training. So these are the risk assessment forms for BFR. So this is the risk assessment. This is the thrombosis risk assessment. If the score is more than 3, the patients are at moderate risk, where supervision is very, very essential if you are doing a BFR training program. It is completely contraindicated in case of high-risk individuals. So the BFR is also contraindicated in people with systolic blood pressure is more than 160 and diastolic blood pressure more than 100 millimeters of mercury. So this is a clinician's workflow before incorporating any BFR program. History and vitals are important. Thrombosis stratification has to be done. It has to be condition specific. You always have to monitor the BP and also modify the pressure regulations. So what is essential in BFR? The clinical judgment, the risk factors, experience comes into play, and the patient safety is at most important. Thank you.
Thank you very much, Dr. Shravan. You've completed in time. And however, now we have the gentleman who is going to close the Recovery 1 Conference 2026 with his last presentation. Can I please ask you all to put your hands together for Dr. Soumyakanta Sahu, co-founder director, Samagam Therapeutics. Over to you. Dr. Saurav, all set?
It's the second time, ma'am.
I don't have that in my list, so that's why. I'm really sorry. Can we all put our hands together for Dr. Saurav, please?
It's okay, ma'am. You are amazing today, actually.
Oh, thank you. Over to you.
So, from morning we are listening about functional outcome, functional approach. So, as a OT, this is my core concept actually. This is my bread and butter, functional outcomes. So, before going to that, we heard a lot actually. A lot of my presentation slides are also, people told it's okay. But before that, I want to tell how the functional outcome or the functional approach came into picture. Because previously it was perfect movement, but how it came to picture. So previously, when rehabilitation, if you see the orthopedic books, the rehabilitation was only about medical model dominance, like correction of the deformity, restoration of normal anatomy, elimination of abnormal movements, that's all. They are not focusing on functional. After that, what is happening? Nobody knows. So then comes one couple, Bobath couple, okay? They, maybe physio OT who are there, they will know. So they develop one neurodevelopmental therapy. Okay, neurodevelopmental therapy, वो क्या करता था? Abnormal pattern को बंद करके normal pattern develop कराना and quality develop karana. That was the focus. Then comes Brunstrom. Brunstrom क्या किए? He developed all the patterns functionally. Then comes our task-oriented approach, neuroplasticity approach. So this is how early 2000 time में task-oriented approach start हुआ. So this is how function came into picture. So now come to the introduction. So in rehabilitation, the ultimate aim is not to always restore the perfect movement, but to maximize the patient's ability to function independently and participate meaningfully in life. So what is perfect movement? Near normal biomechanics, symmetrical movement patterns, ideal muscle activation and coordination, restoration of normal motor control. What is the advantage of perfect movement? Better long-term biomechanics, reduce compensatory strain, improve movement efficacy. Limitation may not be achievable in severe neurological musculoskeletal conditions, require prolonged therapy, can delay independence if pursued exclusively. Then functional outcome. Functional outcome focuses on independent in daily living activity, safety and efficacy, quality of life. Example, independent in feeding using adaptive devices, walking safely with an orthosis, dressing independently despite of compensatory movements. So in OT, if the person is independent with compensatory movements, we allow that at some point of time. So principles of functional outcome is task-oriented training, compensatory strategies, environmental modification, and assistive technology. Advantages of functional outcome is faster independence, improve quality of life, increase motivation, reduce caregiver burden. Risk of functional outcome. So if you do functional outcome, there is risk also, like poor biomechanics. The patient, we are not bothered about biomechanics, so biomechanics will change. So patient may get future pains or aches like that. So learn non-use. Suppose a stroke patient with right hemiplegia, and we train the patient to the left because we know that right hand will not come, then or maybe because of the rehab protocols, like suppose along with training the left hand, we are working on right hand, so the patient will learn non-use. So abnormal movement reinforcement, suppose we are suppose for dressing, if the patient is lifting his hand up to 10-20 degree with the shoulder elevation, we allow that. That means we are abnormal movement reinforcement, we are doing abnormal movement reinforcement. Secondary musculoskeletal problem, as I said, if he continuously do like that, he or she might get aches and pains. So what should be our goal? Functional recovery with movement optimization. So we are not focusing solely on functional recovery, we have to work on perfect movement also. Functional recovery and movement quality are interconnected but not always dependent on each other. So not perfect movement alone or compensation alone. So we have to work together. So perfect movement also and compensation also. Assistive device or adaptive device. These two things are very actually similar, because anything you do functionally and something is helping you, that is assistive device. If you change something to do the function, that is adaptive device. It is a very core concept of OT. So assistive devices help bridge the gap between impairment and participation. So suppose the patient is not able to hold the spoon, so you have to give adaptive spoon. That is adaptive device which will help the person to eat or hold the spoon to eat. Same thing, if the person is not able to lift the hand and hold the glass, we can give mobile arm support. That's an assistive device. Mobile arm support will help the person to move the hand and hold the glass. So it can be orthosis or splint, mobility aids, adaptive devices, environmental modification, environmental control system, communication aid. So, sorry. What is device adoption? So it refers to acceptance and integration of assistive device into daily life to improve function and participation. True adoption means when the patient trusts the device, understands its purpose, use it consistently, experience the functional benefits of early adoption. So functional benefits by adopting a device early is improve independence, enhance safety, reduce caregiver burden, enables early participation, psychological benefit like improve confidence, encourage social integration and reduce frustration. Rehabilitation benefits support task-specific training, prevent secondary complication and conserve energy. Challenges in adoption of assistive devices. So patient and family resistance to visible aids, fear of stigma or dependency, cost and acceptability factors, hope for complete recovery, delay prescription and team disagreement. That happens a lot of time. Recovery and adaptation. Recovery and compensation can coexist. Continue restorative therapy alongside early adaptive strategy, reassess periodically, appropriate device adoption supports comprehensive recovery, B practice is recovery with functional adaptation. So always As a OT, our main goal is to recovery with functional adaptation. Early the movement, early the recovery time. So rehabilitation should prioritize participation, dignity and quality of life. So as a OT, we use dynamic system theory. What is dynamic system theory? There are three things in dynamic system theory: task, environment, person. So adaptation can happen to these three things. If a person is not suitable to the environment and task, we have to adapt the human factor. If the environment is not adapting to the human and task, then we have to modify the environment or adaptation of the environment. Same thing, if the task is not according to the environment and person, so we have to change or modify the task. So this is how the adaptation works in occupational therapy. Thank you.
Thank you very much, Dr. Saurabh Mandal, for the presentation. This time I've got it absolutely right. Can we hear it for all the panelists, all the speakers, please? Have been fantastic, waited till the end. After all the sessions, you were the really patient, not little patient, but had a lot of patience. Thank you very much, all three of you. And now I would like to call Dr. Vijay and Mr. Amit to present the vote of thanks, please. Thank you, sir. Thank you.
Good evening, everyone. I would like to take a moment to express our sincere gratitude to everyone who has supported and contributed to making Recovery One Conference 2026 possible. We are deeply grateful to all our esteemed speakers, moderators, clinicians, rehabilitation experts, hospital leaders, policymakers, and delegates who have traveled from across the country to be part of the first edition of Recovery One. Your presence and participation truly add meaning and strength to this initiative. I would also like to sincerely thank all our sponsors and partners for supporting Recovery One 2026 and standing with us in advancing the future of rehabilitation and recovery care in India. We gratefully acknowledge Platinum sponsor Gen Robotics Innovations Private Limited, Gold sponsor Spurs Mind Innovations, Silver sponsors Rimo Technologies Private Limited, Walnut Medical, Sedexis Advanced Materials Private Limited, Fiji, Jogo, Synergy Corp, Apollo Ayurved, Signutra, Venkateshwara, Art of Healing Cancer, and OncoFit. We also extend our appreciation to our accreditation partner, support associations, media partners, and all collaborating organizations for their valuable support towards this conference. Most importantly, I would like to thank the entire organizing team of Recovery One 2026, the HCAH team, volunteers, coordinators, and everyone working tirelessly behind the scenes whose dedication and commitment have made this conference possible. We truly hope that today's discussion and collaboration become the foundation for a stronger recovery and rehabilitation ecosystem in India. Thank you once again to everyone for being part of this important initiative. Thank you.
Thank you very much, gentlemen. And to everybody else, I, your host, Anchor Jyoti Sukumar, truly felt amazing during the entire day. The very first edition of this Recovery One conference will go a long way. And I promise to meet you again very, very soon. Until then, please have an amazing evening and please dream to do more, excel more, and I wish you all the very best. Thank you for having me and wishing you all a very great evening and a great year ahead. Thank you, everyone. Now, as formally we conclude this, we have something else as well. I request Dr. Gaurav to please join me on stage to announce the winners of the poster competition champion.
What a relief. है ना, बहुत सारे लोगों को इंक्लूडिंग प्रियम ये फीलिंग आ रही है अब. बट सम थिंग्स, कुछ चीज़ें और बची हैं, थोड़ी सी और, राइट. आई एम वेरी प्राउड टू से दैट द साइंटिफिक कमेटी, एंड आई थिंक स्पेशली आई वुड वांट टू कंग्रेचुलेट प्रतीक हियर. जब इतना सब कुछ चल रहा था, राइट, when so much was going on, he had the guts to even invite abstract papers. There was a time, yes, that was amazing. There was a time a few years back when I and Vijay were very happy to do, say, 4 publications in a year, and we used to think, यार और तो कोई करता ही नहीं है, हम तो top पे हैं. And then for the last 3 years, I think we started participating in various conferences where also Prateek led this effort, and he got कि पहले एक publication हुआ, फिर 2 हुए, फिर JERICON में 4 हुए, and today you'll be happy to know that the contributions from internal teams across our 7 hospitals and from outside also, we received 16 papers. Amazing job done, Dr. Prateek. And given my clinical intent to research, ये लोग भूल गए कि उसको जज भी करना है क्योंकि इतना सब कुछ चल रहा था. And then when I went out, तो he was figuring out where is Shoshato, how do I get it judged, and जैसे reached there, क्या कर रहे हो, right? And he said कि sir paper presentation है, उसका judgment करना है. And I said अच्छा मुझे दिखाओ. And then I became on my own, I declared myself a judge. And it was not an easy job. It was a very tough competition. And why it was a very tough competition? Because of the effort put by the team. It's not easy to pull up a research, to pull up a case study, to pull up something doing your routine jobs. It takes a lot of motivation. Hence, although I would say there is a lot of scope for people to learn, right? They could have been coached better by Shoshato, by Prateek, who were leading this initiative. But I actually appreciate the effort put in by a team to churn that data. And Ankit sir, you'll be very happy to know every poster paper presentation talked about fastest recovery. Your dream getting realized. मैं जब भी किसी पूछता था ना, इसमें स्पेशल क्या है इस केस में? सर फास्टेस्ट रिकवरी हमने 44 डेज में कर दिया. मैं कहा भाई बेंचमार्क कहाँ है? सर ये बेंचमार्क. So I think people have done, but yeah, I was forced to give a judgment on which is the best. अच्छा इन्होंने फिर एक ही रखा था. मैं कहा यार 3 तो रखो कम से कम. एक बेस्ट रख लो, फर्स्ट रख लो, फिर एक फर्स्ट रनर रख लो, एक सेकंड रख लो. And very happy again that this time a speech therapist, an occupational therapist also participated. This was not only limited to a DMO, CHMO, a therapy lead. They had come from the ground level. So kudos to Aparna, kudos to Saujanya, Divya, all these people who led this effort. So the winner is, how many people have seen these posters today? Raise your hands. Nishant, Kavya, इनके तो नाम भी नहीं जानता मैं, चलो अच्छी बात है. But who do you think should be the winner? Any guesses? Any guesses? Oh, no guesses. Okay, the first prize goes to this paper. Effect of gamified Bobo-based dynamic balance training as an adjunct to conventional physiotherapy in stroke, spinal cord injury, and cerebral disorders, a pre-post intervention study. And this is our own Saujanya. Come here. No, but I think why this has been judged as the best paper is, number one, where we were struggling, right? कि bobo balance तो use ही नहीं होता, right? So many people in this room would say, sir, we don't get that category of patients, right? She used that device on patients with stroke, with Parkinson's and ataxia, and with spinal disorders. So it was a good mix. She was able to show the improvements in terms of scores very, very scientifically. And she was able to show quantifiable improvement. And it was the perfect paper with no ambiguity, and hence you have got the first prize. Congratulations. The first runner-up, I don't know who's going to represent this, but honge kuch represent. The first runner-up is from sensory chaos to control, desensitization strategies, and sensory re-education in stroke. This is Chetna Bali from Gurgaon Center. She's first runner-up. And she's an occupational therapist. And this is how the good work shows. We have two fantastic occupational therapists in Gurgaon, right? And this girl is from Nirtar, right? Aparna was representing her, right? Fantastic job that this was a patient whose hand, now just imagine chronic patients, we say we are unable to, right? This was a patient, 2-year-old stroke, whose hand did not have sensation. And this girl worked for 6 weeks to get the sensation back and was again able to show, yes, Nishant, you can definitely take the credit. And this girl was able to, Kuldeep, you can also take credit. And this girl was able to get quantifiably how the sensations happen. It's not subjective, ki patient bol raha hai. It was quantifiable with scores. So that's why an occupational therapist applying, and see all this converts into numbers. And that's why now Gurgaon is clocking the highest number of OT sessions. So Aparna, who's our therapy lead at Gurgaon, she is now a PhD holder. A big round of applause for her. And she's the one who got 5 people to present from her team. And the second runner-up again is Gurgaon. And this is a speech therapist, Rita Sharma, and she has shown physiotherapy rehabilitation in a patient with CVA presenting with right hemiplegia and aphasia, a case study. What was so special about this case was that it was a very big, ischemic stroke, right? She showed that picture of the affected brain also. And the aphasia patient recovered from 0 speaking to verbal syllables in 6 weeks. And again, she was able to quantify it through the various scales, which I also can't speak because I'm not a speech therapist. But again, a very junior person, new in the system, making lives change, making somebody speak who could not speak, and presenting a scientific paper. That's why she's got the second runner-up. Congratulations to all the winners. Prateek, now the next responsibility is that all the 16 should either convert into RPs, Excel shores, or get published, right? That's your responsibility. Come, Jyoti.
Thank you very much, Dr. Gaurav. I request you to please stay here. I just love the way he not just announced the names, but he also customized and debriefed what and why they won. So give a round of applause to the gentleman standing next to me, please. And now we would like to present the mementos to the pillars who have made it possible. Can I please request Mr. Ankit also to join me on stage to present the awards, mementos along with Dr. Gaurav, the organizing team. Yes, I would definitely want you to speak on this, please.
No, I want to invite a very special guest today, Swati Goyal, who has made time for us to also be present on the stage to award these mementos. For people who don't know, Swati is Ankit's wife, the force behind Ankit.
Wow. Welcome to you, ma'am. And now as I invite the name, I request the teams to please join me. I request Dr. Prateek to please come forward. Finally coming out of the console area. Come on, you can cheer louder, everyone. And now let's call Dr. Priyam. Dr. Priyam, you can smile. Yes, this moment is for all of us. Let's celebrate together. Cheer louder, everyone. Come on. Now calling Dr. Mahaprasad. He's not here? Okay. Miss Kavya. Congratulations to you, Miss Kavya. So will you shout only when the boys are coming? Yeah. Now let's call Dr. Divya. Hear it for her louder. Woo! And now calling Miss Aishwarya. Warm welcome to you, ladies. Especially congratulating all the ladies and recognizing their efforts who don't generally wear sari for all day long. It is a tough job for us guys who are not used to wearing saris and carrying it throughout. And now Dr. Supraja, please join us. Congratulations and once again welcome on stage, ma'am. And now our poster champion, Dr. Saujanya. Woo-hoo! And now the next award is for Dr. Shashwato. I request Bhattacharya ji to please come on stage and receive this, please. And now we will be presenting the certificate to the participated people in the Recovery One conference. Vineet, please. Mr. Vineet, join us. Satyajit Chobe. I'm just calling the names quickly so that you have to run and come like a marathon towards the stage. Sohail. All of them who are joining us on stage are a part of the organizing committee as well. So hear it louder. Come on, everyone. Sabita. Next, Dr. Sai Shravan. Happy Mother's Day to a mom-to-be. Also Rakesh Verma. Prashant Reddy. Miss Kaveri Verma. Kirti Verma. You know what? I am also Verma, Jyoti Verma before I got married. So there's so many Vermas here. Kirti Verma. Jai Shri. Miss Isha Abdul Fazan Theba. Mr. Amit Kumar. Mr. Abdul Rahman. Mr. Ankit Goel. Mr. Ankit Goel. Sir, yourself. And Mr. Amrinder Malli. That's it. We've completed the certificates. I request now, finally, once again, Dr. Gaurav to please take over as he has a special message for all of us. Put your hands together one more time.
Can you remove this laptop? I don't know. Yeah, thank you. बैठ जाओ यार, अब सारा दिन खड़े रहोगे प्रियम तुम? पीठ दर्द हो जाएगी, कल काम भी करना है. Dr. Vijay, it's all done. Settle down. Come in the front. बंद कर दे भाई. हो गया tin check. So team, we have done it. 3 cheers for this team. Hip hip. Hip hip. Hip hip. Chashma pehanta hu. So this is now a very special thanks note in my own style for my team. So can I have Divya and Saujanya now sitting for some time in the conference? Just give that to me. Please sit. You can also sit. The work is done. So finally, we had 56 speakers in 12 hours of workshops yesterday and 12 hours today. और कल सुबह जब वर्कशॉप शुरू हुई थी तो विजय ने बोला था अब पता ही नहीं चलेगा, now everything is auto mode. और एक्चुअली नहीं पता चला, the energy was so high. -- 71 registrations for the workshop, अमित कुमार बैठ जाओ यार अब तो. 71 registrations in the workshop, 219 registrations in the conference. And this is the first time, first edition. हमने नहीं सोचा था इतने लोग आएंगे, seriously. Divya and Saujanya, where are you? Divya, Saujanya, where is she? Hearty thanks to both of you for managing it so seamlessly. Any conference, the biggest flaw is किसी का मोमेंटो किसी को चला गया, किसी की नेम प्लेट कहीं और लग गई, कोई और आ गया. You managed this flawlessly. Thanks from the bottom of my heart, because this is the experience which counts. And you people did not sit for a single moment when everybody else was sitting. Please sit down now. Where is Jyoti? Where did she go? She left. Well, she's left. I think we should give her a big hand of applause. She managed it very well. Again, it was flawless. Similarly, another person to be mentioned here is Yashi Srivastav. How many of you know Yashi Srivastav? Please stand, Yashi Srivastav. मीडिया में जो भी गया, अंकित ने जो भी बोला, अमित ने जो भी बोला, मैंने जो भी बोला, और पता नहीं और क्या क्या, everything was curated and created by her. Thank you, Yashi. यशी काम हमारे लिए करती है, लेकिन ऑन रोल वो हील हेल्थ के लिए एज मीडिया पार्टनर. थैंक यू यशी, यू मेड लाइफ सो मच इजी फॉर ऑल ऑफ अस. नाउ कमिंग टू ऑल द SPOCs. Raise your hands in this room. All the SPOCs. Divya, Preet, Vineet, Amit, कावेरी, तू भी तो था. कुलदीप, हाथ खड़ा कर ले. कुलदीप, ईशा कहाँ है? Where is Isha? She's left. Okay, Isha. Fantastic experience you people gave to your doctors. I think it was amazing opportunity for building relationships. Anyone and everyone who went to our Somajigoda hospital was awestruck. हमने इस कॉन्फ्रेंस से जो निकालना था, तुम्हारी बदौलत, the experience which you people have given, we have got it. Again, flawless. 6 doctors have messaged me. I have never had such a seamless experience, right? And I'll tell the names also, not now here. But 6 doctors have done. Maybe कल करेंगे कुछ लोग घर पहुंचने के बाद. But they said that the experience was seamless, flawless. Thanks to you, my team. I can entrust now you with any responsibilities. अरे जोर से ताली बजा लो. Well, there are some people who always. डॉक्टर प्रतीक दिखते नहीं है, किसको नहीं दिख रहे? क्या बात कर रहे हो? आई एम टॉकिंग अबाउट राहुल जैन एंड अमरिंदर सिंह मल्ली. जिस दिन ये मैंने पूछा कि पेमेंट कैसे आएगी स्पॉन्सर से, अमरिंदर वॉज देयर. जिसमें मैंने पूछा रजिस्ट्रेशन कैसे लेंगे, अमरिंदर वॉज देयर. जिसने निशांत को बोला कि भाई जल्दी से वेबसाइट बनाओ, अमरिंदर वॉज देयर. जिस दिन वर्चुअल रजिस्ट्रेशन का लिंक देना था, ओवरनाइट इट गॉट क्रिएटेड, अमरिंदर वॉज देयर. एंड इट्स नॉट द एंड. वो मेरी प्रेजेंटेशन देखी थी किसी ने? किसी ने देखी थी यहां पर मेरी प्रेजेंटेशन? अगेन अमरिंदर वॉज देयर. Thank you, Amrinder, for all your efforts and the ownership. आज LinkedIn किसने फॉलो किया? क्या फोन किसका है? ऐसा क्यों करते हो अमित कुमार तुम? तो क्या वो चल रही है? तो चलने दो, सबको सुनने दो. आज LinkedIn देखा किसी ने? Did anybody got time to see LinkedIn? We have created wildfire. I am getting so much of messages. And it's all because of Rahul's support and Rahul's team support, जो again मैं कह रहा हूँ ना, ये silent crusaders हैं, ये दिखते नहीं हैं. Kanika, I would like to mention here, Kanika जिसने बहुत मेहनत करी, सुबह 6 बजे से लेकर रात के 12 बजे तक, ऑल द क्रिएटिव्स यू सी हेयर आउटसाइड, जो इतना सब कुछ बना, दिस गर्ल single handedly with Ayushi, with Rahul's team, did everything. So thank you, Rahul. Again, yesterday, I don't know how many of you realized, but it was a very challenging thing कि इतने बड़े बड़े डॉक्टरों को बुला लिया. फ्लॉलेस भी होना चाहिए, एक्सपेक्टेशन लेवल भी इतने हाई हैं, ऊपर से हेल्थ मिनिस्टर भी आ रहा था, एंड देयर वाज अ टीम which was on the sidelines curating a workshop which has never happened before in the country in the way it happened. How you diagnose using an equipment, how do you work on upper limb, how do you work on the lower limb, how do you work on speech therapy. So congratulations Divya, Saujanya, Aparna, all the PMRs. Hearty congratulations for making this workshop the first of its kind, and I know many more are going to come. एक हमारे यहाँ एक प्राणी है हैदराबाद में, जिसके हम ये बोलते हैं कि भाई जो तू इतना बोलता है ना, उससे थोड़ा कम होता है. Who can guess it? Somebody had promised us, सर हॉल में खड़े होने की जगह नहीं होगी. हाँ, who is this person? हाँ, साई. तो साई देख, हम सब जानते हैं कि तू एक्टर है, राइट? हम सब जानते हैं कि तू सेल्स पर्सन है, राइट? तुझे बेचना आता है, बट टू योर टीम एंड टू यू, hearty congratulations. 71 paid registrations has never happened in the history of HCAH. Very good work done, the whole sales team. Very good work done. यार तालियों की गूंज नहीं आ रही है यार. अच्छा, किसी को अगर मुझे ये टाइटल देना हो कि वो लड़की का भाई था इस पूरी शादी में, तो ये टाइटल किसको मिलना चाहिए? क्या बात है. इसके घर में शादी थी, ये लड़की का वो भाई था जिसको हर बंदा जाके बोलता था भाई खराब हो गया है, भाई करना कैसे है, और ये भाई सांस नहीं ले पा रहा था. एक बार को तो मुझे लगा कि ये गिरविर ना जाएगा कहीं. वेल डन प्रियम. योर ओनरशिप was commendable. हाँ. 6 महीने, 3 महीने में. अब तो तुम ट्रेन हो गए यार, सारी टीम ट्रेन हो गई है. So when we were envisaging this conference, so we had to take the buy-in of Priyam also, Amit also, everyone. So we were sitting in the room. I and Vijay were quite sold कि this can happen on 10th of May. तो पहले तो हम 3rd में पे थे, तो वो तो अमित कुमार ने आउटराइटली ओवर रूल कर दिया, नहीं ये तो नहीं होगा. फिर हमने बड़ी मुश्किल से मनाया, और उसमें सबसे पहले चीज़ आई प्रियम की, सर थोड़ा जल्दी नहीं है ये, पर देख लो हो गया. सो वेल डन प्रियम. एक और टाइटल दिया मैंने आज. अगर वसूली एजेंट का टाइटल किसी को देना हो तो किसको देंगे? एब्सोल्युटली. कहाँ है भाई निशांत? फिर गायब. ओह आज है यहां पे. आगे आजा, पीछे क्यों बैठा है? बिग राउंड ऑफ अप्लॉज फॉर दिस बॉय. फर्स्ट टाइम कॉन्फ्रेंस, he got us 15 sponsors. हाँ थोड़ा चौड़ा हो जा, कोई बात नहीं. अच्छा 8 हो जा. ओके नाइस. थैंक्स प्रतीक फॉर रिमाइंडिंग मी. इन अ कॉन्फ्रेंस विच इज हैपनिंग फॉर द फर्स्ट टाइम, जहां पे पार्टनर्स को यह भी नहीं पता था कोई आएगा कि नहीं आएगा, राइट? ही गॉट 15 पार्टनर्स, और लास्ट में तो इतना चार्ज अप हो गया कि वर्चुअल पार्टनर बना दिया. आज तक किसी कॉन्फ्रेंस में से हुआ ही नहीं है कि लोग पैसे दे रहे हैं और कह रहे हैं हम नहीं आ रहे, हमें लाइव स्ट्रीमिंग में डाल देना. इसने वेबसाइट पे लोगो बेच दिए. बट वेल डन निशान, It was not an easy task. Very well done. मैं पढ़ रहा हूं, कोई रह तो नहीं गया? Okay. Now, the two pillars of this conference, which actually people have made my dream realized. This was my dream that we should do this conference. और सच्ची बताऊं तो कॉलेज टाइम से मेरी ड्रीम थी, जब मैं इतनी सारे कॉन्फ्रेंस कि कभी किसी ऑर्गेनाइजिंग चेयरमैन तो एक बार बनूंगा. फिर मैंने कॉलेज छोड़ दिया, फिर मैंने डॉक्टरी छोड़ दी, और आज तक ऑर्गेनाइजिंग चेयरमैन सिर्फ और सिर्फ एसोसिएशंस वाले लोग बनते हैं. राइट? दिस, एज पीपल सेड टुडे, दे वर नॉट स्पीकिंग फ्रॉम वन एसोसिएशन, वन फोरम, and we have created history today. And here I would like to acknowledge the role of Amit Kumar. वो शादी में एक मामा होता है ना, जो सिर्फ ये देख रहा होता है कि कौन सी चीज गलत जा सकती है कहां पे. ये गलत नहीं जाना चाहिए, मेरी भांजी की बेटी की शादी है यार, इज्जत जुड़ी है इसके साथ. ये रोल प्ले किया अमित कुमार ने. He was there welcoming every doctor, seeing Whole day watching this whole show. You have, I think, not missed a single presentation. Thanks to you, sir, for being part of this. So team, once again, hip hip, hip hip, hip hip. अब एक ग्रुप फोटो कैसे करेंगे सारी टीम के साथ? स्टेप बाय स्टेप कैसे? तो बुलाओ फिर लोगों को. आओ भाई, ग्रुप फोटो तो कर लो लास्ट बिफोर वी वाइंड अप फॉर द नेक्स्ट एडिशन. थैंक यू एवरीवन. Well done.